तो गूगल फॉर्म सेंड कर दिया। हेलो।
ठीक है कुलविंदर, मैं
आया
तुम्हें।
आया नहीं मेरे पास अभी ना। गूगल फॉर्म नहीं आया। मैंने एज अटेंडी
कौन
भी
सा?
मैंने एज अटेंडी भी ज्वाइन किया हुआ है, बट गूगल फॉर्म आया नहीं।
चेक करो कुलविंदर।
सर आपके पास आई ईमेल? आपको भी सेंड किया?
चेक कर रहा हूँ। हम्म। हाँ, ILD क्वेज करके आ गया मेरे को मेल।
एक तो मैंने भेजा था, वो तो नहीं आया।
नहीं, कुलविंदर की तरफ से आया। फिल आउट इन गूगल फॉर्म्स। ILD क्विज आ गया मेरे पास।
मेरे पास आया नहीं, एक बार अटेंडी लिस्ट में देखो। ये आईडी है कि नहीं? सहजल धूरिया 123@gmail.com।
सर होल्ड होल्ड होल्ड। एक सेकंड।
तरुण 9 बज गए, लाइव को कर देते हैं।
मैं कर रहा हूँ सर, एक
We'll
सेकंड।
have maybe a few minutes in between. चालू कर दो इसको, है ना?
बस
चालू
एक
तो कर दो फिर पेपर
जस्ट
जल्दी रहेगा।
1 मिनट सर।
सर है आपका ईमेल आईडी लिस्ट में?
सहजल धूरिया 123 एट
हाँ
जीमेल।
जी, हाँ जी।
पर मेरे पास आया नहीं, कुछ नहीं आया मेरे पास।
थोड़ा रिफ्रेश करके देखो।
रिफ्रेश कर लिया। चलो तरुण स्टार्ट कर दो, ये हम बैकग्राउंड में कर लेंगे, विल हैव
एक
सम।
मिनट एक
आप
मिनट
करते रहना, मैं 5 मिनट का इंट्रोडक्शन दूंगा, फिर डॉक्टर विजय अड्डा देंगे 10 मिनट का, सो यू हैव 15 मिनट्स।
ठीक
और
है सर।
बैकग्राउंड में कर लो, बट अब चालू कर देते हैं, 9 बज गए
ठीक
हैं।
है, ठीक है सर। वी गोइंग लाइव सर।
काउंट डाउन करें।
We are live. Just wait for, I think, just 2 minutes for participants to join.
कहाँ पे आ रहा है?
Tarun, can you hear me?
Yes, sir, I can.
Okay, so I'll start.
मेरे से शेयर करो. We have started, sir.
Yeah. So good morning, everybody. I'm Dr. Sjogren Dhuria. I'm an associate professor of pulmonary medicine at the Postgraduate Institute of Medical Education and Research at Chandigarh. We are holding this ILD course completely online under the aegis of the ICMR's network of pulmonary fibrosis. So this is a completely ICMR sponsored activity. We have formed a network of participating centers who are working to promote the knowledge and research on interstitial lung disease throughout the country. So this will be a 2-day session, and we'll try to cover most of the ILD subtypes and entities included in the ILDs throughout these 2 days. It is comprehensive in that regard, but what I want to mention here is that we will not be covering certain important issues in interstitial lung disease. For example, the pathology of ILDs, pulmonary rehabilitation, palliative care, and lung transplantation. We have purposely left it out because it is already an extensive program, and we wanted to just focus on the clinical aspect of all the various ILD entities. And we have made it very comprehensive so that you get some knowledge at least on all ILD subtypes, including the common subtypes like idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, sarcoidosis, and CTD-ILDs, and other rare ILDs, which are less talked about in most of the ILD courses. And our faculty are very distinguished national faculty, and they are mostly from the INPF network itself. But we also have 2 international faculty members who will be joining us from the United States at very odd hours according to their time zones. And we also have people from the rheumatology specialty who we have specially invited to enlighten us on mainly the CTD-ILDs aspect. So we will first start with the introduction to INPF. So this network was conceptualized by Dr. Vijay Hada, who is a faculty member at the All India Institute of Medical Sciences, New Delhi. And he made Herculean efforts to get this very big budgeted project underway. And he was very well supported by the ICMR, where Dr. R.S. Dhaliwal and Dr. Geetika are directly looking after this project. And it was also very well supported by successive directors of the ICMR. So over to Dr. Vijay Hada to give you an introduction of this network.
Thank you, Sajal, for kind words.
Thank you, sir.
Dear friends, good morning. So, as Sajal have already told that there is a network of this pulmonary fibrosis. Basically, this work on this project was started long back, somewhere in 2018, before COVID came in. So we were thinking that this ILD is one of the neglected disease. And most of the time, although there were few studies at that point of time, one was from Sjogren Dhuria and then other was from Situ Singh. There were 2 studies were already published. And still we feel that there was no good representation from different part of India if we talk about this ILD as such. So those study by Situ and Dr. Sajal, they were eye-opener for us that ILD is really a problem, and there were some insight from those studies. But there were few limitations which we felt that if we address those, then our knowledge will be more. Also, our objective was to identify various people who are keenly interested in managing these patients so that we can form a kind of collaboration and we can start working together so that we can identify some India-specific problems. So with that background, I met DG ICMR and I told him, Dr. Balram Bhargav was DG at that point of time, and I told him that, sir, we want to conduct a nationwide kind of project where we want to study that how the ILD is there in India, how big is the problem. Although there are 2 studies, so we want to see, are those studies representative, not representative? And also, can we do some kind of networking, and then later on we can plan some studies, maybe sub-study of the part of this network itself, or maybe once the people will come together, then they will come to know that who are the like-minded person or like-interested person, or they are having similar interest. So this was the objective. So after 2-3 years of extensive brainstorming with ICMR and multiple experts from different parts of India, finally we get an official approval for this project. And on paper, the start date of this project was 4th March 2022. Although I think the work started long before this date. So total duration of this project, we propose 5 years, but ICMR at present has approved for 3 years. And we are hoping that it will be further taken up for further studies if we propose good studies. So coming to this network little bit, I can maybe, let me see if I can show this. So this is a little bit regarding this, the network that I was talking about. And these were the various centers. If you see here, this is the map of India, and you can see this big light blue dot is the National Coordinating Center. And these kind of dots, they represent the regional centers, which are 3 centers.
Excuse me, sir. The map is not visible, sir. Maybe you can just list the centers, maybe.
Okay. So I was trying to show. So
Sir,
yes.
share the screen, sir. Share the screen and not the PPT. Just unshare it and then share your desktop one.
Okay, that may be. I got.
Yes, we can see it now.
You can see now.
Sir.
But unfortunately, I am unable to make it large. That is the only problem.
It's visible, sir. It's visible.
So if you can see this, so almost entire India is represented in this network. So this is kind of an achievement, and this achievement cannot be successful without participation of the PIs who are working on these centers. And they all have given me the unconditional kind of support. Whenever I ask any kind of support, they were more than happy to help me out. Many times there were few problems, and I am glad that everybody was on the same page, whatever problem it was. So this is regarding network. Till now, if we talk about activities, continuously we are enrolling patients with different ILDs. So this actually I am unable to show this, that I wanted to show the complete work till now, but yes, but I am unable to make it large. But otherwise I could show that in the network currently more than 5,000 patients has already been enrolled from different centers. There are few high volume centers, there are few low volume centers, but I am very happy that we are doing a great work and number is going to increase. Also, we have proposed few studies, and during our last meeting few days back, we decided that all the proposals regarding those studies will be submitted by 30th of December. And maybe the protocols or the performance which are required to fulfill for those studies will be submitted earlier. So I'm requesting everyone that they please submit those performance so that we can make necessary changes in the software or the data collection software. So this is my request. So other than this, I think this is all about INPF. So now at the end, I would like to thank Dr. Sajal for taking this initiative further, because as an objective of our project, we need to conduct these capacity building activities in the form of doing workshop at different centers. So first workshop was done at AIMS, and subsequently this Dr. Sajal is holding at PGI Chandigarh, and then there are 2 more workshops we will conduct. One is at SGPGI Lucknow, another is CMC Vellore. So our objective is to train as many as people we can under this project. So I wish all the best to Dr. Sajal for this event and for future endeavors. Thank you, everyone. Over to Sajal.
Thank you very much, sir. Do we have Dr. Geetika with us in the panelists?
Not yet.
Dr.
No, sir.
Dr. Geetika? Okay. So we have about 1,000, more than 1,000 registrations, and about 100 attendees have already joined. So I'm going to have a surprise quiz here, and we are going to send the Google Forms to all the participants. This will be held when we have enough participants on board. So first I will start my lecture, and then let us see how many participants join during that course, and then we can really hold the quiz for all. And whoever has joined, can you please put in the question and answers session whether you have received the Google form or not. Just type in whether you have received a Google form with just the question numbers, and I can also share the Google form link with you. Okay. If you have not received, you can always go to the link. Just click the link and get to the form. I've put it in the webinar chat, if you can see. In the question answer session, can you? Okay, not received. Yes, sir, received. No question in the forms. Yes. So it's a blank questionnaire. I'm going to show the questions and the multiple choice options live, but you are going to fill it in the form, right? And you can fill the answers only once. You have to attempt all the questions. And if you don't know, you just tick on don't know. Each question has a choice, don't know. You can submit the form only once. So just be sure when you are submitting it. And once I start the live quiz, the form submission window will end after a period of say 20-25 minutes. So after that, you'll not be able to submit. And I would request you to not prompt the answers or try to cheat for the students. So let me start with my lecture first, and then let us see how many participants we get more during the course of this, and then we can hold the quiz. You can just give me in the question answers whether you are open, whether you are able to open the Google link that I have sent you. Okay, you can't see it in the chat. Just a minute. I have sent it again. You just tell me in the question and answers whether you are able to open the Google form through that link. I'll keep on sending this link. Tarun, please keep on sending this link for the attendees who keep on joining fresh.
Sure.
So anybody who has got the link in the chat and has been able to open the form? Not seen, not received. Tarun, can you, Tarun?
Yes, sir.
Just a minute, maybe it does not come. Okay, now you'll be able to have the link. I have sent it again.
I'm just sending the QR code here. I'm uploading a QR code. They can just scan it and open the Google Form. So just give me.
Okay. So meanwhile, you can always join and open the questionnaire, and I'll start my presentation. My lecture is on approach to ILDs. And I'll try to keep it short just to give an introduction of what we are going to see ahead in the entire 2 days conference. Yes, so I'll start from here. So my lecture is about approach to interstitial lung disease and the burden of interstitial lung diseases in India. So I would like to cover the following issues. What are ILDs? What is the classification of interstitial lung diseases? The epidemiology and burden of ILDs in India, the clinical characteristics, and a stepwise approach to ILD diagnosis. So what are ILDs? ILDs are a heterogeneous group of disorders that are classified together because of similar clinical, radiologic, physiologic, and or pathologic manifestations. So clinical meaning the classical symptoms of ILDs, that is dry cough and dyspnea. Radiological in the sense that these entities all have diffuse lung abnormalities. Physiologic meaning that mostly they will have a restrictive ventilatory defect, but some of them might have an obstructive defect because airway involvement is one of the features of these diffuse parenchymal lung diseases. And then pathologic meaning there is interstitial inflammation or fibrosis or both. So why are there two terms, ILDs and DPLDs, and are they different? So ILDs is the term coined for these entities because they involve the pulmonary interstitium, but they also involve the alveolar spaces and small airways. So there was a change in the terminology and a better term, diffuse parenchymal lung disease, was proposed. So for example, organizing pneumonia and acute interstitial lung disease, acute interstitial pneumonia, both have airspace consolidation, and hypersensitivity pneumonitis and sarcoidosis might have inflammation around the small airways. So that's why this new term DPLDs or diffuse parenchymal lung diseases was coined. But currently, as of now, both the terms are used interchangeably. You don't have to make a differentiation that when you mean that the disease is involving only the interstitium, then you use the term ILD. And when it is involving the airways and alveolar space, then you will use DPLD. That is not the case. You can use the term interchangeably as of the understanding internationally. Yeah. So this is the current classification. So we had classification of ILDs in documents that date back to the year 2000, 2002, and 2013. We don't have a revised classification from the international societies like the American Thoracic Society or the European Respiratory Society, but we have this document on progressive pulmonary fibrosis, which gives us an idea of what kind of entities we have amongst the ILDs. So they can be classified into IIPs, which are idiopathic interstitial pneumonias. That is pneumonias which don't have any particular cause known, and they are characterized by inflammation and or fibrosis. Then autoimmune ILDs, the typical CTDs, connective tissue disorders, and other autoimmune disease like vasculitis, which do not come under classic CTDs. Then exposure related, which includes diseases which involve organic exposure, diseases that are due to inorganic exposures, diseases that are due to exposures to medications, radiation, illicit drugs, post-infectious. And then we have ILDs with cysts or airspace filling, for example, Langerhans cell histiocytosis, lymphoproliferative disorders, lymphangioliomyomatosis, or pulmonary alveolar proteinosis, and there are certain others. And then we have a standalone entity in the form of sarcoidosis, which is characterized by granulomatous inflammation of unknown origin. So the categorization of major IIPs, basically the common or major IIPs are now divided into chronic fibrosing interstitial pneumonia, smoking related interstitial pneumonia, and acute or subacute interstitial pneumonia. So amongst chronic fibrosing, you have IPF, idiopathic NSIP. For smoking related, you have respiratory bronchiolitis ILD, desquamative interstitial pneumonia. And amongst the acute subacute IPs, you have cryptogenic organizing pneumonia and acute interstitial pneumonia. And these are the associated radiologic or pathologic patterns which you might encounter, which we are going into detail in the rest of the course. So coming to the burden a little bit. So once we know all these entities are included amongst ILDs, so we performed a study at our center where we included about 2,000 patients, which just looked at the spectrum of ILDs. And then we had a study from Dr. Sheetu Singh's center. It was a multi-center kind of study, which involved 27 centers all around India. And so in this particular study, I tried to combine the data from the two studies and try to calculate or estimate the incidence, prevalence, and national burden of these diseases. So our spectrum at our center was that we had sarcoidosis as the most common interstitial lung disease. Then was connective tissue disease associated ILD. Then it was IPF, then HP, and then others. While from the ILD India registry study from Dr. Sheetu Singh Center, it was mainly HP which came out as the most common interstitial lung disease. So once we combine the data of the two studies, and then we made some projections. So we just took patients who were coming from our Tri-City area of Chandigarh, Panchkula, and Mohali, and we estimated the referral rate with which the patients might have come to our center. And then through these projections, we estimated the incidence prevalence of diseases in our Tri-City region. And then we projected it to calculate the total burden of these diseases in India. So we found that if you take all the ILDs that are included in this particular classification, the annual incidence is between 10 and 20 new ILD patients per lakh population every year, right? And the prevalence is about 50 to 100 new overall ILD patients amongst every 1 lakh population throughout the country. So the total burden in India amounts to about 6 lakhs. So we might have 6 lakhs ILD patients totally in the entire India. Then about sarcoidosis, you can look at the incidence and prevalence. I'll just enumerate the total burden. So sarcoidosis is about 1.7 lakhs. HP is again at the same kind of prevalence, which is 1.7 lakh patients. CTD-ILD is 1.1 lakh. I feel this might be an underestimation because several CTD-ILDs do not get picked up early, and several of them are not referred to pulmonologists. So this was a pulmonology center-based data collection from our center as well as from the ILD registry study. So this might be an underestimation. IPF about 60,000 and other ILDs about 65,000. So moving on to approach again, I try to rush things. The relevance of history taking in the ILDs basically. So you should consider the age group of the patient. So if the patient is between 20 and 40 years of age, what are the common ILDs that we'll see? Sarcoidosis, CTD-ILDs, hypersensitivity pneumonitis, familial ILDs, LIP, LAM, and LCH. In the 40 to 60 years age group, HP, CTD-ILDs, sarcoidosis, and RB-ILD, DIP, LIP. And more than 60 years age group, you have IPF, idiopathic NSIP, fibrotic HP. Sorry. So the gender or the sex of the patient also matters. So IPF, occupational lung diseases, PLCH, and RAILD. These are seen more commonly in men. CTD-ILDs otherwise, like except RAILD, sarcoidosis and lymphangiomyomatosis are more common in women. Onset of symptoms, so acute, subacute onset is seen with organizing pneumonia, acute eosinophilic pneumonia, certain CTD-ILDs, and sarcoidosis, and also acute interstitial pneumonia, which is a rare kind of disorder. While chronic or indolent course is seen with idiopathic pulmonary fibrosis, idiopathic NSIP, sarcoidosis, pneumoconiosis. And HP might have all kinds of presentations, acute, subacute, or chronic. So the thumb rules to diagnose ILDs are basically, step 1 is to identify ILD in the clinic, and I call it the 3-4-5 rule. 3 symptoms, which are prolonged cough, mostly dry, dyspnea, and fatigue. 4 classical signs are crackles and clubbing. And then there might be signs of pulmonary hypertension, especially in advanced ILDs, in the form of loud P2 or a right ventricular heave. Then hypoxemia at rest or on exertion is also an important sign of advanced ILDs, but these signs can also be encountered in other diseases. Then 5 initial investigations in any ILD include spirometry, chest radiograph, thin section chest CT, diffusion capacity of carbon monoxide or DLCO, and the 6-minute walk test. Then step 2 is that in any patient with an ILD, exclude CDEF. C meaning connect.
थोड़ा एथिक्स वाली बात है कि उन्होंने खुद भी मैं आरपी गवर्नमेंट के साथ ही पब्लिश करना चाह रहा था मतलब
Tarun,
मुझे
can
लगता है
you
कमेंट्री मिली
mute
है
all? Can you
नहीं,
mute the
मैं
panelist?
मैं कह रहा हूँ हम
Done, sir.
Yeah, so any patient with an ILD, we have to exclude certain disorders. Basically, if we want to call it idiopathic, but then we also have to identify whether any particular cause may be attributed to the interstitial lung disease. So you must exclude C for connective tissue disease, D for drugs, E for environmental exposures, and F for familial disease. For identifying CTDs, you can first focus on the history. So you know that joint pains, joint swelling, morning stiffness, deformities, Raynaud's phenomenon, skin thickening, puffy fingers, muscle weakness, all these can be seen in various ILDs. I have listed the various CTDs. I have listed the CTDs here. And this is just a glimpse of the CTD symptoms, and you must be knowing most of these symptoms. Then you have drugs, D for drugs. So always take a good history of drug exposure, especially chemotherapeutic agents, immunosuppressants, drugs like nitrofurantoin, amiodarone, and statins. And actually, any drug can really cause interstitial lung disease. Any drug, but certain drugs are more prone to cause, and some drugs will rarely cause interstitial lung disease. There's a very important resource, www.pneumotox.com, which can help you assess what patterns and what kind of ILDs are seen with various drugs. You can just type in the drug name in the resource and you can get a whole lot of ILD patterns that are associated. Then amongst the exposures, you might have smoking, occupational dusts, birds, farm and cattle dust, molds, and radiation as the predominant and more common exposures, but there are also other exposures which are very extensively listed in so many different publications. So several of these exposures might cause interstitial lung disease. So whenever you take a history of occupational environment exposures, go into the details of the patient's employment, lifelong employment, especially farmers, factory workers, stone quarry workers, have to be clearly questioned. Hobbies like bird keeping and pet keeping might be associated with interstitial lung disease. Then family history, whether any family member is having those occupations or hobbies. And then exposures to things like air conditioners, humidifiers, hot tubs, water damage to walls and carpets, damp walls, construction or demolition dust. All these history should be taken, but it should be ensured that most of these exposures will be through the exposure to mold. So just try to make sure whether there is any particular mold exposure. For example, everybody has an AC at their homes or an air cooler, but not everybody is prone to develop HP, because if your coolers and conditioners are clean, they don't have mold overgrowth, then you don't have the risk of developing hypersensitivity pneumonitis. And then a temporal relation of symptoms to exposure must also be looked for. A family history of disorders like IPF, sarcoidosis should be taken. Then certain autosomal dominant disorders are there associated with DPLDs, and certain autosomal recessive disorders are there which are associated with DPLDs. In the physical examination, look for crepes, look for mostly fine crepes, but coarser crackles might be there in advanced IPF, other IPs, sarcoidosis, and HP. Upper and anterior involvement occurs in sarcoidosis and HP. Both the diseases might have normal auscultation. V's might occur in diseases which involve the airways. And then squawks are typical of HP or bronchiolitis. Step 4 will be examination for identifying CTDs. So you must look at the hands of each patient. That is the most informative organ after the lung for searching for the cause of ILDs, especially CTDs. So you can look for cramps. Cramps meaning C for calcinosis, R for Raynaud phenomenon, A for arthritis and joint deformities, M for mechanic hands and Cotron papules, P for puffy fingers, and S for sclerodactyly and skin thickening. Also digital ulcers. The face might be puckered in systemic sclerosis ILD, heliotrope rash may occur in dermatomyositis, Miller rash may occur in SLE. And always make the patients stand from the squatting position in a busy OPD just to make sure whether he or she has any proximal muscle weakness. Step 5 is what investigations you should do in all patients. So chest radiographs, spirometry, HRCT scan are the important initial investigations. But then you also obtain autoantibodies to rule out any particular CTD that you might have missed. So we do ANA and RF as a routine. We also perform anti-CCP and ANCA as part of our research studies. But ANA, RF, I would recommend should be performed in all, at least to get a glimpse whether there can be a clue to any particular CTD. And then downstream investigations, for example, ANA immunoblot or ENA should be performed accordingly. Then pulse oximetry and 6-minute walk test should also be performed to look for gas exchange. And then the CBC, LFT, the renal function test, urine analysis, and electrocardiogram according to the needs, because most of these tests will be needed for planning treatment also. Then in selected patients, you can go for further antibodies for HP-specific antibodies for diffusion capacity, lung volumes as required, ABGs, and then other tests for specific etiologies. And if you suspect pulmonary hypertension, go for right heart catheterization and echocardiography. Imaging, CT chest is the most important investigation. It has to be high resolution. A volumetric acquisition is preferred. We are going to listen to Dr. Ashu say it on this. Expiratory scans to be obtained in all patients, and bronch scans only if there is basal disease. Interpretation, I'm not going to go into details, but I just want to tell you that a patterned approach should be followed, which Dr. Ashu will tell you more about. So I'll just skip this. I'll skip the UIP pattern part and we'll go to step 7, which is deciding on a lung biopsy or bronchoalveolar lavage. So surgical lung biopsy was previously considered the gold standard for confirmation of the diagnosis, but not any longer in some instances. So if you have a CT chest, which is consistent with definite usual interstitial pneumonia or UIP, you might not require a lung biopsy. If there's a clear-cut CTD and a related ILD, then again, you don't require a lung biopsy. If you have hypersensitivity pneumonitis with typical exposure history, you do not require a lung biopsy. But in other cases, you might opt for a lung biopsy, which might be performed using surgical lung biopsy, a transbronchial lung biopsy, or a cryobiopsy. And we will see in the individual entities where all these biopsy methods might be important and might be utilized. Step 8 would be multidisciplinary discussion. So a team of a pulmonologist, thoracic radiologist, and pulmonary pathologist should discuss all the clinical, radiologic, and pathologic data. And one can also include a rheumatologist. So this is becoming more and more regular practice to include a rheumatologist within the MDD, because they may offer very important insights which we might miss as pulmonologists or general physicians. Rheumatologists might pick up subtle signs, skin signs, joint signs, which we might be missing during a clinical examination. In patients with typical clinical and HRCT features of a particular DPLD, for example, typical IPF, typical sarcoid, typical HP, MDD might not be required, and the clinician, by his or her own knowledge and experience, can proceed with the diagnosis. So the take-home message from this particular lecture is that interstitial lung diseases are a heterogeneous group of disorders with common clinical, radiologic, physiologic, and pathologic manifestations. They are grouped as autoimmune-related, exposure-related, idiopathic interstitial pneumonias, cysts, and air space filling ILD, sarcoidosis. Sarcoidosis, CTD ILDs, HP, IPF, and non-IPF IIPs are the most common ILDs in India in that order. So thank you very much. I conclude my lecture with this, and I will again go to the chat panel so that I might just come to know whether people have required people have got the link and they are able to open the Google form associated with the quiz.
Now, can
Yeah.
someone please share the QR code for the quiz, please?
Yeah, so you can just scan this QR code and try to open the Google form, and we'll start with the live quiz then.
So
Just keep on telling me in the question and answer box whether you are finding any difficulty with opening the link to the Google form. Keep on typing in the question and answer box so that I come to know of any problems that you might be facing. I have also sent the link in the chat box. You can just copy it and paste it. I'll give you 2 or 3 minutes to just get active with the Google form, and please keep on prompting me in the question and answer box whether you are able to get the Google form or not. So the Google form just has question numbers and the A, B, C, D options without the text of the options. You just have the numbers and the A, B, C, D. So I'll give the questions live and you'll have to mark it on the Google form. Yeah, dear participants, we are here. We were just waiting for you to join the Google form. I'm going to hold a live quiz. You just click on the link that is being sent in the chat box repeatedly, and you can then open the Google form. It will not have any particular questions. It will just carry the question numbers, and you just have to fill in the choices in the Google form. The questions and the options I'm going to show live, and we are going to start in about 4 minutes. So please open your Google form. It can be opened in the mail itself if you are doing it on a laptop or a desktop. If you're doing it on a mobile, then you have to click the link so that you go to the Google Form site, and there you can fill the entire Google Form. So the initial information is about your identification, basically your demographic characteristics, whether you're a practitioner, whether you are practicing in a clinic, all these things that you can fill up. And then I'm going to show the questions, and then you're going to submit. And each particular question needs to be answered. If you don't want to answer the question, you just say don't know, which is always an option in all the questions. And you have to fill all the answers in order to be able to submit the form. Otherwise, you will not be able to submit the form. The form can be submitted only once. You cannot submit it again. And it can be submitted in a particular window. So when I'm going to hold the quiz, as soon as the quiz ends, the window of submission will close, right? So you will have to answer the questions as and when I show them, because anyways the questions are not written, so you will not be able to go back to the questions, right? And try not to prompt, try not to cheat. That is a given, especially for the students. And it's just a way for us to assess what is the current level of knowledge. And the quiz is quite tough, I would say. And it will be our endeavor that during the course of this particular conference over 2 days, at the end of it, you should be able to answer most of these questions. So we just want to test your knowledge currently, and then we'll give out the answers in the end, at the end of the 2 days sessions, so that you then come to know about what the answers to these questions were, right? So in about 2 minutes time, I'm going to start the quiz. Please keep on prompting me in the question answer box whether you are able to get to the Google form or not. So many people are saying that questionnaire not received. So basically, you might not receive it on mail. You just copy the link, which I am sending repeatedly in the chat box to everybody, and you just paste it in your internet browser and just click it. All right. So that way you can just go to the particular link. So you might find my name there. You can just change it, change the email. You can also change the options while the quiz is still going on. So I'm going to start in about a minute's time. Please prompt me on the question and answers box whether you are now ready. Those who are able to get to the form and are able to change the email address and are able to start answering the questions, please give me a thumbs up in the chat box, in the question and answers box. Okay, I'm finding a lot of readies. So it is 9:50, so I'm going to start the quiz. We'll run the session a little late, but we have a lot of buffer during the discussion time, which we can cut short for now. And during the second session, we can take up certain questions. If in the link any particular choice is marked, please ignore it. It may not be the correct choice. It was just done during the testing, so there might be some problem with that, but you can always change the choice. And before submission, you just go through the entire form, whether you are able to answer all the questions. If you don't know the answer, you just mark don't know. Every question has a don't know. And keep on prompting in the question and answers box if you are finding any particular difficulty marking the questions. So I'm going to share the quiz slide now. And keep on chatting with me in the question and answers box, okay? So can you see my slide? ILD quiz. Can you see
Yes,
my
sir.
slide? Yeah.
Yes, sir.
The audience also, please keep on prompting in the question and answer box whether you can see my slide or not. So I'll go through the quiz, the rules of the quiz again. So I'll give you multiple options, 4 options for each question, and the last option will be don't know. You just have to find a single correct answer. Select the most appropriate choice. If you have some difficulty, if you feel 2 options might be correct, then the most appropriate choice needs to be selected. And you have to submit the form immediately after completion of the form, because the submission window will close after the live quiz is over. Mark don't know, as I told you, if you do not want to attempt any question. If you leave any question unattended, you will not be able to submit the form. And the submission window will close 20 minutes. For attendees who are joining now, please click the link in the chat box to get to the Google form. So the first question is, please listen to the question carefully and you can see it on the screen. Which is true regarding pulmonary function or exercise testing in interstitial lung disease? So the first choice A, is presence of obstructive airflow pattern excludes the presence of significant interstitial lung disease. Choice B is a 5-point decline in the percentage predicted forced vital capacity suggests disease progression. Choice C, diffusion capacity for carbon monoxide may be normal in ILDs. And choice D is oxygen desaturation on a 6-minute walk test helps differentiate ILD from other disorders. That is, it is typical of ILDs only. So I'll wait for 10 seconds. You can go through the options and mark the choices. Question 2. Which imaging feature on the chest CT is consistent with usual interstitial pneumonia, a UIP pattern? Choice A is profuse traction bronchiectasis. B, profuse ground glass opacities. C, profuse micronodules. And D, profuse cysts. Which imaging feature on chest CT is consistent with UIP? Profuse traction bronchiectasis, profuse ground glass opacities, profuse micronodules, or D, profuse cysts. Question 3. A diagnosis of idiopathic pulmonary fibrosis, that is IPF, can usually be made despite the presence of exposure to or the presence of which of the following factor? A, connective tissue disease. B, significant exposure to smoke. C, significant exposure to birds. D, significant exposure to bleomycin. Question 3. A diagnosis of idiopathic pulmonary fibrosis, IPF, can usually be made despite the presence of or exposure to which of the following factor? A, connective tissue disease. B, significant exposure to smoke. C, significant exposure to birds. D, significant exposure to bleomycin. Question 4. Which drug combination is known to increase mortality in idiopathic pulmonary fibrosis, that is IPF? A, prednisolone plus azathioprine plus N-acetylcysteine. B, pirfenidone plus nintedanib. C, nintedanib plus sildenafil plus omeprazole. D. Low-dose prednisolone plus dextromethorphan plus pirfenidone. Question 5. Which is not a feature of non-specific interstitial pneumonia on lung biopsy examination? A. Temporal heterogeneity. B. Expansion of interalveolar septate. C. Moderate lymphocytic inflammation. D. Presence of collagen in the interstitium. Which is not a feature of NSIP? Question 6. In association with which connective tissue disease, organizing pneumonia or OP is a characteristic pattern encountered? A. Systemic sclerosis. B. Systemic lupus erythematosus. C. Sjogren syndrome. D. Dermatomyositis.
Sajal, can you go back to the previous question?
Sir, I'll repeat the entire set of questions at the end of the live quiz, and anybody who has missed one particular question can look at that question again. Question 7. Which of the following statements is correct with regards to smoking-related diffuse lung diseases? A. Respiratory bronchiolitis interstitial lung disease is characterized by the presence of numerous lung cysts. B. Desquamative interstitial pneumonia is characterized by squamous metaplasia followed by the shedding of the airway epithelium. C. Pulmonary Langerhans cell histiocytosis is not associated with smoking. D. Respiratory bronchiolitis pattern can be encountered on the lung biopsy of smokers even in the absence of significant interstitial lung disease. Question 8. Which of the following drug has not been found to reduce the lung function decline in systemic sclerosis interstitial lung disease? A. Tocilizumab. B. Mycophenolate mofetil. C. Nintedanib. D. Hydroxychloroquine. Question 9. Which of the following antibodies is an anti-amino acyl tRNA synthetase antibody found in the anti-synthetase syndrome? A. Anti-MDA5. B. Anti-endomysial. C. Anti-PL12. D. Anti-MI2 alpha. Question 10. Which of these is not a risk factor for interstitial lung disease amongst patients with rheumatoid arthritis? A. Female sex. B. Tobacco smoking. C. High titers of antibodies to cyclic citrullineated peptide. D. Other extra-articular manifestations. Which of these is not a risk factor? Question 11. Which of the following signs on chest CT does not typically suggest the presence of a connective tissue disease-related cause of the usual interstitial pneumonia pattern? A. Central lobular nodules. B. Exuberant honeycombing. C. Anterior upper lobe sign. D. Straight edge sign. Question 12. Which feature supports a diagnosis of interstitial pneumonia with autoimmune features? A. Presence of anti-GM-CSF antibodies. B. Presence of non-specific interstitial pneumonia on chest CT. Please note, presence of non-specific interstitial pneumonia, that is NSIP. C. Presence of usual interstitial pneumonia, that is UIP pattern on chest CT. D. Presence of anti-GBM antibodies. Which cystic lung disease is associated with a mutation in the folliculin gene? A. Follicular bronchiolitis. B. Lymphangiomyomatosis. C. Burt-Hogg-Dube syndrome. D. Tracheobronchial papillomatosis. Question 14. All the following laboratory investigations are suggested by international guidelines to screen for extrapulmonary manifestations of sarcoidosis, except A. Serum calcium. B. Serum protein electrophoresis. C. Serum alkaline phosphatase. D. Electrocardiogram. Question 15. Which of the following is true regarding the treatment of pulmonary sarcoidosis? A. Almost all patients require initial treatment with glucocorticoids. B. Methotrexate is contraindicated in lung sarcoidosis. C. Treatment can be initiated with 20 to 40 milligram per day of prednisolone in most patients requiring treatment. D. Golimumab is the biologic of choice for treating sarcoidosis. Question 16. Which radiologic feature is seen in typical hypersensitivity pneumonitis on chest CT? A. Perilymphatic nodules. B. Hyperattenuating mucus. C. Consolidation. D. Ground glass opacities. Question 17. Which drug is used in clinical practice for treating hypersensitivity pneumonitis? A. Mepolizumab. B. Montelukast. C. Medroxyprogesterone. D. Mycophenolate mofetil. Question 18. Which of the following drugs is most likely to lead to the formation of lung granulomas? A. Bleomycin. B. Etanercept. C. Azathioprine. D. Benralizumab. Question 19. Which statement is true about pulmonary alveolar proteinosis? A. The primary form is caused by inhalation of environmental protein antigens. B. Severe disease is treated with glucocorticoids as the primary modality. C. GM-CSF can be used to treat mild disease. D. Lung biopsy is mandatory for diagnosis. Question 20, which is the last question. Which of the following is true about silicosis? A. Simple silicosis is characterized by the presence of centrilobular nodules on chest imaging. B. Glucocorticoid treatment can result in complete resolution of lung opacities in simple silicosis. C. Progressive massive fibrosis occurs more commonly due to exposure to amorphous silica as compared to crystalline silica. And D. Antifibrotics have been found to reduce mortality in silicosis in a randomized controlled trial. So that was the last question. So if somebody has missed a particular part of a particular question, I'll just show you the questions for 5 seconds each, serial wise. So you can just pick up on the question that you missed and you can immediately mark the choice. After I end this repetition, you have to submit the form because the submission window will end. After that, you'll not be able to submit the form. And I will tell you one thing which I didn't mention previously, that there is an award. There are actually a few awards for those who score the best, but don't try to cheat. That will be my request to all, because it is basically an assessment of your knowledge, current knowledge. Question 1. Question 2. Question 3. Question 4. Question 5. Question 6. Question 7.
क्या नाम है उसका? सजल?
Yeah.
सजल, नेटवर्क स्लो होने की वजह से some
Okay,
slides didn't move.
I'll give some more time. Question 5.
Fourth one.
Okay, question 4.
Okay, fine.
Question 5. Question 6. Question 7. Question 8. Question 9. Question 10. Question 11. Question 12. Question 13. Question 14. Question 15.
Slide is again stuck at 13.
Question 13. Question 14. Question 15. Question 16. Question 17. Question 18. Question 19. Question 20. So you will have to submit the form now because the window, as I said, will close in just 1 or 2 minutes. So we have received 88 responses. All of you please submit. Yeah, so there were about 200 participants. We have received 95. Please submit. So another 2 minutes maybe for all of you to submit. And then we'll close the form submission window. Please submit. The questions are no more available to you. You just submit it. Don't try to cheat. The award is not a very big award. It will be just a small token kind of an award. So don't go for that. So about 100 responses have been received. I'm going to close the submission window in another 30 seconds. Please submit. Another 15 seconds to go before I close. Please submit. Okay, so I'll be closing the submission window. You'll not be able to submit your responses beyond this. Okay, so we now proceed with the conference, and I'm very sorry for getting late by about 15 minutes because I wanted to hold this quiz as a surprise only. So we now have a lecture, a very important lecture on the radiology of interstitial lung diseases. And we have a very distinguished faculty from the All India Institute of Medical Sciences, New Delhi, Dr. Ashu Seth, who has been a pulmonary radiologist for umpteen years. I have been there at AIIMS as an MD resident and as an MBBS student. And I have interacted with her, and I found her very well versed with all kinds of radiology, especially pulmonary radiology, and she has a special interest in radiology of interstitial lung diseases. So I invite ma'am to deliver her lecture on the radiology of interstitial lung diseases. We'll keep on projecting the curriculum vitae of all the faculty members at the time that I'm introducing them. Ma'am, you can start.
Thanks, Sajal. Just give me a moment to share my screen and then let me know if I'm all good.
Yes, ma'am. Yes, ma'am. Sure. I can see the slides, ma'am.
Yeah.
I can also hear you.
Okay.
I can hear you. I can see the slides. Slides are moving.
Thank you. So we'll need to go a little fast because we hope to cover everything that the major patterns of ILD entail. I'm going to skip the initial part of basics of ILD and etiology because Sajal has very nicely covered it in his introduction part, and we will go on to straight the radiology. So which means that amongst this stepwise approach that he spoke of later, I'm a radiologist, so my steps begin with radiology first. And I cover step 1 and step 2 for you today, which means it says step 1 being exclude mimics, and step 2 being that how to go upon the interpretation, essentially based on the dominant pattern. And subsequent to that, it says that you correlate it with history, lab, compared with previous imaging, etc. Now, why do you talk about mimics? Let's say that why do I need to say that exclude mimics? For instance, let's look at this image, the second one below. Do you think this is an ILD? So we have something which looks like, what would go into a reticular pattern, which means like white lines which are running through this CT. And is this an ILD? It's obviously not an ILD because I put it into mimics. And I will tell you what it is. This is a patient of pulmonary edema. So this is not interstitial lung disease. This is venous congestion due to pulmonary edema, which is a common mimic of ILD. Then the above patient, which also looks like having a diffuse ground glass with some septal thickening, is also not an ILD because this is COVID pneumonia in week 2. So there can be the major mimics that you need to exclude are infections, post-infective sequelae, pulmonary venous hypertension such as pulmonary edema, and numerous other vascular causes. Similarly, 2 more instances which are not ILDs. This is again diffuse ground glass with some septal thickening. And what is this? This was a patient of recurrent diffuse alveolar hemorrhage. multiple cysts here, which looks like cystic lung disease on a background of ground glass. And this is a post-TB sequelae. So having seen that it's important to rule out the mimics, particularly infections and post-infective sequelae, and if somebody has come to you with acute symptoms, the numerous causes such as DH, pulmonary edema, we now move on to our main job, which is the pattern-wise assessment of ILD. Overall, before we get on to pattern, we do look at the lung volumes and the overall distribution of the disease, which also Sjogren spoke about in the morning, that does it have an apicobasal gradient? It's more above upper lobes, more in the lower lobes, and more in the central part of the lung or peripheral part of the lung. Essentially, radiology always talks in terms of patterns when it comes to ILD, and there are 4 major patterns which are discussed: the linear pattern, nodular pattern, increased lung opacity means ground glass opacities and consolidation, and decreased, amongst which cystic lung disease is what is significant because the other major cause is emphysema. And then we look at all additional findings such as mediastinal nodes, pleura, and calcification, which may help us. We always look at the main pulmonary artery and the cardiac chambers to see, even on a non-contrast HRCT, to see that how much of PAH we already have, and in an acute setting also to see that there may be a cardiac cause which is responsible for the mimic. Now we get on to our major patterns, and any teaching of ILD prior to understanding the major patterns start with the understanding of the secondary pulmonary lobule. And why do we always return to the secondary pulmonary lobule? Because the distribution of the disease that we see is going to follow this. The secondary pulmonary lobule, which is the basic structure on which the ILD assessment is based, basically is a polygonal structure. So the walls of this polygon contain lymphatics and veins. So everything which affects the lymphatics and veins, like we saw pulmonary edema, that's why we got this polygonal kind of appearance in pulmonary edema, because the veins here got distended. So it gave us the polygonal appearance. In the center runs the pulmonary artery in the bronchus. So anything which predominantly involves the airway will fall into a different distribution. It will come into the centrilobular distribution, means it will come into the center of this lobule and not. That's the basic premise on understanding the distribution based on secondary pulmonary lobule. Linear and reticular opacities, we already saw examples, things which look like white lines, basically, which are either straight or zigzag or wavy. Some of these are, mostly a sequelae of atelectasis or infections, and really don't help us in terms of ILD interpretation. So the 2 main patterns which get talked about in ILD interpretation are interlobular and intralobular septal thickening. We'll go on to see both of these to understand. Now, again, we are back to the pulmonary edema patient, and this is a normal case. Now, if you look at the normal also, you may think that I can see a polygon here also, polygon along the surface of the pleura. So, looking at a few walls of the interlobular septum, especially in the anterior part of the lung, are normal. Only when there are thickened and they are numerous that we call this abnormal. So some polygonal structures can be seen normally also in the anterior lung. After that, we need to further characterize it and see that is it very smooth like it is in the pulmonary edema, or it is irregular, as we will see in the cases of fibrosis, or it is nodular, which also we will see subsequently. Now we come to the whole purpose of discussing this story, which is the fibrotic ILDs. There is a definition for fibrotic ILD on radiology also. So essentially now the first step that we do when looking at ILD is to try and identify whether fibrosis is already present or not. So the criteria for these being presence of architectural distortion, traction bronchiectasis or bronchiectasis, or honeycombing, or both. So you see, you have some reticular opacities, but in addition, you have something which has caused architectural distortion, volume loss, traction bronchiectasis, honeycombing. We know that this is fibrotic ILD. The second term is, which the terminology needs clarification before we get on, is the term PF-ILD or PPF as it's called now, which is that is it progressive or not. So we will see that what this term means. progressive ILD already, has been explained in terms of deterioration in the PFTs. In case of HRCT, it will be that any new area is involved or a previous area which was involved has developed fibrosis or fibrosis which has present has worsened. Any of those three happen are enough to label it as a progressive pulmonary fibrosis. There are so many causes of fibrotic ILDs. And, the 2022 now amendment which has come for IPF has enlisted out and already discussed with you in the morning. So let's get on and see some prototypes. So 68 classical history, 68-year-old male, smoker, symptoms of progressive dyspnea, pandistal clubbing and restriction, Velcro creps. What is striking? Now, this one is not a chest radiograph. It's what we call the scout image or the topogram that we take before we start the CT. What is striking, if you were to interpret it like a chest radiograph, what would one say about the overall lung volumes? The overall lung volumes are definitely diminished. Would we call the lung architecture normal in these mid and lower zones? No, there is some opacity and the lung architecture looks distorted. Can you find the diaphragm and the heart outlines at all? No, there is a blurring. You can't make out the outline of the diaphragm at all, and neither of the lower heart border. And also what you see are numerous small black-looking holes, which are these cystic lucencies, which are predominantly present in the mid and lower zone. So even before we go on to our axial imaging, we have our answer on what this could be. This is the axial, to remember that if you look at, older literature on what is HRCT, that we take thin sections, which are 1 mm or less, we take them at a gap, and we have a high resolution reconstruction algorithm. So that is how HRCT used to be acquired. Currently, what is to be remembered is that CT is an interpretation of a volume and not of sections. So we acquired a volumetric CT, and then we only do HRCT as a subsequent reconstruction. We do not acquire HRCTs anymore. So the only decision that you need to take before is that do you need a contrast enhanced or non-contrast? So HRCT by definition is a non-contrast scan, but we would do a contrast enhanced scan, for instance, in this case, if you are looking for secondary infections or, you suspect that a malignancy has developed, any reason to give contrast. Otherwise, by default, it's a non-contrast examination. Now, this is a CT of the patient which confirms what is called the apicobasal gradient, that the lower lobes are involved more. You see these linear black lines, which are irregular. This is the traction bronchiectasis. And in addition, there are cystic lucencies in the periphery, which represent the honeycombing. I will come to this concept also subsequently. So numerous cystic lucencies, which are like, subpleural and stacked on each other, but going right medially also, because here also this is diaphragm. Remember, we have a pleural surface. So this has classical honeycombing plus traction bronchiectasis. So the keywords here are subpleural, reticular, honeycombing, absence of alternative diagnosis. So our pattern is usual interstitial pneumonia. It has a apicobasal distribution, which we already discussed. Now, this is from the 2022 update, but broadly, the major classes of the division of categories have not changed since 2018. It's just that the predicting probability has gone up. So these are the key features that we already saw in our index case, which places us at the pattern called usual interstitial pneumonia or UIP. The word definite used to be used earlier, which is not used. In absence of honeycombing, we call it probable. And when we come to indeterminate, almost any form of variant fibrosis, will come under this pattern. What is important to see is that when do you say that this is not a UIP, which means alternative diagnosis? If an ILD dominantly has cysts, ground glass, nodules, then you are not dealing with UIP. So similarly, if it's predominantly has a distribution which is not peripheral. So what is the opposite of peripheral? What used to be called axial or peribronchovascular. and which is not lower lobe dominant, which means it is upper or mid lobe dominant. So these 5-6 things at least say that you are not dealing with the UIP. Almost every other form of fibrosis can fit into at least an indeterminate for UIP pattern. Now, after this is the UIP pattern. It is not equivalent to IPF. UIP is a radiohistological pattern, and in an appropriate clinical setting, it becomes, the clinical syndrome becomes idiopathic pulmonary fibrosis. Now, we used to do a lot of reconstructions, to try and differentiate traction bronchiectasis from this multi-layered honeycombing. This is the one modification which has come in the 2022 modification, that it says, which we have recognized for a long time, that it's very difficult sometimes to make out that where does the dilated bronchus end and where does the honeycombing start. So it says that there is no need to do the same, that honeycombing would actually be a combination of parenchymal lesions as well as the dilated bronchi which have cystic bulbous end. So the need to differentiate traction bronchiectasis from honeycombing has been removed in the latest modification, because it felt that eventually both airway and lung may be contributing to this opacity. Now, based on what we have already seen, again, we have something which has a similar distribution, has something which is looking very cystic. But what is very striking about this, one, that this is a young patient. She's a 32-year-old female. Besides, the size of the honeycombing is very large. It's almost looking like emphysematous lesions. They are very large and they are layered. So what is the terminology which is used for this? It's still called a UIP pattern, but the honeycombing is referred to as exuberant honeycombing. It has a sharp edge. This is the apical segment of the lower lobe. It has a sharp edge, which is called the straight edge sign. So all these are suggestive of a non-IPF UIP, which means a UIP which is because of connective tissue disorders. This index case also is showing us the Monod sign because of presence of aspergillomas. So remember, these honeycombing cysts are prone to a lot of complications in younger patients, mostly aspergillomas, and eventually carcinoma lung in IPF develops in these honeycombing cysts. So this is a CTD-ILD, and the classical signs are these: exuberant honeycombing, straight edge sign, and what is called four-corner sign, which means that it is distributed anteriorly in apical segment as well as in the lower lobes. Now we move to pattern 2 of fibrosing ILD. If you will look, it's the same patient, left and right, but at different time points. This looks very obviously like what we have come to recognize as a fibrotic pattern. But does it have a UIP distribution? It has a lower lobe dominance, although mid zones are equally involved. It doesn't have a clearly subpleural. Subpleural is involved. But when we look at it in its earlier phase, there is a black line which is coming just beneath the pleura, a clear black line which we did not see in IPF. And on top of it, what is the dominant pattern? Then we see it in the first scan. The dominant pattern here is ground glass, which means that the lung is white. It is white, but we can still see the bronchi through it. It is not so white that it has eliminated the details of the bronchi and the vessels. So apico-basal gradient, but ground glass dominance with subpleural sparing is referred to, is reflective of an NSIP. When you see a dominant ground glass pattern, it's a cellular NSIP. And eventually, when we know the now familiar signs of fibrosis, it develops those. It is a fibrotic NSIP, a commonest pattern associated with CTD-ILD. But when it goes into a fibrotic phase, you see that this subpleural sparing is difficult to make out. You will not be able to make out the subpleural sparing once it's in the fibrotic NSIP phase. And the other thing is that very often the two phases coexist. So reinforcing the keywords fibrotic NSIP, reticular, but in a combination with ground glass. In a ground glass phase, subpleural sparing, and eventually this also goes on to develop honeycombing. So to the key features: homogeneity, heterogeneity, reticulation, honeycombing. Predominant finding is ground glass, which changes when it becomes fibrotic, and subpleural predominance. The pleura usually also looks thickened, and this is subpleurally spared. we have seen the two major entities of two major patterns entity-wise. We have seen CTD-ILD also. Now we come to the third major entity. Again, if we were to say dominant, is the reticulation, traction bronchiectasis and honeycombing dominant, or is that my white milky kind of appearance dominant? So here definitely the white milky kind of appearance is dominant. In terms of distribution, almost the entire lung is involved, although it looks here also that the lower lobes are involved more. But if you look at it, the extreme CP angles and the extreme apices are not that much involved. And what do we have in the middle of those white areas? We have in the middle some areas which are darker. And so what is this known as? This is known as the 3-density pattern. So what used to be called the Hedge sign, we'll come to all this terminology. We already did what is ground glass opacity. Ground glass opacity in combination with some black area is called as mosaic attenuation. So mosaic attenuation can be because the black area is abnormal, this black area is abnormal, or the white area is abnormal. Black is abnormal if there's too much air, which means air trapping. White is abnormal if there's too much blood, or black has less blood because of, oligemia. How do we differentiate? So we differentiate by doing an expiratory scan. And if the black area becomes predominant in that, it's called air trapping. The normal lung and the rest of the lung will all become more white as more blood gets concentrated in a lesser area. But terminology wise, so you use the word mosaic attenuation. When you have an inspiratory scan, you're essentially not allowed to use the word air trapping unless it's a paired inspiratory expiratory scan. Most guidelines recommend doing a paired scan, but due to radiation concerns, we also don't do a paired scan routinely. But when you see a pattern like this, if you have a radiologist on table, or you can get the patient back and perform an expiratory scan. So remember, the term air trapping can only be used once you have performed an expiratory scan. And why is it known as 3-density pattern or triple? Because we saw 2 densities, white, 2 black, and in between density is normal lung. So normal, 2 black, 2 white is a combination of 3 densities, which forms the 3-density sign. And this is classical for a fibrotic HP. And why is it classical for a fibrotic HP? Is because HP has to show on CT a combination of lung changes and a combination of airway changes. There has to be lung fibrosis in combination with airway changes. Remember, neither UIP nor NSIP did we talk about the airway. But when we come to HP, we are talking about the small airway. And all this mosaic attenuation, sometimes ill-defined nodules, are reflective of airway disease. So a combination of lung disease plus an airway disease suggests that you are dealing with hypersensitivity pneumonitis. So this is one of our patients, 2012. You see, initially it just looks like ground glass. You can't see the triple density, but you can see some areas which are definitely blacker. Avian antigen positive, changed her residence so many times. And over a period of time, now it has given rise to the classical 3-density sign, because patient has been having progression. Will this be labeled as PPF? Yes, it will be labeled as PPF, because even initially the entire lung was involved, but the signs of fibrosis have increased. So this is a PPF. So this is a fibrotic HP. And on the second scan, we would say progressive fibrosing ILD. Which guideline to use, which will be, spoken about again and again, I'm sure, but it basically depends on your patient profile. So to summarize the pattern 1, which was of reticulation, we see that whether we have traction bronchiectasis, honeycombing, and if it will fit into UIP or not, which may be IPF or CTD-ILD. If this goes out and we still have fibrosis, we look that is it still a UIP, is it NSIP or HP? These are the main patterns we are looking for. And suppose we have some reticulation like we saw in the pulmonary edema, but we have no traction bronchiectasis, no bronchiectasis, no honeycombing, then we are dealing with, something else like edema, lymphangitis, carcinomatosis, and other lymphatic disorders, which we will be seeing. Basically, venous and lymphatic disorders. We come to the ground glass pattern for sake of completion, although we have mostly covered the ground glass pattern. because we have spoken about what is ground glass, that it is not obscuring the underlying airway and blood vessels, unlike consolidation. We have spoken about what is mosaic attenuation and what is air trapping. Now we come to the role of ground glass opacity in predicting reversibility, which means that ground glass is taken as a marker to say that at this time point, if you use immune suppression, you are likely to induce reversal. But, once the fibrosis has set in, what looks like a ground glass may not be reversible. So, for instance, if you look at the image above, it shows ground glass with some mosaic attenuation without traction bronchiectasis and fibrotic lesions. So this is potentially reversible. This ground glass type appearance is simply as a result of, some partial volume averaging. And even if there are ground glass opacities, there is so much architectural distortion and traction bronchiectasis in this that this is not reversible. At least a major component of this is not reversible now. So to summarize the approach to ground glass, we see that is it diffuse or is it heterogeneous? In diffuse comes the whole group of mosaic attenuation, mosaic perfusion, in which besides infections, viral infections, bronchiolitis, means all small airway disorders of various causes, our main prototype is hypersensitivity pneumonitis. And then if we have a diffusely increased, then we spoke about if it's subpleural, it's NSIP. And if we get a crazy paving pattern, it can be PAP. So we have discussed the major entities, which we run through briefly again. This one is, we know by the keywords and distribution now NSIP pattern. To revise, this one is HP pattern. One ground glass pattern, which we have not covered as yet, which has some key distributions. So the keywords here are that the distribution can be peripheral as well as bronchocentric. Sometimes it can be band-like. It can show areas of central clearing, which is called the reverse halo sign or atoll sign, famous because of mucormycosis, but also seen in this ILD and also seen in pulmonary infarcts. And it has another pattern which looks a lot like atypical viral pneumonia, which is called the perilobular pattern. All of these point to the entity known as organizing pneumonia. So just like all the other patterns we have seen before, this is only a pattern and doesn't point to an etiology. And the commonest etiology in case of organizing pneumonia is autoimmunity or infections. So to summarize, the geo-dominant patterns are NSIP, and we saw all of these prototypes, HP and organizing pneumonia. Several times NSIP and OP will exist together because in both it's autoimmunity that rules, in which case we refer to as NSIP OP overlap. All other causes of ground glass basically are acute. We are not in context of ILD when we discuss critical care imaging, etc., which means they are either pulmonary edema, DAH, infections. But in a subacute and a chronic setting, these are our major entities. This is a patient, as you can make out, of UIP pattern classical. And patient over the years, which is marked 18, 20, 21. And in the last admission that the patient has with us in 21, we lost the patient after 2 days of the CT scan. You may think that between 18 and 21, like what was so dramatic that we lost the patient, it looks like between 18 and 20, definitely there is progression. Earlier, there was only reticulation. Now there's over-traction bronchiectasis, there's honeycombing. But if you look between 20 and 21, you may think that, the fibrosis looks broadly similar. Why did we lose the patient? Because you have to look at this intervening area, which was relatively uninvolved at that time and looks black. That one has definitely become more dense. It's whiter. And if you look at these areas of honeycombing, these walls have become thick. So the patient had probably an infection here, and this diffuse ground glass is suggestive of an acute X or acute exacerbation. Acute exacerbation can occur in a diffuse manner, it can occur in a peripheral manner, multifocal manner, but any ground glass on top of an IPF requires the differentiation of infection versus an acute X. And as you know, you will need a high level of immune suppression for the acute X. So excluding the infection becomes very critical. So this patient is not intubated at this stage, but went on to be intubated subsequently. We come to pattern 3, which is the nodular pattern. So we are not discussing SPN today. We are not talking of a pulmonary nodule. We are only talking of nodular pattern, which means that when we have multiple nodules which are scattered in both the lung fields, in which case the distribution besides the density becomes the key point. Sajal, you were saying something? No. Okay. So in the distribution, we again come back to our secondary pulmonary lobule. You are familiar that the vein here has been made red because we are in the pulmonary circulation. The artery is blue and the lymphatics are all yellow and the bronchus is green. So everything that is lymphatic will give a perilymphatic distribution. Everything which comes in through the bronchus or artery will give a centrilobular, and anything that gets scattered all around through the pulmonary arteries gives a random distribution. Now, the basic teaching is that the first step in this is nodules on the pleural surface. If we have nodules along the pleural surface, remember this is the major fissure. Fissure is also a pleural surface. If you have nodules here, there is one pattern you know that you are not dealing with, which cannot be on the pleural surface, which is the centrilobular pattern, which means when you have airway disorders or centrilobular distribution, this surfaces should be clean. And if they are not clean, it's any of the two patterns. So what would you say about this pattern? The subpleural area is clean. Subpleural area is clean. So this pattern is centrilobular. And is it centrilobular like in a tuberculosis pattern? No, this is diffusely scattered. When we have diffusely scattered pattern, we are either dealing with respiratory bronchiolitis, we are dealing with non-fibrotic hypersensitivity pneumonitis, or in endemic areas, we are dealing with tropical pulmonary eosinophilia. This was a patient of non-fibrotic hypersensitivity pneumonitis. If we look at this pattern, on the other hand, central distribution also distributed along the fissure has a nodularity. You can see the thickened secondary pulmonary nodule again with the classical symmetric nodes. So we are dealing with a perilymphatic pattern and sarcoidosis. This is zoomed out to show you the classical pattern in perilymphatic distribution going along the fissures, So this is a classical book picture of sarcoidosis. Some other signs which have been described over time in sarcoidosis, and subsequently, you occasionally see them in TB also, which means central dense area, peripheral nodules. This is sarcoidosis. TB still looks same, but it has a big area of cavitation inside it. So without cavitation, this is the galaxy sign taken classical for sarcoidosis. Similarly, if you have it without the central sun and lots of nodules, it's referred to as the cluster sign, which is also a classical sign for sarcoidosis. Now here you have large mass-like lesions with peripheral emphysema, a lot of architectural distortion, nodules which can be in any distribution. They are perilymphatic also, random also, centrilobular, but very high density. So these can be seen in, these are suggestive of exposure-related ILD or pneumoconiosis. This patient, centrilobular nodules, 15-year-old male. So this will be non-fibrotic HP. Now, this is to explain the difference between the centrilobular pattern we saw and tuberculosis. This is a tree in bud pattern, and this is miliary nodules in the background. If you see the centrilobular nodules in this are very coarse and crude compared to the ones in the background, or compare this to the non-fibrotic HP. This is the tree in bud. It's in distribution of a particular bronchus. It's not diffusely distributed, and the size of the nodules is very large. So this suggests infection, while this suggests the other three differentials which I told you, RB, ILD, HP, or TPE. So to again summarize the nodular distribution, we look for pleural and fissural surface involvement. Perilymphatic takes us towards sarcoidosis and pneumoconiosis. Random takes us still towards infective and metastasis. And when it's centrilobular without a tree in bud, we are looking at hypersensitivity pneumonitis, RB. It doesn't say TPE because that is a peculiar problem to endemic areas. But if you get a coarse tree in bud nodules, then the first possibility is infections. Sajal, are we left with time to do cystic ILD? I think we have run out of time, no? Should I go ahead?
Ma'am, you can take it up briefly, ma'am, because
Okay. So say
time.
for 3-4 minutes of cystic ILD to cover
Yes.
the key concepts. So
Yes,
first is, what is a lung cyst? So lung cyst is, something which is totally black. This is also black, but this has no vessels, no bronchus. It has a thin epithelial lining. So it has a thin wall, less than 2 mm. And in understanding cysts particularly, it's very important to understand mimics, which I will be showing you. And when you have lots of these cysts, we call it cystic lung disease. For example, hydatid cyst is not a cystic lung disease. It's full of fluid, but it's still a cyst. When it empties out, it will be full of air. So it can be full of fluid as elsewhere in the body or in air. But in context of ILD, when we say cystic lung disease, which means we mean lots of air-filled lucencies. There are numerous etiologies just like ILD, but herein the entity of neoplasms also becomes important. Many patients come with spontaneous pneumothorax. I want to now show you the mimics, which are very important. One is cavity. So we tend to think, what is a cavity? What is a cyst? Like this one would be called a cavity. An important sign is the thick walls. But more than that, what is important to remember is that cavity has a past. It is the evolution of some pre-existing disease, like there was a nodule, there was a mass, there was an area of consolidation, where the contents got expelled through a bronchus, and then the center became lucent like this. This is a cavity. Eventually, it will become thin-walled also, but it is not a cyst. The other thing is emphysema, which shows us a vessel in the center, centrilobular emphysema. Shows us a vessel in the center, so we know that this is emphysema. Bronchiectasis we have already seen. These are large paraseptal bullae. When very small, it's referred to as bleb, but it said it's not a good term, so don't use the word bleb. But sometimes, if it's like a really tiny thing, you don't know what else to call it. And honeycombing also we have already seen. So blebs, bullas, pneumatoceles, cavities, and emphysema is not counted as cystic lung disease. This patient, I called it a mimic earlier and told you it's post-TB, but it looks like cystic lung disease. Just to show you the previous CT of this patient 11 months back, where it was full of treen bud plus consolidation plus miliariopasties. So in children and adolescents, it's very, you will occasionally come across cystic ILD, which is because of a TB. So very important to ask for previous radiographs or CT. Now, basically, in these 3 minutes or 4 minutes, we cover the 4 major entities, which means we excluded infections, excluded all other mimics. We are left in, I will just call it by way of a mnemonic, which is very nicely discussed in the same order in way of a mnemonic form in uptodate.com also. So do look at it there. I found their approach very nice because it goes like LPBL. So, this is, if I have a lung which is studied with cysts and I know it's not a mimic, I'm going to go in this order, LPBL. So let's look at it in this order. First step, L, is lymphangioliomyomatosis. Are the classical features present? Which means these are the keywords. Multiple, more than 10 in number, diffusely distributed, thin-walled, bilateral, uniform in size also. So this is young patient, especially a woman. Remember, it's not always a woman, because if it's a patient of tuberous sclerosis, male tuberous sclerosis patients can also have LAM, but idiopathic LAM is an exclusive female disease. But TSC LAM is not an exclusive female disease. So, and also LAM is now counted, is basically a tumor of the PCOMA family. It's not strictly an ILD, but it presents like an ILD. So we'll just see a couple of classical slides more of LAM. And the others which we see are going to look different. So in a TSC LAM patient, every LAM patient, we will screen for angiomyolipomas and look for other associations of tuberous sclerosis. Step 2, the first L is over. We come to the P. These cysts look very different. Yeah, most of them will come with spontaneous. These are irregular in shape. They are not round. They are what is called bizarre shape. They are not diffusely distributed. They are upper lobe dominant in a young male smoker. So we know we are dealing with histiocytosis of the form pulmonary Langerhans cell histiocytosis or PLCH. In the early stages, remember, PLCH doesn't always lung diseases mostly have maintained lung volumes. These are the classical forms of LAM and PLCH with the differentiating features in terms of appearance of cysts and distribution, which we already discussed. But PLCH eventually is a fibrotic disease, unlike LAM. This is also, these are outside scans which I clicked because you seldom see such advanced fibrosis. But remember, PLCH eventually is a fibrosis. So it has so much fibrosis, but with maintained lung volumes. And there is a new sign, which has been recently described, known as octopus sign in fibrotic PLCH. So this is not presenting really like a cystic lung disease, but preserved lung volumes can either be, background emphysema, or it can be in this PLCH. So again, patient age. So two entities we saw, L and P. Now, if both of those are not the case, then and you still have a lot of cysts, what can it be? The third one is BHD or Burthoff-Dube disease. That one was upper lobe. This is lower lobe dominant. This shape is oblong, ovoid shape. It's also called lentiform shape. So lentiform shape distributed in lower lobes along the pulmonary veins is suggestive of Burthoff-Dube disease, what he mentioned to you, the FLCN gene mutation. Earlier, it was not picked up because we only made this diagnosis when we saw it in conjunction with renal tumors. But with this availability of the FLCN gene, the diagnosis increasingly made. Again, a very characteristic picture, which is very different from the first two entities we saw. If all three are not present, the last entity is lymphoproliferative interstitial pneumonia or LIP. Here you see the cysts are tiny, tiny. Lots of small ground glass also, and some ill-defined kind of nodules. This is suggestive of LIP. So the patient can have CTD, patient can have HIP. It's all a reflection of hypoimmunity, autoimmunity, or idiopathic. Lastly, idiopathic is actually very rare, and mostly there will be something underlying. Again, patients of LIP, the cysts are very small and not the dominant feature. Sometimes, you'll see lots of cysts. You excluded mimic infection, you excluded LPBL, and it's none of them. What next? So just remember that you may not have a cystic lung disease. Most of the fibrotic ILDs will have a lot of cysts eventually in the end stage of lung, and it may not be a predominantly. So we have to differentiate that the cysts come first or the fibrosis came first, and whether there is volume loss or no volume loss to make this conclusion. So just to summarize, we have to have very good CT acquisition protocols, always interpret it on scanners, on a volume. And LDCT we do not use as a routine protocol, but it's not advised for ILD. But we have to, the guideline says that we have to keep our doses of HRCT very low now to desirably less than 3 millisieverts. Thank you very much.
Thank you very much, ma'am. So I will first invite the panelists, whoever has joined us. If they have any questions, they can pose those questions to ma'am. And then I'll take up some of the questions that have come from the audience in the question and answer box. Kavita, Dr. Abhishek, Adhar, if you have any particular questions, you can pose them to ma'am. Okay, then I'll take up first the audience questions. Some of them might have been covered by ma'am, but we'll still take them up because maybe some of the audience didn't get it properly. So one question is how to differentiate between macrocysts and paraseptal emphysema on the CT chest.
Yeah. So do you want me to go back to the slides and show it, or should I just say it?
Maybe, ma'am, you can go back to the slides also.
Okay, so I will go back to just one second on this. Yeah, so I'm coming back to the cystic lung disease table on paraseptal emphysema versus honeycombing. Now, the major point is in terms of, are you able to see, Sajal, the paraseptal emphysema slide?
Yes, ma'am. I can see the subpleural cyst slide.
Yeah.
Yes,
So
now
these
this
are
looks
the now, this is a paraseptal emphysema and this is a honeycombing. So 2-3 things. Both are subpleural in distribution. The second point is dominance of the location, upper lobes versus lower lobes. Not that you can't have paraseptal emphysema in the lower lobes. It's a little more complicated. I will just explain to you. So strictly what is called paraseptal emphysema is an upper lobe dominant disease. Look at the size of this individual cyst. It can be smaller also, but by and large, it's not as small as 3 to 10 mm. Then the most important thing is that 3 to 10 mm and sharing of walls. And if you look at the individual walls also, they are thicker. In the single, you can have a single layered honeycombing also. So single layered honeycombing, when do we still call it honeycombing? We at least have a cluster of 3-4 of these small in a single layer with shared walls, which are thick, and the sizes are not so big except in case of exuberant honeycombing. So exuberant honeycombing had bigger cysts, but still in layered. But you see, exuberant honeycombing was in a younger patient and was in location was same, but patient is a 30 female. Now, what happens if a patient is a 60-year-old smoker and I see this same appearance in the lower lobes, and they are multiple. So there is another entity, smoking related ILD and emphysema I did not cover. There is only, there is another entity known as AEF, which means airway expansion with fibrosis. Airway expansion with fibrosis is very common in smokers. You see it just like this paraseptal emphysema, but you see it in the lower lobes. But still, the size of those individual cysts are way bigger than honeycombing, and the walls, even in AEF, are way thinner than in honeycombing. So, thicker walls, smaller size, and layering with shared walls points to it being honeycombing versus a paraseptal emphysema. In a patient of CPFE, you will see an appearance like this. Upper lobe will have emphysema and lower lobe will have UIP pattern.
very clear, ma'am. Thank you. So the next question is, which we have, I think, covered in detail, how to differentiate between IPF and fibrotic NSIP. But we may take it up because this course is basically meant to impart very basic knowledge to all the participants. So we can even stress and repeat certain things which are very important to them.
Yeah, so we will see our classical, we will see an example again. Yeah. So, as I said, eventually honeycombing develops in everything. They say NSIP also, but I will just show you some. And sometimes, NSIP, when it occurs in a CTD setting, is not a problem because your patient profile is totally different. But it becomes a challenge if your patient is 60 something because has some biomass fuel exposure and is a woman. So you don't know, she can have UIP also, she can have NSIP also in terms of patient profile. So then the entire differentiation rests on the HRCT pattern. So I will show you some subtle points also. We already discussed that this is in subpleural area. It is involving the extreme bases, okay? Extreme bases, which means the posterior costophrenic angle also, it dips right till the lower end. And it has this multi-layered honeycombing. By and large, when it's very advanced, like it will cover this whole depth. But when you see higher up, these are the levels of the pulmonary vein. This is the left atrium. This part of the lung is spared. This part of the lung is spared, which means the peribronchovascular and the axial interstitium has not taken the hit of the disease. And there is this either subpleural or this whole thickness type of appearance. Yeah. Now I will go to a patient of fibrotic. Now look at this in fibrotic NSIP. I still have a whole thickness type of appearance in some sections, but you see this section has whole thickness. rather than my extreme costophrenic angle. And also see this part of the lung. You see, it's this peribronchovascular area also which takes a hit. In fibrotic NSIP, both the subpleural as well as this peribronchovascular area takes a hit. And I told you many times it will be an overlap. So again, it will be OP plus NSIP. But suppose you are seeing it already at the fibrotic stage, then you will see that the distribution of the central interstitium and involvement of the extreme CP angles is less, and honeycombing, though present, is not the dominant feature of this fibrosis. So that is how it helps, purely disregarding the patient background also, to help differentiate. The other thing I wanted to say is that when a disease becomes fibrotic, you can see some areas which will look black, but it is not fibrotic HP. Yeah, here, this is not the triple density sign. Eventually, when fibrosis happens, the lung contracts and the adjoining lung may appear lucent and may have some expansion also. But remember that the triple cheese is as the sign of fibrosis that I showed it to you, that when you have the mosaic attenuation. So absence of the extreme CP angle involvement, peribronchovascular interstitium, honeycombing if present, not being the dominant feature, are the differentiating points between NSIP and UIP.
Ma'am, can you go back to the last slide that you showed?
Yeah.
Just now? Yeah, so the second image, which we see
This
on the
one?
right, this one, yes. Previously, it was only about UIP and NSIP. NSIP might have been fibrotic or mixed or cellular. Now, the term probable UIP has been introduced. And this
Yes.
particular section, and even the entire
Will
CTP take
fit
the lower
into
image
probable.
also.
So that's what
Yeah.
I'm telling you. Almost, if you exclude the last ones, which means that look for different etiology, which means ground glass nodule cyst dominance, but almost every pattern of fibrosis will come into the variant. And if you look at similarly the HP guidelines also, almost any pattern of fibrosis will fall into that. So once you actually have an advanced fibrotic disease, it's difficult to make out. But then my question to you, Sajal, would also be that if this is the pattern, is your treatment going to differ vastly? That's why they remove the distinction between honeycombing and traction bronchiectasis, saying that probably at this stage, you're not going to go in for a full immune suppression, no? So
Yes,
that's
ma'am.
why they remove the distinction, saying that probably the point of distinguishing between the two is also lost by that time. But in an end stage fibrosis and an irreversible fibrosis, depending on patient background, there is a lot of overlap in all the three entities.
I think we still have to make some distinction between true UIP and something which was
Okay,
NSIP,
so
which has progressed to now what looks like a probable UIP. So this often happens in systemic sclerosis ILD, that initially we have a completely cellular NSIP. And the patient presents, say, 1 or 2 years later, and then he or she has a fibrotic. Yeah.
PSS patients, the distinction is not difficult because your patient profile is, you're not going to have a new onset CTD, however late onset, in 65 or 70 directly with the fibrotic age.
Yes, ma'am. But I'll just intervene, ma'am. Like if you see a patient, say at early, if you have that CT, you might see a very cellular kind of NSIP, typically on the first image, right? And then after, say, 1 or 2 years or 3 years, you might see the second type of pattern after some time. And it further sometimes progresses. If it is not so extensive as in the second image, if it is mainly basal, then after a few years more, the patient might absolutely have a UIP pattern. And if you don't have access to the previous CTs, that is the first CT that was performed, you can label it as definite UIP. I agree that it will not matter much with the treatment currently, but this confusion occurs with a lot of pulmonologists. They keep on getting confused between UIP and NSIP. And even with the rheumatologists, they get so confused between these two entities that some radiologist has told NSIP, the other radiologist says UIP, so we don't know what it is. So that confusion I wanted to really address, and you can address
the value
that.
of looking at a previous scan cannot be underestimated. And now we have patients of our fibrotic NSIP follow-up patients are our follow-up patients for the last 15 years, and we sit and compare 10 scans on the PACS, but so be it. We have to do it. That's why I'm saying seeing an end-stage fibrosis the first time becomes difficult to differentiate. That is why critical to always, whatever imaging patient can produce, even a chest X-ray is invaluable. I removed from my mimics I hid those slides from a lack of time. I usually carry patients of mimics of pulmonary hypoplasia who developed septal thickening and have received steroids over years. Even mitral stenosis who have received steroids over years because those curly lines were repeatedly interpreted as linear pattern on HRCTs, and no contrast was given or no echo was done. So, looking at one-time scan versus a serial scan is like not replaceable. Even if a chest X-ray of whatever quality is available, it's invaluable.
Yes, ma'am. So I'll take two more questions. One is a recurring question that amongst the cystic ILDs that we covered, 4 cystic ILDs, what happens to the intervening lung parenchyma in each of the ILDs?
Yeah,
this question has been asked for each of the cystic.
Yeah, we'll go back to all of them. So I'll open my LAM patient. So the intervening lung parenchyma is normal. Many times it will not look absolutely normal. It can have a little ground glass type of appearance, but by and large, it's not. LAM is a tumor, so it's not dominantly a fibrotic process. So the classical teaching says that the intervening lung parenchyma is normal, and most of the time it will be normal. You may get a little ground glass or some subtle things which look like septal, but mostly the intervening lung parenchyma remains normal because it's a tumor. It will go on progressing. The number of cysts will increase. The size of the cysts may increase, but you do not. Now here, for instance, we have some fibrosis, but this is in the lingula and is an isolated like a post-infective kind of fibrosis, and most of the lung remains fine. On the, this is another TSC LAM, same story. As I told you, sometimes you will see little reticulation. You will see some ground glass because you remember several of these patients would have had numerous pneumothoraces. They may have had pleurodesis. So some areas of fibrosis you will see, but that is not the dominant pattern. On the other hand, PLCH is a fibrotic ILD eventually. This is also a neoplasm, but it results in fibrosis. So this is only one stage of the, it is divided into 3 stages. So in the first stage is what is called the nodular stage. So then there is a nodular cystic stage, then cystic, and then cystic fibrosis. So it begins with nodules, it goes on to this cyst, but eventually the intervening lung parenchyma will have either nodules or start to develop fibrosis. So besides bizarre shaped cyst, if you look at the intervening lung parenchyma, it will develop fibrosis. And this is one of the most advanced forms of PLCH that I've seen, because eventually, see, with preserved lung volumes, it does go into fibrosis. So nodule cystic fibrosis, and there are well-defined and well-described stages of PLCH. So it is a fibrotic process. That's why this octopus sign, which says that, you know, it's like a stellate scar, it radiates from the center, and but it's a one-off report, and we'll see how much the community adopts the size, but it says that there's a stellate scar which radiates on the side. BHD, the intervening lung, is always normal, except, as I told you, that below the pneumothorax, if some atelectasis becomes fibrotic, nothing happens to the intervening lung. Only the area of the cyst is abnormal. You can have some nodule occasionally, but intervening lung is always normal. It is not a fibrotic process, and the predominant problem you will face is of recurrent pneumothoraces. Besides, if they have multi-system issues, LIP is, there's lots happening to the background lung because it's happening, happening in a background usually of autoimmunity or hypoimmunity. So cysts are not the only feature. And the other entities, because I didn't have time, I didn't cover, is the smoking-related ILDs. The very important cystic smoking-related ILD is DIP, or discomative interstitial pneumonia, which will have ground glass opacities and cysts in the lower lobes. lower lobe dominant, ground glass, and combination of cysts. So I have a table. I will just go off and I will show you on a table based on. No, I think I removed it because of lack of time. Basically, it says that based on the type of background that you are seeing. No, so if you see a combination of ground glass plus cyst, then what can it be? It can be DIP, it can be HP, or it can be LIP. So when you see a combination of ground glass plus cyst, it can be either of these three. So amongst the four major entries, the background lung in terms of fibrosis is a problem with PLCH, but in terms of ground glass can happen with LIP, but LIP plus cyst can also happen in DIP or in HP.
Thank you so much, ma'am, for the extensive coverage. So we'll end the session now. And thank you, ma'am. So I let the session overshoot the time because I really wanted people to have a lot of time devoted to radiology. Other sessions will try to try to finish them within the time allotted. Thank you so much, ma'am. If you can be with us in the next two sessions also, it'll be nice. But if you want to sign out, you might go as well.
Thanks, I'll try.
Thank you. Thank you. So I now invite Dr. Alok Nath, if he's here. I received a message from him that he might be busy for the next few minutes. Dr. Alok, are you there? We can take your lecture. If Dr. Alok is not there, I would like to request Dr. Puneet Saxena, if he's there.
Yes, sir. I'm there, sir.
Yeah. Puneet, can you just let me check? Are you ready with your presentation?
Can you give me 2 minutes just to set myself up?
Yeah, you can take that time. In the meantime, what Puneet I'll do is we can take up the IPF diagnosis first and then your lecture, and I will rather take up idiopathic NSIP then.
So how do you want to go about, sir? You'll take diagnosis first?
No, I'll take the idiopathic NSIP lecture first from Dr. Vijay Hada.
Okay.
And then Dr. Alok can join, and then you can join. So that IPF diagnosis comes before
treatment.
IPF treatment.
Fine with me, sir. Fine with me.
Okay. We'll just take a short break of 2 minutes, and then I'll join back.
So, sir, first lecture will be by Dr. Alok Nath.
No. The
NSIP.
first will be by Dr. Vijay Hada, NSIP. Then IPF diagnosis by Dr. Alok. Then IPF treatment by you.
Sure. Right, sir.
So as I made the announcement that we'll take up the NSIP lecture first because Dr. Aloknath, due to some reasons, could not join immediately. So we'll have the NSIP lecture followed by IPF diagnosis by Dr. Aloknath and followed by IPF treatment by Dr. Puneet Saxena. Dr. Vijay Hada is currently traveling, so he has sent us a video of his presentation. He'll be able to take up questions if possible, or otherwise I'll take up the questions. Dr. Vijay Hada is an additional professor at the All India Institute of Medical Sciences in the Pulmonary Department. He has more than 250 publications, and the CV is projected on the screen. And now we can have the lecture, which will be in the form of a recorded
Dear
Zoom
friends,
presentation.
colleagues and delegates, good morning to you and all. In next 15 to 20 minutes, we are going to discuss the diagnosis and treatment of NSIP. This presentation is based on a case, and based on that case, we will try to revise that how to evaluate a patient with NSIP and maybe little overview regarding the treatment of NSIP. So this patient is 66-year-old lady who is homemaker. She never smoked. She had a history of hypothyroidism for which she is taking thyroxine supplement. She came to us with progressively increasing shortness of breath for last 3 years. Along with that, she had dry cough and some intermittent feverish kind of feeling. On examination, her room air saturation was 93%. This was the CT scan she was carrying, which is showing bilateral reticular opacities, which are inter and interlobular septal thickening. There is some kind of GGOs are also there. They are in the immediate subpleural area. There is no honeycombing, no nodule, and there is no subpleural sparing. There is no air trapping is seen here. If we see here, there is a picobasal gradient with lower lobes are more involved as compared to upper lobes. In the mediastinal window, there is no pleural effusion. There is no pericardial effusion is there. The pulmonary artery diameter looks okay. The esophagus is not dilated. So these radiological features are quite consistent with NSIP. So if we talk about NSIP radiological finding, we usually see increased reticular markings, traction bronchiectasis, lower volume loss. There can be ground glass opacification. And one should note that the honeycombing is rare. So if there is lots of honeycombing, and especially if the honeycombing is more than GGOs, then it is not NSIP, it is more likely UIP pattern. These abnormalities are more in subpleural, they are symmetrical, and there will be a picobasal gradient there on CT scan. There is immediate subpleural sparing can be there, and it is considered as a specific sign. However, it is not very common. The one thing regarding HRCT is that its role in accurate diagnosis of NSIP is limited. So whenever we want to make a diagnosis of idiopathic NSIP, many times we will require a lung biopsy. These are the few other images where you can again see that there is a immediate subpleural reticular shadows. There is interlobular and interlobular septal thickening. There is GGOs. So these are again indicative of NSIP kind of pattern. In this case, there is a fibrotic pattern as well as GGOs. So it looks like cellular fibrotic pattern in NSIP. If we talk about NSIP as such, so NSIP pattern either on HRCT scan or on pathology is one of the common pattern observed among patients with ILDs. If the NSIP as such usually present in middle-aged adult, the prevalence is usually is higher in women because of association of CTDs. But if you talk about idiopathic NSIP, there is no difference between two genders, and smoking is not a risk factor or a protective factor for NSIP. If you talk about various causes, there is numerous causes of NSIP, especially connective tissue diseases, hypersensitive pneumonitis, various drugs. Then it can be seen in HIV infection, some rare diseases, for example, IG4 disease, family ILD, or graft versus host disease. So unless we rule out all these causes, we cannot label a patient with idiopathic NSIP. Therefore, for evaluation, there is lots of evaluation in the form of clinical evaluation, laboratory evaluation, bronchoscopic evaluation, maybe biopsy, and pulmonary function testing is required before reaching a diagnosis of idiopathic NSIP. In clinical evaluation, we need to focus mainly on symptoms suggestive of connective tissue disease, because as we discussed that connective tissue is one of the common cause of NSIP pattern ILDs. When we come to examination, again, we need to see whether this patient is having any finding suggestive of connective tissue disease. So for that, we need to focus on skin changes, joint examination, eye examination, and like that. So in the current patient, we took a detailed history and we did not find any history which is indicative of connective tissue disease. There was no joint pain, swelling, skin rash, Raynaud's, eye symptoms. There was no exposure history. So there was no pet or pigeon at home. There was some feverish feeling, but it was never documented. There was no weight loss, no flu-like symptoms. There was no history of drug other than a thyroid supplement. She was homemaker, so there is no other exposure. So based on this clinical evaluation, at least we are unable to find any secondary cause of NSIP. Coming to laboratory investigation, we always ask for routine investigation, which include complete blood count, liver function testing, kidney function testing, urine examination. Then we also see serological testing, and in all patients, at least rheumatoid factor, ANA, and NSIP should be ordered. Again, serology testing is decided based on case to case. HIV testing is also important in patient with NSIP, and comorbidity screening should also be done. The other serology which should be done in patients with suspected idiopathic NSIP are these. If we, in all patients, we always ask for ENA profile, and ENA can show various these antibodies, and sometimes we go, in addition to ENA profile, we ask for myositis panel. In some patients, we ask for hypersensitivity panel also, but this exact role is, I am not very sure. The next comes the pulmonary function testing evaluation. This pulmonary function testing, we know that these are not diagnostic of any pattern of ILD. However, these are important because these tests establish baseline as well as monitoring parameter, so that we can follow up these patients and we can see whether this patient is progressing or this patient is responding to treatment. So in the current patient, all the laboratory investigation in the form of complete blood count, LFT, RFT were normal. The rheumatoid factor, anti-CCP were negative. ANA and ENA profile were also negative. Hypersensitive panel, we wanted to do in this patient, but patient was not affording. And also we thought that this setting is not for HP, because CT was also not suggestive and there was no as such history of exposure. So we did not go for this. The pulmonary function testing revealed FVC of 53%, FE1 was 57%, and DLC was 25%, and 6-minute walk test revealed the distance was approximately 350 meters. So after this evaluation, we could not find any cause of NSIP. So next we went ahead with bronchoscopic ball, and in evaluation of patient with NSIP, this ball is again not diagnostic, but this can help in exclusion of other causes of NSIP, for example, infection. So we send the ball for microbiological analysis, or it can be some malignant process. So for that, we do cytopathological examination. And in few patients, differential count of the ball can be helpful in making diagnosis. For example, I have shown here in this slide, the various cell, based on various cell count, we can make a diagnosis, or at least our confidence of making the diagnosis of that disease can be a little bit higher as compared to without ball. So coming to the lung biopsy as such is considered as a large resort. Here we have evaluated patient with clinical evaluation, laboratory evaluation, and we are not finding any cause for that NSIP. In those cases, the lung biopsy is helpful. And one important thing is the lung biopsy should be considered only after MDD. That even after MDD, we are unable to make a diagnosis. In those cases, the lung biopsy should be done. And we can obtain the lung biopsy from bronchoscopic techniques or surgical, and we will discuss how these are faring. So If we talk about conventional TBLB, the sensitivity is very, very low. It ranges from 16 to 33%. If we talk about cryo-TBLB, or is also commonly called as TBLC, this is a relatively new technique to obtain lung biopsy. Its yield is improving and is with day by day is increasing, and it's approaching to surgical lung biopsy, and it has a very good safety profile when we compare to the TBLB. Also, if we talk about surgical lung biopsy, that is considered gold standard, but unfortunately, the many patients who are coming to us, they are already having advanced diseases, so they may not be fit. So surgeons are not many times willing to do a lung biopsy. So if we talk about evidence as such, so there is recently a study was published in European Respiratory Review, which was a systematic review and meta-analysis, which showed that the cryo-TBLB with MDD, the pooled diagnostic yield was approximately 77%. The complication rate overall was approximately in 10% cases. Pneumothorax and bleeding was a common one, and in few patients there was acute exertion of ILD. If we talk about FETs, guided lung biopsy, the pooled diagnostic yield was close to 94%. There is another meta-analysis published in this year, and this meta-analysis showed that the cryo-TBLB as such is useful technique of obtaining lung biopsy, and with this we can achieve a definite or high confidence diagnosis in approximately 82% of patients. And again, the complication rate was approximately 10%. The pneumothorax is commonest one, and then severe bleeding can also be seen in approximately 2% of the cases. So overall, if we see that this cryo-TBLB seems a reasonably safe procedure, and the diagnostic yield is also reasonable one. In our case, we did the BAL, and the report revealed that there were macrophages 66%, 60% were macrophages, 30% neutrophil. The lymphocyte count was 10%. The infective workup was totally negative. So it was not helpful in making diagnosis, but at least it has ruled out infective causes, and there was no evidence of any malignancy. And the cryobiopsy was reported as below, that there was a uniform septal thickening with fibrosis, along with few alveoli showing acute lung injury with type 2 pneumocyte hyperplasia. There was chronic inflammatory infiltrate seen in septal and interbronchial location. Overall feature suggestive of NSIP. There was no granuloma, no OP pattern, there was no giant cells. So we discussed this case as MDD, and finally we made a diagnosis of idiopathic NSIP. So this is how we can approach a patient with radiological feature suggestive of NSIP, and we can make a more confident diagnosis of idiopathic NSIP. Once we have made a diagnosis of NSIP, then comes the treatment. And treatment, usually if we talk about an NSIP as such, then it depends on what is the cause of NSIP, whether it is CTD, exposure, or drug. So based on that, we take the decision, and also what is the disease severity and rate of progression. So when patient is having very few symptoms, mild disease, in those cases, or there is a limited or very little physiological impairment, in those cases we can wait and we can observe the patient for maybe 3 to 6 months. And in case of progression, we can take a decision to start treatment. However, in our case, patient was quite symptomatic and there was significant physiological impairment on pulmonary function testing. In moderate to severe case, again, we don't know how to treat these patients. However, whatever treatment we practice today is based on our experiences with the patient connective tissue disease associated NSIPs, and any patient who is having moderate symptoms or impairment on PFT require treatment. So usually we have two options, glucocorticoids and immunosuppressives. So we don't know what is the best dose and duration of glucocorticoids. However, most of the centers start a steroid dose of 0.5 to 1 milligram per kg body weight equivalent of prednisolone, which is given for 4 weeks, and then another 2 months, little bit higher dose, maybe 30 to 40 milligram. At our center, we give 20 to 25 milligram once daily. This is because our patients are having a little low weight as compared to Western population, and then we taper this dose. slowly to with a target that we will bring it to approximately 5 to 10 milligram per day at the end of 6 to 9 months. In few cases, higher dose may be required or pulse may be required, especially if patient is hospitalized or patient is having acute respiratory failure. The other options are immunosuppressive. Usually these drugs are in addition to the glucocorticoids or corticosteroids. The various options we have is MMF, azathioprine, cyclophosphamide or rituximab, and methotrexate. In most of the time, methotrexate is not used. We avoid usually giving methotrexate in established ILD. However, MMF and azathioprine are the commonly used drugs, and cyclophosphamide and rituximab are the drugs which are reserved for refractory disease. So if we talk about MMF, the target dose is ranges from 1.5 to 3 grams per day. It's good to start with low dose because the patient otherwise will not tolerate because of GI side effect. The target we can achieve in next 2 to 3 months. Azathioprine, again we start with low dose, maybe 25 to 50 milligram per day, and then we can increase over next 1 to 2 weeks. The target dose is 1.5 to 2 milligram per kg body weight daily, and we should never exceed the dose of 200 milligram per day. In refractory cases, we have two choices, either cyclophosphamide or rituximab. The cyclophosphamide experiences are from retrospective studies. For example, in this study, 54 patients with suspected or proven NSIP, and they have shown that at 6 months there was significant stabilization or improvement when patients were treated with cyclophosphamide. So most of the time, the cyclophosphamide is given monthly doses or oral doses. We at our center give monthly doses, and we suggest that at least a trial of 3 to 6 months is required to see any significant difference. So if you want to give cyclophosphamide, at least 3 to 6 months are required to see any significant response. And once patient is showing response, we can continue it maybe up to 12 months, and after that we should switch it to either azathioprine or MMF. Coming to rituximab, all of us know that it is a monoclonal antibody directed against CD20 positive B cells. The dose is 1 gram, which is given IV, and usually two doses are given approximately 2 weeks apart. And these again is the experience are based on connective tissue disease related ILD. And if you see recently, there was a study published in European Respiratory Journal. This was a RCT, which included patient with NSIP, 122 patient, and the authors divided the whole group into 2 arms, the patient who were treated with rituximab with MMF or MMF alone. And in this study, the authors reported that there was some improvement in FVC, and there was a better progression-free survival in patients who are treated with rituximab and MMF combination as compared to MMF alone. However, there was some infections which are more common in rituximab and MMF group. Coming to the other option which are there for refractory disease is calcineurin inhibitor in the form of cyclosporin or tacrolimus. However, these are not commonly used, and if we want to use these drugs, then again the important thing is we need to monitor the therapeutic levels or serum levels, and in absence of that facility, one should not use these drugs. Last, coming to antifibrotics, we have 2 antifibrotics available, which has been approved for IPF and systemic sclerosis related ILD, as well as progressive pulmonary fibrosis related to rheumatoid and HP. However, role in NSIP is indirect. There is no study which have studies the role of these drugs in NSIP directly. So there is dilemma. If we want to use these drugs, what criteria we should use to prescribe, whether we should use these drugs in fibrotic NSIP who meet criteria which are used in inbuilt study, or we should wait till more data is available. At our center, we use these drugs, but in all cases, first we give a trial of corticosteroids and immunosuppressives, and only after that, if the patient is having fibrotic disease, we give antifibrotics. Other therapies, for example, if patient is having acute exacerbation, the treatment is almost same as for IPF. If the patient is having hypoxemia, that patient will require oxygen. All patients should be vaccinated and they should be referred for pulmonary rehabilitation. And these patients should also be evaluated and offer lung transplant wherever indicated. So to conclude, my friends, the NSIP is a common pattern which is seen among ILD patients. If we see etiology of NSIP, this is varied. It can be seen in different disorder, maybe connective tissue diseases, hypersensitive pneumonitis, some drugs, exposure. So for diagnosis of idiopathic NSIP, detailed evaluation is required before labeling it idiopathic. Once we have made a diagnosis of idiopathic NSIP, the treatment is not known. However, whatever treatment we do, it is based on experiences with CTD-related NSIP. And treatment options currently available include corticosteroid, MMF, azathioprine, rituximab, and cyclophosphamide. Ritux and cyclophosphamide are reserved for refractory diseases. Last but not the least, antifibrotics. These are commonly used, but direct evidence is lacking as far as efficacy in idiopathic NSIP is concerned. So thank you, friends. If there is any question or comment, I will be happy to respond.
Okay, so as Dr. Hada is traveling, most likely he'll not be able to join. Whatever questions we have got in the question and answers box, I've already answered directly. And because of shortage of time, we'll not take up the questions right now. We have a long discussion at the end of the session and we'll take up the questions there and then. So we'll go to the next lecture. And the next lecture would be diagnosis of idiopathic pulmonary fibrosis, for which I invite my dear senior from PGI, Dr. Alok Nath. Sir is professor and head in the Department of Pulmonary Medicine at SGPGI MS Lucknow. He has about 100 publications. He is member and fellow of various societies and has won several awards. So over to sir for a lecture on diagnosis of idiopathic pulmonary fibrosis, that is IPF.
Thank you, Sejal. A very good morning to all the panelists and esteemed audience. I'll be talking about the diagnosis of IPF. Is my screen visible now?
Yes, sir, the screen is visible. You can proceed. Could you just make it full screen and just run the slide a bit so that...
Is the slide moving?
No, it is stuck. Yes, now it has moved. Yes.
There may be some lag.
You might, there's some lag, but you might proceed now, sir.
So, a very good morning to everyone. And to proceed further, we have our the assignment given to me, that is the diagnosis of idiopathic pulmonary fibrosis. We have heard about the approach to idiopathic pulmonary fibrosis and a comprehensive discussion about the radiological patterns in the diagnosis of ILD. And there has been considerable progress in understanding of the disease and understanding of the mechanisms and the forms of interstitial lung diseases. And the classification of interstitial lung diseases have been modified several times through several updates by various societies. And a new classification or a working classification at present is being followed. So the interstitial lung diseases are a heterogeneous group of disorders which are of more than 150 types and has been classified into exposure-related idiopathic group, the CTD-related granulomatous and other miscellaneous groups. The prevalence of interstitial lung diseases is slightly higher in males, and among all respiratory diseases, about 15% of patients are ILDs. And out of those 15%, about 65% of patients have idiopathic, that is the ILDs of unknown cause. So the current classification which we are following is in front of you, which have been broadly classified into major idiopathic interstitial pneumonias, the rare idiopathic interstitial pneumonias, the unclassifiable ones, and acute fibrinous and organizing pneumonia, that is AFOP, and bronchiolocentric patterns of interstitial pneumonias. So amongst the major idiopathic interstitial pneumonias, IPF is the topic of discussion today. And the question is, why do we want to actually split or classify or differentiate between all the kinds of idiopathic interstitial pneumonias? The answer is very, very clear, that the prognosis and the survival of idiopathic pulmonary fibrosis is very poor, and the mean survival is around 3.5 years only. So we need to find out to prognosticate the patient and to tell the prognosis of the patient, of the disease to the patient, because effective modality of therapy, unfortunately, is not available for idiopathic pulmonary fibrosis till date. So as we know, IPF forms around 55%, 55 to 60% of idiopathic interstitial pneumonias. It is slightly more common in males, with the age, presentation is mostly, but not always, in more than 50 years of age, and there is often association of smoking. Duration of symptoms is usually more than 6 months, and the median survival from the time of diagnosis ranges from 2.5 years to 3.5 years. The initial diagnostic criteria for idiopathic pulmonary fibrosis in early 2000s was grouped into major and minor criteria. The major criteria was exclusion of other causes. There was abnormal pulmonary function test by basilar reticular abnormalities in HRCT, transbronchial lung biopsy or BAL showing no supportive alternative diagnosis, and minor criteria were 4 criteria: age, the insidious onset, the duration of illness, and the presence of bibasilar respiratory crackles. So there had been considerable research in the field of pulmonary medicine, in the field of interstitial lung disease, and in the last decade there had been a gross change, or there had been paradigm shift how we look at idiopathic pulmonary fibrosis and other interstitial lung diseases. So after multiple revisions and multiple updates and perspective published by various researchers in this field, now what we have come up with the diagnostic criteria of IPF is that first is that exclusion of any other known cause of ILD, that is domestic and occupational exposures and environmental exposures, presence of connective tissue disorders and drug toxicity. The presence of a UIP pattern on HRCT in patients that were not subjected to surgical lung biopsy, and a specific combination of HRCT and surgical lung biopsy patterns in patients who were subjected to surgical lung biopsy. So this is the current classification and the way we look at the requisites for the diagnosis of IPF. The combinations and permutations of SLB and HRCT I'll be talking about later. So how do we rule out other causes? Dr. Sjogren has already covered the approach part, so I won't be reiterating or repeating it. There is no substitute for a detailed and comprehensive history, including history of smoking exposures, etc. Age and gender have got its own importance, because some of the ILDs are more common in males and females. However, these are not watertight compartments. History of smoking is important because there are some specific smoking associated ILDs like LCH, good pastures, RBILD, asbestosis, and individuals exposed to asbestos and who smoke are more likely to develop asbestosis. And also, history of smoking is an important history in patients with idiopathic pulmonary fibrosis also. Now, the history of drugs is important. There is a comprehensive, exhaustive list of drugs which can cause interstitial lung diseases of various types, which can be cytotoxic, non-cytotoxic. The list is in front of you. various antibiotics, anti-inflammatories, analgesics, and cardiovascular drugs, inhaled drugs, intravenous drugs, and miscellaneous drugs, among which radiation and some anti-tubercular drugs and antihypertensives are amongst the common ones. So a history of drugs is important. Environmental and occupational history, which Sajal has already covered, is one should underscore and very carefully take these kind of histories so as to find out if there is any offending exposure and there is a temporal relationship in the development of disease process. A detailed physical examination should be done, and some important clinical findings which can give us clue towards systemic involvement, like uveitis scleritis, presence of generalized lymphadenopathy or organomegalies, presence of pericarditis, presence of bone involvement, presence of myositis, presence of glomerulonephritis, nephrotic syndrome-like presentation, presence of renal masses. These are various clinical examination findings which are actually can give you a direct clue towards a underlying systemic disease. So a battery of investigation is required to approach a patient of IPF, which includes a complete blood count with a peripheral blood film, a complete urinalysis, serum proteins, and serum autoantibodies, in which antinuclear antibodies, RA screen, ANCA with anti-GMM in selected cases, and a ENA screen also is recommended in a patient who is suspected to have idiopathic interstitial, idiopathic pulmonary fibrosis or ILD of unknown cause, who has come up for evaluation to a pulmonary or a respiratory physician. HIV serology should also be obtained in patients with presenting with interstitial lung diseases. The importance of these obtaining serum and autoantibodies and the panels of ENA screen is now expanded. Sajal also has talked about it, and this can be done in two parts. First, the six antigen panel in the ENA screen, and later on the comprehensive panel also can be done if you are strongly suspecting or there are odd features for the diagnosis of idiopathic pulmonary fibrosis. So after investigations, you get the results, and these are some of the things which are very important, in which presence of serum autoantibodies and immune complexes points towards a collagen vascular disease, which may be underlying. Anti-GBM or serum ACE levels can give you some indication about the other illness. Anti-neutrophilic cytoplasmic antibodies can give you an indication towards systemic vasculitis. Similarly, simple examinations, findings like presence of active urinary sediments or eosinophilia or thrombocytopenia can give an indication or a clue towards an underlying disease. Importance of pulmonary function test, which includes spirometry and diffusion capacity, cannot be undermined, which can show you a restrictive or a mixed pattern. Diffusion capacity should be obtained. These are more of prognostic tools rather than diagnostic tools, because after obtaining HRCT and making a diagnosis of interstitial lung disease, spirometry and diffusion lung capacities or ABG or exercise capacity by a 6-minute walk distance are more of a prognostic tool and should be obtained and baseline to monitor the progression and the response to treatment. So the first part is over. That is, we have done our work, or we have worked up the patient in detail for ruling out an underlying secondary cause of ILD. And now we we see the disease or the patient in a form that you don't know exactly what you do not have any apparent known cause of the ILD. So now next is to demonstrate that presence of a UIP pattern, which is doesn't have any cause, makes the diagnosis of IPF. So that the radiological patterns have also evolved over a period of time. The earlier classification was on radiology was a definite UIP, possible UIP, or inconsistent UIP, which actually focuses on presence of specific radiological abnormality, that is the presence of subpleural basal predominant distribution, which is often heterogeneous, that is there is temporal heterogeneity, and lesions of all ages are can be appreciated on a HRCT scan, and presence of honeycombing. So these are some radiological features which are consistent or which are diagnostic of presence of a UIP pattern, along with presence of tractional bronchiectasis. Again, there should be apico-basal gradient. The basal, the lower lobes should be more involved as compared to the upper lobes, and the distribution should be subpleural and basal. So this was the definite and the probable UIP pattern, which can be seen in these radiographs. And then there were some features which make the diagnosis of UIP absolutely inconsistent, or they are not consistent with the UIP. That is presence of various cysts, presence of diffuse ground glass opacities, too much asymmetricity, or presence of consolidations or crazy paving appearance, which can be appreciated here. So these are all found to be inconsistent with UIP. Later on, the updated HRCT patterns reiterated the same thing with slight modification, that in definite UIP, there should be subpleural and basal predominant distribution, which is often heterogeneous, and there should be honeycombing with or without peripheral traction bronchiectasis or bronchiolectasis. So bronchiectasis or bronchiolectasis everybody knows. Bronchiolectasis is appreciated as opening off of the bronchioles, which can be seen in this radiograph. In the bases, you can see that there is dilatation of the distal part of the airways, which is called because of traction or because of fibrosis, and that is called bronchiolectasis. So these were the features of definite UIP. Probable UIP, the distribution is same. There is reticular pattern or bronchiectasis or bronchiolectasis, but honeycombing is not present. And minimal or mild GGO or ground glass opacification can be seen. However, indeterminate for UIP, the lesions are distribution is subpleural or basal predominant, but reticulation is not that marked, which can be labeled as early UIP pattern, and CT features or presence of CT features or distribution which point toward any alternative diagnosis, such as presence of cysts, mosaic attenuation, ground glass opacification, profuse micronodules, central lobular nodules, consolidations, distribution which is peribronchovascular or perilymphatic, upper or mid-lung predominant disease, and other features like presence of pleural involvement, dilated esophagus, there is clavicular erosions, extensive lymphadenopathy, and presence of pleural effusion or thickening, which point towards alternative pathology. So these were the updated HRCT patterns. However, it was seen that UIP, although UIP is hallmark radiological pattern of IPF and mostly bilaterally symmetrical, but asymmetric disease was also found in around 25% of patients. The positive predictive value of a radiological diagnosis of UIP on a HRCT for a pathologic diagnosis was between 90 to 100%. However, positive predictive value for a less confident diagnosis can be as low as 70%. And more than 50% of the histologically proven UIP cases were not given a confident diagnosis on HRCT, underscoring the limitations of HRCT. So these latest update, which was published a year before, came up with the similar kind of description, but with the level of confidence, that is with how much confidence you can make a diagnosis with a given pattern, which was similar to the previous description. However, the point of asymmetricity was also mentioned in that, and presence of honeycombing, traction bronchiectasis, bronchiolectasis, and irregular thickening of interlobular septal with a superimposed with a mild GGO. These all features were discounted upon for UIP pattern to make a confident diagnosis with a confidence of more than 90%. Similarly, probable or UIP pattern, which can have a confidence level between 70 to 89 and 50 to 70% respectively. And with the last, that is presence of features which suggest an alternative diagnosis, make the confidence for the diagnosis of less than 50%, which is very poor, and further evaluation of the patient should be done with appropriate investigations whenever these kind of patterns are encountered. These are some of the radiographs again to so that you can appreciate that this is a definite UIP pattern. In the upper panel, the panel showing A, B, and C. You can see definite honeycombing here, and presence of bronchiolectasis, no ground glassing, and apicobasal gradient with the subpleural and basal distribution. However, in this panel D, E, F, you can see these are features suggestive of probable UIP, in which apicobasal gradient is clearly seen. There is a definite subpleural and basal distribution. There is bronchiolectasis. The definite honeycombing, however, is not seen in this CT scan films. Similarly, these patterns in which presence of areas of ground glassing and presence of interlobular septal thickening with bronchiolectasis, but subpleural sparing, which is typically described, however, not sine qua non of non-specific interstitial pneumonia pattern. And in the lowest J, K, and L pattern, you can see mosaic attenuation, air trapping, diffuse ground glassing, and that 3 density sign, which is very typical of hypersensitivity pneumonitis. So with all that in hand, we further studies also gave us some insight that in 50% of patients with possible UIP pattern, the histological examination showed features or a diagnosis of other than idiopathic pulmonary fibrosis. And in the same cohort, the outcomes and response of nintedanib in the patients with the possible UIP with traction bronchiectasis and HRCT was similar to that with the patient of definite UIP. But in the same cohort, it is not clear if they would have offered therapies other than antifibrotics, what could have been the fate of these patients. That is a matter of debate. So, so this gives you a basis of performing histological examinations whenever you have features other than definite UIP, that is probable UIP or indeterminate for UIP. One should try and find out any alternative cause by going back again to the patient, re-evaluating the patient, and obtaining relevant investigations, whatever are indicated on the basis of clinical findings and the baseline investigations. And if one cannot find any clue, then a patient may be subjected to histological examination, and the histological patterns similar to the radiological patterns have been described. Definite UIP is typically described as described with presence of dense fibrosis with the architectural distortion, presence of fibroblastic foci, patchy involvement of the lung parenchyma, and similar to radiology, predominant subpleural and paraseptal distribution of fibrosis, and absence of features to suggest an alternative diagnosis. And probable UIP, which has features same as column number 1, that is of the definite UIP, and absence of features to suggest an alternate diagnosis or presence of honeycombing only. However, for indeterminate for UIP, you should have fibrosis with or without architectural distortion, with features favoring either a pattern other than UIP or features favoring UIP secondary to another cause. Apart from that, some histological features from the definite UIP group may be present, but with other features suggesting an alternative diagnosis. And alternative diagnosis pattern we are aware of. So we can after the histological examination, we can reach or make a confident diagnosis of IPF. But a relevant minority of patients with non-diagnostic HRCT, that is patients with possible or inconsistent with UIP, are left with the diagnosis of possible IPF. And in these patients, even surgical lung biopsy sometimes fails to reduce the diagnostic uncertainty even after a histological examination. Therefore, a multidisciplinary team discussion is the standard of care for evaluating patients with ILD, whether they are suspected to have IPF or they are not suspected to have IPF. And once a histological pattern is recognized, that is whether it is an NSIP pattern, organizing pneumonia pattern, or a UIP pattern, what the clinician has to go back and reevaluate for relevant history. And as I just spoke about, take a deep and a comprehensive history and reevaluate the patient for presence of underlying connective tissue disease, there's drug exposure, and investigate accordingly to find out any systemic secondary cause of the disease. So if a histological UIP pattern is found in absence of a known cause, IPF can be confidently diagnosed. In other circumstances, despite the availability of extensive clinical data, the confirmation of diagnosis remains challenging, particularly for non-expert clinicians. Therefore, a face-to-face multidisciplinary team discussion involving clinician, radiologist, and pathologist is now widely used to increase diagnostic agreement, and the reproducibility of an IPF diagnosis established by a multidisciplinary discussion is good, and it improves prognostication. This is the proposed diagnostic algorithm. So, summarizing whatever we just heard about, that in a patient who have suspected, who has presented or to us with suspected IPF, and no potential cause or association has been found, a patient should be subjected to HRCT with the protocols which were told in detail by Professor Ashu. And if you find a definite UIP pattern, patient should be subjected to multidisciplinary discussion and a diagnosis of IPF can be made. If there is indeterminate or probable UIP pattern on HRCT, the multidisciplinary team discussion should be done, and the patient should be subjected to either a surgical lung biopsy or a transbronchial lung cryobiopsy. The recent edition of the ATS ERS update says that TBLC is an acceptable alternative to surgical lung biopsy or VATS-guided lung biopsy for histological examination of lung tissue in a patient with suspected interstitial lung disease. And after surgical lung biopsy, a repeat multidisciplinary team discussion should be done, and conclusion is reached if and a diagnosis of IPF can be made. However, if you have a potential cause or an associated condition, then HRCT should be seen. A pattern should be pattern-based approach should be taken as described in the radiology lecture, and according to that, an alternative diagnosis is achieved. So, what are the recommendations? Recommendation that for a patient with newly diagnosed interstitial lung disease of apparent unknown cause, who is suspected to have IPF with an HRCT pattern of UIP, surgical lung biopsy is not recommended. However, in the same kind of presentation, who have a probable UIP or indeterminate for UIP kind of pattern, SLB is suggested. Transbronchial lung cryobiopsy can be regarded as an acceptable alternative to surgical lung biopsy for making histopathological confirmation of IPF. But it should be done only in medical centers who have adequate experience to perform the procedure, and at the same time adequate experience to interpret the tissue specimens provided by cryobiopsy. For patients with newly detected ILD of apparently unknown cause who is suspected to have IPF, MDD is suggested for diagnostic decision making, and a combination of specific combination of HRCT pattern and histopathological pattern through this contingency table should be done, and a confident diagnosis of UIP can be made if you have UIP, probable UIP, or indeterminate for UIP pattern on HRCT, and UIP probable or indeterminate pattern on histology. So this table can be, contingency table can be used for making a confident diagnosis of IPF if you in the patients who have been subjected to biopsy, either by VATS or surgical lung biopsy or transbronchial lung cryobiopsy. And multidisciplinary approach should always be always be followed, because diagnosis is dynamic. It requires close communication between clinician, radiologist, and pathologist, as well as the rheumatologist. And many times disease evolve, and the diagnostic process is dynamic, and we encounter such kind of patients in which change in diagnosis is seen in due course of management and follow-up. The clinical data, the laboratory findings, the radiological findings are essential tools for making a multidisciplinary diagnosis, and the need for histological confirmation cannot be under. The aim of MDD is not to undermine the histological need of histological confirmation, but it actually makes you more wiser where a patient should be subjected to an invasive procedure for obtaining a histological or making a histological diagnosis of idiopathic pulmonary fibrosis or confirming a UIP pattern. So thank you for your patient listening. I'll be happy to take up questions.
Thank you so much, sir. We'll take up the questions in the very end, at the end of this particular session. So now I invite the next speaker for this session, and the topic will be the treatment of idiopathic pulmonary fibrosis. And we have a very good speaker with us, my favorite colleague, junior colleague at the PGI, Colonel Puneet Saxena. He has completed his MD from AFMC and DM Pulmonary Medicine from PGI. He is a senior advisor and head Department of Pulmonary Medicine and Critical Care at the Army Hospital R&R, New Delhi. He has more than 30 publications. He has received several awards, including a Chief of Army Staff Commendation. So over to Puneet for delivering a lecture on IPF treatment.
Shall I share my presentation?
Yes, you can share.
Is it my presentation visible, sir?
No, not yet.
Not yet.
You press share screen and then select your particular presentation and then go to full screen.
Is it visible now, sir? Is it visible now, sir?
No, sir.
No.
No.
Puneet, if you are having a problem, I can share from my side. You have already sent me the presentation.
Fine, sir.
And you can deliver the lecture.
And
You
will
can
I be
just
able
prompt me. I'll move the slides. I'll move the slides when you prompt me.
Can I try once more?
Yeah, you can try once more. Yeah, now we can see it. Now
Yes.
we can see it.
Yes.
Make it full screen.
Yes, sir.
Just try to move the slides. Yeah, they are moving. Okay, right. You can start now.
Right, sir. So, good morning, everyone. Sorry for this hitch. So, we've had this excellent discussion on diagnosis of IPF. And in the next 20 minutes, I'll try to answer these questions. Why to treat and who to treat? What should be our goals of treatment? What should be the expectations from treatment? What definitely works? What definitely does not work? And what probably may work? And finally, what should we expect in future to come in the treatment of IPF? So coming to the first question, why to treat? That is simple because we have seen from the studies in the last 2 decades, especially the study of the control arms of the trials, that untreated IPF eventually deteriorates in the terms of lung function. So we find that untreated IPF FVC declines at a rate of about 150 to 200 ml per year, which is almost 4 to 5 times the normal FVC decline. So this is the biggest reason to treat, because the patients would eventually worsen, and the decline in FVC is strongly related to symptoms, to mortality, and to poor quality of life. So that is the reason why they should be treated. But having said that, we also know that the natural history of IPF is not homogeneous. There will be some patients who may have a rapid decline after diagnosis over months, and yet there'll be some who have a very slow progression and may give a lot of time. And then there'll be others who are extremely stable. Year to year, their CT scan, their spirometry just does not change, and they remain stable. But even then, the trajectory also does not remain constant. So a patient who has been extremely stable may suddenly have an acute exacerbation, and then thereafter the FVC may start declining rapidly. Or somebody who has been having a slow progression may suddenly become stable or may start declining rapidly. So what is important to note is that not only the natural history of IPF is different from patient to patient, also in a single patient, the trajectory does not remain uniform, and it may change from time to time, especially when there is an acute exacerbation. So that highlights the role of monitoring. And also, we must understand that most of these patients are geriatric and they have other comorbidities, they're aging, they're deconditioning. Several times it is not possible to be sure whether the decline which is happening is because of their IPF, or is it because of their age, or because of their COPD, or because of their cardiac problems. So that is also important. So it's very important to monitor these patients closely, so that both the physician as well as the patient, they have a clear idea what we are heading to, what should be the aggressiveness of treatment, when should we opt for transplantation, when should we opt for palliative therapy. So it's important that the patients have to be monitored closely. And like Dr. Alok mentioned, that the monitoring tools remain the same. Clinical spirometry and 6-minute walk test, like any time of exercise test, they're easily available, not very expensive. So these are some things that should be frequently done. So typically, clinical evaluation, that is symptom scoring, dyspnea, cough, spirometry, and 6-minute walk test should be done every 3 to 6 months in all the patients. HRCT may be done a little less frequently, maybe annual in some patients, or maybe once in 2 years. So it depends upon the stability or the severity of the disease. In patients who are rapidly worsening, we may need to do more frequent HRCTs. In patients who have been following up for years and the disease has remained stable, we can reduce the frequency of HRCT. So it has to be individualized. Similarly, echo, these patients, they often develop pulmonary hypertension and they have to be evaluated for that. Also, they may have other comorbidities which may affect their cardiac function and pulmonary pressures. So echo has to be done from time to time. Again, the frequency has to be individualized according to the patient to patient. So the monitoring is important. Clinical spirometry and 6-minute walk test has to be done very regularly, 3 to 6 months. HRCT and echo from time to time, depending upon patient's preferences and patient's requirement. Also, we must understand that many patients are labeled as IPF in the beginning, but as we see through them over the period of time, we may realize that this may not be IPF. It may be something else. It may be an autoimmune related ILD. It may be CTD-ILD or a hypersensitive pneumonitis. So the diagnosis may change in time. So therefore, we have to follow the patient up with an open mind, and the diagnosis and the treatment may change as the disease evolves. So the goal of treatment in all these patients would be first to check the progression of the disease. Like we discussed, that the trajectory is not uniform. It varies from patient to patient, and even in a single patient, the trajectory may change with time. So the goal of the treatment has to be to check the progression of the disease, specifically the decline in FVC. Also to improve the overall health related quality of life depending upon the patient's symptoms and other comorbidities. Symptom management is important because that is what matters to the patient the most. and to mitigate risk factors for acute exacerbations, risk factors for progression of disease. So mitigate the risk factors as much as possible. It is important to understand the goals of treatment because the treatments that we have at the moment are not perfect. So we can do only as much in a disease as frustrating as IPF. So to achieve these goals, there are various modalities that we have. We have medical therapies, preventions like vaccination, palliation, lung transplantation, rehabilitation, and treatment of comorbidities. And we have to give all of them concurrently or sometimes sequentially. And this is what I'm going to discuss now. So there are certain treatments which are for everyone. Pulmonary rehabilitation, smoking cessation, adult vaccination, patient education. These are for everyone. They have to be given. And I'll come to all these a little later. But before that, I'll speak about something which is more important, which is pharmacotherapy. It is very important to understand that what works in IPF and what might harm in IPF and what probably may work, but the evidence as of now is not very clear. So what works is very clear. The only treatment that works at the moment is antifibrotics. And the only two antifibrotics that with the current evidence we can use are nintedanib and pirfenidone. So we all are familiar with these two drugs. Nintedanib, it is a multiple tyrosine kinase inhibitors. Multiple tyrosine kinases like fibroblast growth factors and vascular endothelial growth factor and platelet-derived growth factor. Multiple TKIs are inhibited and thereby fibrogenesis is prevented. Pirfenidone inhibits collagen synthesis and extracellular matrix deposition and fibroblast proliferation by more complicated and not very well understood mechanisms. And possibly it inhibits TGF beta and maybe by inhibition of myocardial related transcription factor signaling, and however more work is going on in this. But both of them, they have got potent antifibrotic effect. The dose of nintedanib is 150 mg twice a day, and pirfenidone is typically given 40 mg per kg per day in 3 divided doses to a maximum of 2403 milligram per day. The dose we start at a low dose like 200 milligram thrice a day, and we gradually escalate to full dose over 2 weeks as the patient tolerates. Many patients are not able to tolerate full dose, and sometimes we have to stop at 1800 milligram, but anything less than 1800 milligram per day in an adult patient may be suboptimal as far as pirfenidone is concerned. Both the drugs have an hepatotoxic potential, and therefore dose reduction may be required in mild hepatic impairment, and the drug should possibly be avoided in more severe forms of hepatic impairment. The biggest problem are the adverse effects. Both the drugs are poorly tolerated. The adverse effects are almost 10 to 20% in the clinical trials. In real world studies, the adverse effects are much more, and the dropout rates are almost 30% in real world studies. The most common are the gastric side effects, diarrhea, nausea, vomiting, gastritis. These are the most common side effects. Pirfenidone can also cause a lot of rash, and both the drugs can cause weight loss. So these are the reasons why many patients would discontinue the medicines. So therefore, it is important that these things are discussed with the patient when we are when we are starting the treatment. And sometimes if the patient does not tolerate one drug, switching to the other drug like pirfenidone to nintedanib or nintedanib to pirfenidone might work. Sometimes dose reduction might work, but how much does the dose reduction compromise upon the efficacy of drug is not very well known. So nintedanib is effective, and we've had the phase 2 tomorrow trials, and then we have impulses 1 and 2, which is the phase 3 trials, and they've shown that not only the safety profile is quite acceptable, also there is a significant improvement in the rate of decline of FVC in the IPF patients. The issue with these approving trials was that most of the patients in these trials, they had quite good FVC. They were fairly well preserved patients. So the points which came up were that will these drugs work when the disease is advanced, and should we start these drugs upfront, or should we start these drugs only if we have clear evidence that the patient is deteriorating? So but now we have clear answers that wait and watch approach is not recommended. It has been seen that the drug nintedanib, it works as well if the FVC is high or the FVC is low. So we have got sufficient trials and now meta-analysis data to suggest that the nintedanib works as well in early disease as well as in late disease. Also, we know from meta-analysis data and from the pre-specified subgroup analysis from the clinical trials that in all subsets of populations, nintedanib is effective. So irrespective of age, gender, level of FVC, smoker, non-smoker, background treatment, whatever patient is receiving. So nintedanib is effective in all sorts of patients. Also, even in advanced diseases where the diffusion is less than 30%, FVC is less than 50%, even in those cases, nintedanib is effective, and the quantum of effect is also as much. Having said that, definitely patients who have got advanced ILD, they do not tolerate the treatment very well. The adverse effect and dropout rates are higher, but the drug is as effective in reducing the progression of fall of FVC. When we see pirfenidone, we see similar results. We initially had capacity studies followed by phase 3 ASCEND trial, which showed that not only the decline in FVC is prevented by pirfenidone, also it had a mortality benefit, and the relative risk of death or disease progression both fell down significantly in the population which received pirfenidone. And again, just like pirfenidone, it is just like nintedanib, pirfenidone is effective in early as well as advanced disease. So this is the data from RECAP study, which showed that the safety profile was similar. The dropout rates were higher in advanced disease, but the annual rate of FVC decline was similar in both the groups, early as well as advanced. So the bottom line is that both pirfenidone and nintedanib are effective. They should be given to all the patients if tolerated, if they have IPF at the time of diagnosis, and we do not have to wait for the patients to advance to go to the advanced disease or to progress. Now, what do we start between pirfenidone and nintedanib? Which is better, which is more effective? We do not have head-to-head data, but network meta-analysis data is available, and we feel that the efficacy of nintedanib and pirfenidone is similar. So there is no reason to choose one above the other. The adverse effect profile is also nearly the same. Some patients may develop rash with pirfenidone, which may not happen with nintedanib. Weight loss potential may be more with nintedanib than with pirfenidone, but it varies from patient to patient. So therefore, the choice of the drug, it only depends upon patient's preference. Nintedanib is twice a day, pirfenidone is too many tablets thrice a day. So some patients may want to take lesser tablets, and some patients may want to take more. Sometimes because of drug interaction potential, we may have to change. Like nintedanib, it's a tyrosine kinase inhibitor, it's a VEGF inhibitor. So somebody who's on therapeutic anticoagulation, we may not give pirfenidone because it may increase the bleeding potential. So therefore, drug interactions have to be seen, adverse effect profile has to be seen, and those can be the reasons to choose between pirfenidone or nintedanib. And we may have to make a switch if one is not effective, the other one may be effective. Similarly, effect on mortality and effect on prevention of acute exacerbation. This is also similar between both the drugs. Both the drugs are effective in preventing mortality, reducing hospitalizations, and reducing the frequency of acute exacerbations. So if these two wonderful drugs that we have, what about we combine both of them? Because both have different mechanism of action, and it is hypothesized that if we combine both of them, we may have a more profound improvement in FVC if we give both of them together. So the data is evolving. Currently, we have got two good trials which have at least shown that it is feasible, and the acceptance rates are good. The safety profile is not so bad, and the both drugs can be combined without significant increase in the drug toxicity. However, how much efficacy will it give, and what should be the dosing profile, that is yet to be seen. The data is still evolving. The problem with nintedanib and pirfenidone are that both these drugs are poorly tolerated. Adverse effect profile is not very pleasant, and no effect on symptoms. The patients, they come with dry cough and dyspnea. These two, they do not really improve. The only thing that we are doing is that we are improving the longevity, reducing the FVC decline, but the patient does not get symptomatic benefit. So such toxic drugs in such heavy doses with so many adverse effects, and it becomes difficult to maintain a straight face when you explain this to the patient that you have got a disease. I cannot treat it, I cannot improve your symptoms, and I'm going to be giving you drugs which is going to make your life hell by causing gastritis, nausea, vomiting, diarrhea. And then convincing the patient to take it can sometimes be really difficult. So therefore, this is the problem, and probably future studies have to focus on antifibrotics which have got a better adverse effect profile. And even the RCTs should have more meaningful primary outcomes. So primary outcome of FVC decline is not really patient-centric. So more patient-centric outcomes should be primary outcomes in the future RCTs. So what works? We now know that nintedanib and pirfenidone are the only two pharmacological agents which work. But we have a huge list of what does not work. So basically, immunosuppressants, immunomodulators, they do not work. Not only they do not work, they can cause harm. So before 2011, 2012, a combination of NAC, azathioprine, and steroids used to be a very popular therapy based upon some observation data and small trials. But then this big trial came, Panther IPF trial in 2012, 2011-12, and it clearly showed that not only it is not effective, it can significantly increase mortality, time to death, or time to hospitalization, that they can cause actual harm. And this was a time when this therapy was discontinued. Even NAC alone has not been found to be effective and can cause harm. So a lot of theoretical possibility was given to NAC therapy for IPF, but so far clinical trials have not shown any effect. There was a recent Japanese trial which tried inhaled NAC. Even that did not show any benefit. So as of now, all these therapies, immunomodulators, immunosuppressants, they should not be used even for trial, because patients can be harmed, seriously harmed by this treatment. And unless the diagnosis is revised from IPF to something else, if the diagnosis remains IPF, these things should not be tried. What about pulmonary vasodilators? So a lot of these patients, they develop pulmonary hypertension, and it is very tempting to start them on pulmonary vasodilators. And but what we realize is that the pulmonary hypertension in these patients is because of a lung problem, and giving pulmonary vasodilators can worsen the ventilation perfusion ratio and can cause actual harm. And this has been seen in the studies on ambrisentan, bosentan, and sildenafil, that using pulmonary vasodilators, systemic pulmonary vasodilators, does not help. It can cause harm. It can worsen the hypoxia. It can increase the disease progression events. In fact, bosentan was sometimes hypothesized to have antifibrotic role also, but it has not been shown. So systemic pulmonary vasodilators should be avoided. However, observation data has shown that some patients might benefit with pulmonary vasodilators, or at least some of the endpoints may not be disease progression, but some of the endpoints like exercise capacity might improve, or symptomatology might improve. But which are these patients, we do not know. So because this worsening of VQ mismatch and worsening of the disease is a serious threat, inhaled pulmonary vasodilators have been tried, and this has been the recent increased trial where inhaled treprostinil was used, and it showed that there was a significant improvement in exercise capacity in IPF patients when inhaled treprostinil was used, possibly because systemic therapy was not used. So pulmonary vasodilators by inhaled route may have a role in future. Again, the data is evolving. As of now, with the current evidence, we should not use pulmonary vasodilators routinely in patients of IPF. We may have other reasons to use pulmonary vasodilators in these patients. We may use it at the time of palliation just to improve the exercise capacity, but routinely they should not be used. They can cause harm and progression of the disease. This is the pharmacotherapy. As far as non-pharmacological treatments are concerned, they're universal, like in all chronic respiratory diseases: oxygen therapy, pulmonary rehabilitation, good nutrition, lung transplantation when required, and palliative care. Now, lung transplantation is something which is now increasingly available in our country, but still it is not widely available. There are logistic issues, costs are high, insurance is not available. So this is something that we have to judiciously discuss with the patient. In a receptive patient who can afford, who has the ability, we should discuss the lung transplantation prospects right at the time of diagnosis, so that when the time comes to refer the patient is mentally and logistically prepared to go for it. So it should be definitely offered to all the deserving patients. However, logistic issues remain, and probably in future, lung transplantation will be more widely available for our IPF cases. Palliative care is something that we have to understand. A time comes when the patients advance, or when they develop acute exacerbations. These patients, they do quite badly with invasive ventilation, and the outcomes are not very good when they come to high levels of respiratory support. So palliation should be discussed with the patients, and it is sometimes futile to be very aggressive in advanced IPF cases when they develop acute exacerbations. I'll not discuss much lung transplantation today because of paucity of time, but a little word about pulmonary rehabilitation. So it has been shown, we have meta-analysis data to suggest that pulmonary rehabilitation works in IPF patients. Not only the exercise capacity improves, but also objective goals like improvement in the oxygen uptake and the peak work capacity. It improves with pulmonary rehabilitation across studies. And the objective exercise improvement is there. Dyspnea scale improves, fatigue scale improves, and also psychological issues like emotional scale and depression, everything improves by using pulmonary rehabilitation in this patient. Especially when we have limitations in pharmacotherapy, this is something which we can offer to all our patients. So 8 to 12 week structured program, it has been shown to give significant symptomatic as well as exercise capacity improvement to patients, especially when aerobic exercise is complemented with breathing exercises or inspiratory muscle training. And it can also reduce psychological distress. So this is something which we have to offer our patients when the pharmacological therapy, especially because pharmacotherapy is not very effective. Also, like I said earlier, these patients are old and most of them, they have got comorbidities. Most of our IPF patients, they're smokers. It's a disease which is associated with smoking. So smoking related other problems like COPD, lung cancer, cardiovascular diseases, they're common in these patients and they have to be optimally managed if we want the overall health related quality of life to improve. Especially CPFE, combined pulmonary fibrosis and emphysema, is a big problem, and almost 30% cases of IPF may have a CPFE problem, especially the smokers. So these patients, they have higher level of symptoms, more pulmonary hypertension, higher mortality, and more refractory to treatment. So these patients, they have to be treated, and unless we give a holistic treatment to all these disorders, they won't improve. Also, we have to take care of pulmonary hypertension, but not with systemic pulmonary vasodilators, like I mentioned earlier, by oxygen therapy. And sleep apnea, pulmonary embolism may occur in these patients because of prolonged immobilization. Frailty is an issue. Most of these patients, they are osteoporotic, old, multiple problems. So frailty has to be addressed, and sometimes because of frailty itself, they are not able to tolerate the antifibrotics that we have to offer, and we have to look after all these issues. GERD is something that requires attention because a lot of these patients, they got GERD. It was believed that GERD might be one of the risk factors that can cause IPF, and in the earlier recommendations, it was recommended that all these patients should be given treatment for GERD. But however, now we know there was a RAP IPF trial by the Raghu group, and thereafter several studies, and now we have meta-analysis data, and we also have data from observational studies which shows that treatment of asymptomatic acid reflux does not help, neither by pharmacotherapy nor by surgical therapy. So if the patient is having symptomatic reflux, symptomatic GERD, he must be treated as we would do for any GERD. But asymptomatic patients should not be treated with antacid medicines or anti-reflux surgery because it has got no benefits in IPF. It might even cause harm. So anti-reflux therapy or anti-reflux surgery should be offered only if the patient is symptomatic. Now, management of exacerbations. So acute exacerbation of IPF is something that is devastating for the patients. And the current definition says that acute exacerbation may not necessarily be idiopathic. Even an exacerbation because of an infection or because of any other inciting factor is an acute exacerbation, because acute exacerbation because of any etiology would mean the same for the patient. It may make the patient significantly lower than what he started with. It may even change the disease trajectory and the patient may rapidly worsen after that. So acute exacerbation is devastating, but unfortunately, till now, we only know what does not work. We have no idea what works. So there is paucity of randomized controlled trial data here, but we know that corticosteroids may worsen survival, and high dose steroids and corticosteroid data may not be helpful in acute exacerbation of IPF. Similarly, cyclophosphamide, thrombomodulin alpha has anti-inflammatory and antifibrotic properties, and these also may worsen the patient. They may increase mortality. So as of now, the only thing that we can offer when the patient comes with acute exacerbation is good supportive treatment, do no harm. So manage the infection, manage the infection appropriately, give supportive therapy, prevent lung damage, same way we manage our ARDS patients. So do no harm is the only policy, but we do not have a definite solution for acute exacerbations. But supportive therapy may work. Mechanical ventilation, especially invasive mechanical ventilation, but also NIV, is not very helpful in these patients, and they do not tolerate it well, and the mortality is significantly high when these patients, they require any form of mechanical ventilation. So I come back to the initial slide that this multi-modality treatment we have to offer preventive aspects like vaccination to all the patients. Rehabilitation has to be given to all the patients. Oxygen when required. Comorbidity should be routinely addressed. Medical therapies in the form of nintedanib and pirfenidone, and lung transplantation and palliative care whenever the time comes, that has to be offered to the patients. In future, we may have other drugs So like combination therapy I mentioned, in future we may have combination therapy and we may have a role for it. As of now, the data is still evolving. Phosphodiesterase 4B inhibition is being studied and the initial data is promising. So PD4B inhibition, it prevents degradation of cyclic AMP, and that may have an anti-fibrotic and anti-immunomodulatory effect, and that may come up in future. Pentraxin 2 also may have a role. Pentraxin 2 inhibits monocyte differentiation into pro-fibrotic fibrocytes and pro-inflammatory macrophages, and that also the initial data has shown some promise, but the data is still evolving. Pamrevlumab is something of monoclonal antibody against connective tissue growth factor. The initial data has not been very promising. The initial RCTs have been negative, and therefore we have to see whether this drug will come anytime in the treatment paradigm of IPF or not. Stem cell therapy, the animal studies have not shown very good efficacy, and human trials are awaited. Again, a promising tool, but the initial data is a little disappointing. So these things may come in future. Even biomarkers, currently we do not have any biomarkers to understand who will progress, who will not progress, what level of disease we are in. But biomarkers are also being studied. Biomarkers of alveolar epithelial injury like SPA, SPD, and KL6. Biomarkers of extracellular matrix remodeling like MMP7, periostin, osteopontin, then blood gene expression blood gene expression signatures like telomere length of the leukocytes, and then peripheral blood monocyte count. They have also been found to be associated with disease progression and all-cause mortality. So in future, these biomarkers may have an important role to play to understand where in the trajectory of natural course the patient stands, what is likely to happen in future, how aggressive should be with the treatment, and to prognosticate the patients. So finally, the take-home messages are, we have to understand our goals of treatment. To check progression of the disease, what we have is nintedanib and pirfenidone, complemented with oxygen therapy when required, adult vaccination, and to avoid exposures which may cause worsening of the disease and acute exacerbations. So just like hypersensitive pneumonitis, it has been seen that exposure to organic antigens may worsen even IPF. So noxious exposure should be avoided. Smoking cessation should be ensured, and with rising pollution, even that may be a threat in these patients. Then to improve overall health-related quality of life, rehabilitation, oxygen therapy, and optimal management of underlying comorbidities. Symptom management, this is the big question, because the drugs that we have, they do very little to give symptomatic management. So antitussives may be required, pulmonary rehabilitation, breathing exercises for dyspnea management. And when the time comes for palliation, maybe opioids, and sometimes even off-label use of drugs like pregabalin might work in dyspnea management in the palliative stage. Then mitigate risk factors. So smoking cessation has to be done. GRD management may have a role, but again, only in symptomatic patients. In asymptomatic patients, GRD management may not help. And do discuss with all the patients the transplantation, palliation right at the time of diagnosis, so that when the patient progresses, if he progresses, the patient is mentally and logistically prepared for these options. So this is all about management of IPF, and I'll be happy to take any questions.
Thank you very much, Puneet. You can unshare your slides now. Yeah. So we'll take up the questions at the very end. Are you able to hear me?
Yes, sir.
Yeah, so we'll take up the questions at the very end of this session.
Right, sir.
So I'll rather proceed with the next speaker. And the next topic is organizing pneumonia, which the lecture will be delivered by Dr. Abhishek Goyal. He is one of my favorite seniors from the Department of Pulmonary Medicine at PGI. We were doing our MD, our DM Pulmonary Medicine together, and he is currently working as additional professor of pulmonary medicine at AIIMS Bhopal. Dr. Abhishek, are you there?
Yes, I'm there. Are my screens, the slides visible?
Just a minute. No, I can't. They are not visible. It is
I will
a
do it
blank. Yeah, please connect again.
Is it visible now?
Yeah, it's visible. Can you move it a bit to the next
Yes,
slide?
I think.
Yeah,
Yes.
it's moving. Yeah.
Okay,
So
thank
we
you,
can start.
Sajal, and thank you to INPF team for giving me this lecture. Good afternoon to all. Continuing the series of IIPs, I will be talking about a lesser known and lesser investigated IIP, that is organizing pneumonia. There has been a significant change in the name of this disease. So now we are seeing that these are named. There are significant changes in the name of the disease. Wegener's is now called as GPA. Churg straws like eGPA. Hetch's sign is now called as 3-density sign. So similarly, the name of COP, the cryptogenic organizing pneumonia, and BOOP, bronchiolitis obliterans with organizing pneumonia, was used interchangeably in last half of century. But since this disease was not investigated enough and we did not know much about the etiology, so the term COP was used preferentially as compared to organizing pneumonia, which is the currently used term. Since as more and more research is being done, we are knowing that most of the causes of this etiology can be known if we investigate the disease properly. So the term is organizing pneumonia, organizing and pneumonia. So most of the pneumonias are usually organizing in itself. But what differentiates this from the community-acquired pneumonia is that this is a diffuse interstitial lung disease which arises from injury to the alveolar wall. It is a disease which usually starts on the alveolar wall, but it causes some injury around the parenchyma also. And it is characterized by the typical presentation on a CT scan, which I will be describing, and has been discussed in this morning lecture by Dr. Ashu also. And the most important thing is, it is one of the rare IIPs which usually responds very well to systemic glucocorticoid therapy. So that is one of the most important features which differentiate it from other IIPs. So in the IIP, it comes under the acute or subacute because it presents like this. And the cryptogenic organizing pneumonia, or now the organizing pneumonia, is now the cryptogenic organizing pneumonia comes under IIPs, and organizing pneumonia if it is due to some infections, which I'll be talking later on. So this is extensive list of what causes secondary organizing pneumonia. So most often now we see that we are getting more and more CTs for viral infections. So we are now seeing a pattern which closely mimics that of COP. The most important causes which have been enumerated are the bacterial infection, the atypical organisms like Legionella, Mycoplasma, Coxiella, the common one like Streptococcus, Staphylococcus, and Pseudomonas, all can cause a pattern which mimics that of organizing pneumonia, the CT pattern. The viral we had seen in the first and second wave of COVID that we did extensive CT scan for these patients, and the pattern which closely mimics that of organizing pneumonia or even fibrotic NSIP, which I will be interpreting in the last part of this lecture. Even malaria and fungi can have a similar kind of CT pictures. Now, drug-induced ILD will be talked about in tomorrow's lecture, but drug has also been postulated to cause organizing pneumonia. Most important drugs which needs to be asked is amiodarone, nitrofurantoin, bleomycin, and methotrexate. So in a relevant settings, connective tissue disease is probably the most important disease which needs to be ruled out in patients of organizing pneumonia. The most important the disease which can cause organizing pneumonia is polymyositis or dermatomyositis. Apart from that, Sjogren syndrome and RA can also lead to CTDs. And antisynthetase syndrome should be ruled out if in the relevant settings only. Also, leukemia, lymphoma, post-transplant setting, post-radiation setting, and immunodeficiency can also lead to organizing pneumonia. So we can see there is a long list of diseases which can lead to organizing pneumonia. And if we have a secondary cause, then it is known as secondary organizing pneumonia. If we cannot find any cause, then it is now called as cryptogenic organizing pneumonia. So what we know about cryptogenic organizing pneumonia from the literature, whatever available, is that it usually presents in 5th or the 6th decade of life and usually doesn't present before adolescence. It is usually seen in both male and female, although it is a rare disease, the few studies about cryptogenic organizing, few studies which have shown that the prevalence of cryptogenic organizing pneumonia was around 5 to 10% of all the ILDs. And smoking in earlier literature was said to be slightly protective of cryptogenic organizing pneumonia. So the pathogenesis is not completely known, but what we know as of today is that it is a reversible disease. It is an inflammatory disease, and it leads to fibroproliferative state. It is just like IPF in some aspect, but it is kind of self-limiting. That's where it differentiates from IPF. So in this picture, we can see in the on the low down the A, this suggests there is some injury by infection, by drug, or any other cause, which leads to leakage of plasma protein and recruitment of fibroblast. This leads to organization, then it leads to further recruitment and proliferation of fibroblast and myofibroblast. And it ultimately leads to a fibro-inflammatory buds, which are known as Masson's buds. But this disease is unlike IPF, where also there is some kind of fibroblast proliferation. This disease is self-limiting in some cases, can be, and after treatment, the disease remodels, and most of the things from this fibroblast are usually cleared in histopathology if it is being done. So this H&E stain shows there's a polypoid mass of granulation tissue inside the respiratory bronchiole, and this was a Mason polyp inside the alveoli. So the usual presentation of this disease is like any other IIPs. The symptoms are most commonly it is dry cough, dyspnea, and fever and malaise and weight loss are seen in roughly half of the patients. The important presentation which should when it should be suspected is when the patient has a non-resolving pneumonias, or when patient has recurrent pulmonary infiltrates, fleeting opacities, and when these do not improve with the usual antibiotics. So that is the case when organizing pneumonia should be suspected. In 50% of these patients, the literature says that flu-like illness is usually present with fever and malaise, which may last for weeks, or after that, fatigue and cough may persist. And usually, the important thing is the antibiotics usually do not improve these symptoms. On examination, bilateral basal crackles can be there in half of the individuals. Clubbing is very rare. So, although there is nothing which can on examination can signify whether this can be due to organizing pneumonia, but the most important thing is history taking, and as mentioned earlier, connective tissue diseases, the history of CTD, which will be tackled in a separate session in afternoon, needs to be done in all patients in whom we are suspecting OP. The detailed drug history should be taken, and history of any recent exposure to irradiation, significant fumes or dust should be taken in all these patients. The laboratory exam, although it is non-specific for most of the individuals, the acute inflammatory markers like ESR and CRP can be raised. If a patient has some history suggestive of CTD, then obviously ANA with ENA reflex should be done in carefully selected individuals. Myositis profile can be done, but sometimes patient may have no clinical features suggestive of CTD, and they can have pattern suggestive of organizing pneumonia. And we now do more and more ANA profile in these patients who have a pattern of OP and do not fit with any other cause. And sometimes we also pick patients of CTD, even they don't have a clinical picture. So a pulmonary function test suggests restrictive pattern on spirometry, reduced diffusing capacity, and low saturation. These are usual clinical features which does not differentiate from any other IIPs. The most important feature is the radiology. In the classical description of organizing pneumonia is bilateral, basal, peripheral, patchy consolidation, which is usually seen in the lower lobes. But sometimes it can be seen uniformly also. The consolidation can be, it can be dense consolidation, or ground glassing can also be seen. Sometimes only nodules can be seen throughout the lung. This is also a less commonly seen picture. Sometimes only GGOs are seen in perilobular areas. Sometimes even atoll sign can be there. Just like on this picture, reverse halo sign can be seen in organizing pneumonia. But the most important, the classical description is peripheral patchy lower lobe distribution of consolidation or GGO, which are relatively denser in consolidation. Denser. Sometimes we also have overlap of OP and NSIP, which is usually seen in patients of CTDs and most importantly synthetase syndrome. And it should be ruled out in this subset. Most commonly polymyositis, dermatomyositis should be ruled out. Then some drugs can also lead to similar kind of overlap, and rarely HP has been reported to cause this kind of overlap picture. The bronchoscopy, although is not required in most of the individuals, sometimes it has to be done to rule out infection. And also CP, chronic eosinophilic pneumonia, can almost mimic the radiology picture of organizing pneumonia. CP also has bilateral peripheral patchy opacities. Diffuse alveolar hemorrhage can be ruled out on the basis of BAL if it is suspected. Although after MDD, most of the cases of organizing pneumonia can be suspected, and most often we usually treat with immunosuppressives. But if MDD, even after MDD, we are not sure that it fits with organizing pneumonia, histopathology can be done. Although literature is not very supportive which kind of biopsy should be done. Most of the patients, in hospital setting now, cryo-TBLB is being done for patients if it is required. Open lung biopsy, as Dr. Vijay mentioned in last lecture, that probably the patients are not that well preserved in condition in which we need to do biopsy. So which kind of procedure should be done, it depends upon the patient's preference and the institute policy. But if histopathology is done, the usually classical picture is showing the cryptogenic organizing pneumonia is a kind of granulation tissue within the alveolar duct, which is called Mason's polyp. And there are also some variants in this organizing pneumonia. The rare variant is a focal organizing type, which is localized to a particular segment, which is usually not progressive, and there is no significant treatment which needs to be done. Some reports say that only removal of that particular area is sufficient for the treatment. There is a fibrosing type, which usually behaves like fibrotic NSIP, and for that antifibrotics can be given, although there is not much literature on this. There is another fulminant type variety, which usually we see in our ICUs, and most commonly it is with secondary causes. We have seen this kind of patients in COVID and also with other viral pneumonias. After infection has been ruled out, only then steroids should be given. So there is a long list of differential diagnosis. Community-acquired pneumonia is the most important one, which needs to be differentiated before giving for immunosuppressive. Hypersensitivity pneumonitis, chronic eosinophilic pneumonia can have the similar kind of radiological picture. As I mentioned, bilateral patchy peripheral GUs can be seen. Diffuse alveolar hemorrhage can have bilateral basal consolidations, but they have a clinical picture of probably hemopsis, low hemoglobin or a hemoglobin drop, which can support a diagnosis of DH. And then if it is suspected, then BAL needs to be ruled out to rule out DAH and CP. Bronchial alveolar carcinoma can also have a radiological picture, just like organizing pneumonia, and for that, if it is suspected, then we need to do a histopathological approach by using a TBLB, cryo-TBLB, or open lung biopsy. As I mentioned, OP NSIP, if the pattern is there on CT, then CTD, synthetase syndrome, and drug-induced ILD should be ruled out. Now, coming to treatment, as such, there are not much literature available regarding the RCTs of organizing pneumonia, because it has not been extensively evaluated disease as like other IAPs like NSIP or IPF. Most studies have shown that some patients may improve spontaneously. If patient have significant restriction, or they have dyspnea or persistent cough, then empirical steroids is usually started, and most of these patients usually responds very well to this therapy. The usual dose is 0.5 to 1 milligram per kg with a maximum dose of 60 milligram per day, usually given for a month and then taper over next 4 to 6 months. If patient presents in ICU requiring high oxygen support like high flow nasal cannula or an IV or invasive mechanical ventilation, then pulse steroid is given from 0.5 to 1 milligram of 0.5 to 1 gram for 3 to 5 days, and then IV drugs is continued in a lower dose, and then as and when patient improves, then the patient is switched to oral drugs. Whenever the dose of steroids is reduced, the relapses can happen in these patients. The relapses have been reported to in the tune of 15 to 20% of the patients. And then whenever the dose is reduced, you have to approach whether you can increase the dose of steroid or you can give steroid sparing agents. The treatment is almost like how we treat an NSIP as far as immunosuppressive is concerned. The option of immunosuppressives are mycophenolate, which is now preferred. And also there are other therapies like rituximab, cyclophosphamide, azathioprine. The dose is almost similar, which has been described for NSIP. Prognosis is relatively good for most of the cryptogenic organizing pneumonia, and most usually recover steroids. However, the patients who present with infections, that entirely depends upon the patient, the condition of the patient. Patient may or may not improve with steroid, and if patient has infection as underlying cause, probably may worsen with steroids. So in the last, I would like to bring to your notice that we all have done we have seen many CTs for COVID-19 patients, and we saw this kind of pattern which closely mimics that of organizing pneumonia. There were kind of bilateral patchy GGOs and consolidation seen in most of the individuals. And as we can see, this pattern almost mimics that of the classical organizing pneumonia or the COP pattern, which has been reported in literature. There are also studies which have shown that post-COVID organizing pneumonia can persist with the similar kind of presentation of shortness of breath, impaired function test, although the symptoms improves over few months. But some patients now we are seeing are presenting with progressive opacities or fibrosis even after a few months. The study done by Dr. Sjogren last year, in which he compared high dose versus low dose, that is 40 milligrams steroids and 10 milligrams steroids, where the study showed that the dose of 40 was almost equivalent to 10 milligram dose as far as the post-COVID diffuse parenchymal abnormalities was concerned. And giving a high dose of steroid for post-COVID organizing pneumonia or any kind of post-COVID changes need not to be done, and only low dose of steroids was sufficient. And this kind of CT, as we are routinely seeing in COVID and routinely seeing in patients of H1N1 and also other viral infections. So the pattern is almost same, bilateral patchy peripheral opacities. With some patients can also have a kind of fibrosis, like we are seeing in is the right lower picture, lower picture of some fibrosis is seen. Some band-like fibrosis is also seen in post-COVID changes after following for a few months when the patient have organizing pneumonia in the initial part, but later on they can have band-like fibrosis or some fibrostic NSIP or can have traction bronchitis. And some patient can also have atoll sign in these post-viral CTs. So to summarize, organizing pneumonia is usually secondary, as we are doing more and more CT in our patients who's presenting with persistent cough and shortness of breath after some suspected viral infections. Early identification is the key. In patients with right clinical radiological picture, we should extensively evaluate and rule out common causes, and most important is connected to disease. Cryptogenic organizing pneumonia is usually easily treatable IIPs with relatively good prognosis compared to other IIPs like NSIP and IPF. And steroid is the first line. Sometimes we have to use steroid sparing agents in patients who have a relapse. And usually, in my experience, we do not have to give long course of steroids in this kind of IIP. Thank you so much.
Thank you very much, Dr. Abhishek. Please stay back for the questions at the end of the session. And next we have the last talk of this session, which is on smoking-related ILDs. So it includes respiratory bronchiolitis, desquamative interstitial pneumonia, etc. And for that, I invite Dr. Kavita, who is DM Pulmonary Medicine from AIIMS, New Delhi. She's currently working as Associate Professor of Pulmonary Medicine at the St. John's National Academy of Health Sciences. And her areas of interest include chronic respiratory diseases, including ILDs and sleep medicine. Over to Kavita.
Is my slide visible?
Yeah, slide is visible. Can you move it a bit to the next slide? Can you go? Yeah, it's moved. Okay, right.
Okay.
You can start. Thank you.
So, good afternoon, everyone. So this is the last talk of this session. It will be a very short and crisp talk because the topic is RB-ILD and DIP, about which not much is known, unlike the other ILDs that we have listened to in the last few talks. So I have restricted this talk to RB-ILD and DIP. I will not be covering all the smoking-related ILDs, including the cystic ILDs. So when we talk about smoking-related ILDs, we have a few ILDs that are specifically associated with smoking. Though a causal relationship has not been established, we still think that smoking has a very strong association with these ILDs, of which we will be talking about in detail today, that is desquamative and interstitial pneumonia and respiratory bronchiolitis associated ILD. And Langerhans histiocytosis, pulmonary Langerhans histiocytosis is also a part of that. Some ILDs which may be precipitated by smoking but may not be really caused by smoking include acute ILDs, which can be acute eosinophilic pneumonia and pulmonary hemorrhage syndromes, especially Goodpasture's syndrome. And ILDs may also be, other ILDs may be precipitated or they may be exaggerated in prevalence by smoking, which includes IPF and rheumatoid arthritis ILD. So, like I said, not much is known about these smoking-related ILDs because most of the knowledge is based on case reports and case series. Not much evidence-based management or diagnosis exists, unlike IPF and other ILDs. So, there is a lot of confusion about the nomenclature of these ILDs, whether RB-ILD and DIP are two different entities or do they form the same spectrum of the disease is still a debatable issue. There are a variety of terms that are used to describe these, and in the absence of large series and evidence-based data, like I said, most of the knowledge is from anecdotal case reports. So whatever knowledge is available, we will try to understand that today. So how does smoking cause these ILDs? A short brief note on how it is likely to cause. Not much is understood, but whatever is understood, it is probable that along with smoking, there are some exogenous factors also, including genetic factors, which can influence the development of these ILDs in patients. A lot of toxic chemicals that are present in smoke, as you all know, nearly 5,000 toxic chemicals is what is said, will induce inflammation in the airways as they are inhaled. And most commonly, these inflammatory cytokines that are produced, I'm not going into the details of all the cytokines, but the well-studied ones are GM-CSF and TGF-beta. So as we all know, TGF-beta will promote fibrogenesis and GM-CSF is known to recruit macrophages. So one of the hallmark findings in both these ILDs, RB-ILD and DIP, is accumulation of pigment-laden macrophages in the airways. So this is one of the cytokines that is responsible for this recruitment of the macrophages to happen. Obviously, when we inhale something, the lung wants to get rid of that toxin. So macrophages are recruited to engulf those toxins and lymphatics will get rid of these macrophages. So most of the inhalational ILDs, if you see, are upper lobe predominant, which is true about RB-ILD also, but not really the case with DIP. Now, when macrophages are recruited, I said that most of the inhalational ILDs are upper lobe predominant, like hypersensitivity pneumonitis or other pneumoconiosis. That is because though ventilation is much more in the lower lobes, there is better lymphatic drainage in the lower lobes. So probably the clearance of these toxins is better from the lower lobes. So upper lobe predominance happens. So macrophages are recruited and fibrogenesis happens, which leads to like I said, bronchiolar inflammation, accumulation of pigment-laden macrophages, and interstitial inflammation and fibrosis in varying degrees, which will help us in differentiating RB-ILD from DIP, which we'll see in the future slides. One thing that smoking is probably, I can't say helpful because we cannot start asking patients to smoke, but in some ILDs like hypersensitivity pneumonitis and sarcoidosis, it has been seen that smoking probably has a protective role. The possible explanation for this is that there is decreased IL-12 production and decreased Th1 polarization of the macrophages. So as we know, sarcoidosis and HP need Th1 predominant inflammation for the granulomas to form. So once this is decreased or inhibited, that probably leads to decreased granuloma formation, and that Th1 mediated response is not there. That is probable explanation for them being protective against these ILDs. So coming to RB-ILD, there are two entities that we need to understand here. One is respiratory bronchiolitis and the other is RB-ILD. Again, like I said, are they two different entities? We don't know. They probably are the same spectrum of the disorder. Respiratory bronchiolitis is seen in almost all smokers if you take a lung biopsy from smokers. So it is also called a smoker's bronchiolitis. It is almost a universal phenomenon in all the airways of smokers. We saw the pathogenesis in the previous slide. It is probably because of that. It is just an inflammatory response that you see histopathologically. The patient may not be symptomatic and the lung functions may be normal, or there may be very mild derangement in lung functions. Then why do we do a biopsy in these patients? It is mostly seen in patients who have undergone a biopsy for some other reason, or especially in patients with lung cancer in whom lobectomy has been done. In them, the histopathological finding has been proven, and most of the smokers will probably have this respiratory bronchiolitis picture. How does it look? I'll show in the future slides. RB-ILD is something that is probably a bit more extensive than respiratory bronchiolitis. It is just not a histopathological finding, but the patient may be symptomatic. One of these may be there. Patient may have clinical symptoms. Patient may have lung function abnormalities, which may be either of them, obstructive, restrictive, or a mixed pathology. There is derangement in diffusion capacity, and some concurrent radiological abnormalities also may be seen. Either of these four, along with a respiratory bronchiolitis pattern on histopathology, should prompt a diagnosis of RB-ILD. So the radiological pattern in respiratory bronchiolitis or in RB-ILD will predominantly be, like I said, upper lobe predominant, mostly few GGOs, if you can make out here, not very classical findings like you see in HP or in other GGO predominant NSIP or something. It will be restricted to the upper lobes or maximum to the middle lobes and lingula. It will be very subtle GGOs that are present, or they may be centrilobular nodules. Like it was shown by Dr. Ashu in her talk, when we talk about respiratory bronchiolitis, there is accumulation of pigment-laden macrophages in the bronchioles. So whenever the bronchioles are involved, bronchioles are studded, you get centrilobular nodules as the finding on the CT. So there are subtle centrilobular nodules and ground glass which may be present. If this picture is associated with clinical features or lung function impairment, like I said, or with some amount of fibrosis that you can see on the CT, then you may make a diagnosis of RB-ILD. Coming to desquamative interstitial pneumonia, it is considered a misnomer because initially it was thought that it is because of desquamation of the alveolar epithelial cells that are getting collected in the alveoli. But now we know that it is not the alveolar epithelial cells, it is the macrophages that are collected. So these are again pigment-laden macrophages. The better terminology that is now proposed is alveolar macrophage pneumonia, but we still continue to use DIP as an accepted term. So alveolar macrophage pneumonia, like the term itself says, there is accumulation of alveolar macrophages inside the alveoli, not just restricted to the respiratory bronchioles like we saw in RB-ILD. So if there is more diffuse involvement and more accumulation in the alveoli and the airways, then it becomes DIP. Most of these patients are smokers, but there are other causes of DIP also, which are not smoking related. So taking history of exposure and ruling out other CTDs and drug-induced etiologies is very important. So it can be CTD associated. There can be drugs that may cause DIP, viral infections which may cause DIP. DIP is also a common phenomenon seen in childhood ILDs, where there can be surfactant protein mutations that can cause a DIP kind of a picture. So it is not always smoking, but 80% of the cases may be smoking related ILDs. One of the we can't say it is present in every patient, but something that is more common in DIP compared to RB-ILD is clubbing in patients. So clubbing is more common in DIP than with RB-ILD. So when we come to radiology, like I said, most of the inhaled ILDs are upper lobe predominant, but DIP is something that does not follow that rule. The reason for this is really not known. It is not given in literature why it is lower lobe predominant, but it is a lower lobe predominant ILD. Another inhalational ILD that you can think of, which is lower lobe predominant, is asbestosis in pneumoconiosis. Otherwise, most of the inhaled ILDs or pneumoconiosis are upper lobe predominant. So if you see here, compared to what we saw in RB-ILD, the ground glass is much more than what we saw. It is more definitive than what is seen in RB-ILD. There is some evidence of fibrosis also. There is lower lobe predominance. Here, the lower lobe predominance of the ground glass is much well made out in the coronal section. And you can see the diffuse ground glass that is there in the lower lobes. As the patient progresses, you can see some amount of fibrosis also setting in. And once fibrosis sets in, it's very difficult to differentiate it from NSIP. And like it was told in the morning in the radiology session, there can be some cysts that can be seen within the areas of fibrosis and ground glass. So cysts, ground glass, and some amount of fibrosis can be seen. So as you have noticed, the clinical presentation is very similar to any other ILD: cough, progressive dyspnea. PFT may not give us a definite diagnosis. Radiology, again, is not very specific for these RB-ILD or DIP also. So a biopsy or a pathological diagnosis may be required in most of the patients where you do not have a definitive diagnosis. BAL or bronchoalveolar lavage, the cytopathological examination of it may be helpful in giving a diagnosis when you see exuberant accumulation of these pigment-laden macrophages that you are seeing here. So you can see that there are macrophages which have golden brown pigment accumulated inside them. So if this is there, then a biopsy may be avoided because you have the history, you have radiology, and you have this classical finding that you're seeing. So most of the patients, the characteristic BAL finding that you can see in DIP and RB-ILD would be exuberant, this characteristic pigment-laden macrophages that can form the majority of the cellularity of the BAL. Unlike other ILDs, where lymphocytosis is common, it is characteristically absent here. So you will not see many lymphocytes in patients with smoking-related ILDs. You will see pigment-laden macrophages and some neutrophils or eosinophils may be present, but lymphocytosis is characteristically absent. If you go to biopsy, I have put both these together for comparison's sake. This is the middle one is RB-ILD and this is DIP. So as you can make out, the accumulation of macrophages in RB-ILD is restricted to the respiratory bronchioles and not much in the alveoli. You can see the surrounding alveoli are clear, or there may be some amount of emphysema. But here in the right extreme figure, which is a case of DIP, you can see extensive accumulation of pigment-laden macrophages, which is characteristic picture of DIP, and there may be some alveolar septal thickening also. So this is the histopathological difference between the two. More extensive and diffuse involvement is likely a picture of DIP. Higher power magnification of the same, showing alveolar deposition of the pigmented macrophages. So like I said, most of our understanding is from case reports and case series. This should give a clue of how rare the disease is, and it is not probably encountered very often. One reason may be that the patients may not be very symptomatic, so a diagnosis may not be made, and the other may be that biopsy of these patients is probably not considered because they are mildly symptomatic. So one of the extensive or comprehensive reviews of DIP that we have is 362 cases, and including case series and case reports from 1965 to 2019. These are all histopathologically proven cases. So they are predominantly seen in males, obviously smoking predominant, so it is likely to be predominantly seen in males. Lung functions were characteristically normal in nearly 20%. And like I said, ball pigment-laden macrophages, which form the predominant cells in the ball, up to 60 to 98% of the cells may be just pigment-laden macrophages. So that is important for the diagnosis. The treatment that was given in most of these patients includes steroids. Most of the time, just smoking cessation itself is probably helpful in reverting the findings that are seen, or the lung functions may also normalize if they are very subtle and very mild. Just smoking cessation should be helpful. Or if the patient is symptomatic, then steroids may be given. Steroids, again, we don't know what dose should be given. There is no evidence, but most of the studies have used from 15 milligrams per day to nearly 1 gram per day, depending on the acuity of the presentation and symptoms of the patients. Again, the duration is not known. 2 weeks to several months have been used. Steroid-sparing agents like azathioprine and cyclophosphamide have been used in few cases, but it may not be really essential because most of the patients would respond to smoking cessation and steroids alone. Non-smokers and women have a poorer outcome. We saw that there are other non-smoking etiologies also for DIP. So non-smokers and women were found to be having poorer prognosis. And like it was thought earlier, DIP is not really that benign. Nearly 25% of the cases may progress and it may lead to death also. What biopsy? Again, most of the time, surgical lung biopsy is what was considered a gold standard, but like they have enumerated for other ILDs, now cryobiopsy for smoking-related ILDs has also been studied in around 40 in a series of 45 patients in which all smoking-related ILDs were studied. 43 out of 45 were diagnosed based on cryobiopsy itself, showing that the yield has been very good with cryobiopsy also. So comparing the two, what I have already mentioned, most of the cases are seen in males, but DIP is more male predominant. Clinical features and PFT are not very significantly different from other ILDs, will not help you make a definitive diagnosis. BAL is something that will help increase macrophages and pigment-laden macrophages seen in both. The histopathological finding that is different in between these two are, like I said, this is predominantly in the respiratory bronchioles, and this is more diffuse and entire alveolus may be filled with these macrophages. Radiologically, again, RBILD is more upper lobe predominant, and GGOs and centrilobular nodules are seen, and DIP is a lower lobe predominant, and fibrosis may be more commonly seen with DIP than with RBILD. Spontaneous improvement is known to occur with smoking cessation with both of them, and steroids may be more required in DIP rather than RBILD. Treatment, like I've already mentioned, smoking cessation is the most important treatment. Steroids and immunosuppressants are required in a subset of these patients who have more extensive involvement and are more symptomatic. Lung transplant has also been done for a few cases where it has been so extensive and has failed to respond to these treatments. Another entity which Dr. Ashu just touched upon during the question answer session was smoking-related interstitial fibrosis. I've just put this up because the radiological appearance is something that we need to understand. Again, variable terminologies are used: airway enlargement, airspace enlargement with fibrosis, smoking-related interstitial fibrosis, respiratory bronchiolitis with fibrosis, or RBILD with fibrosis. Many terminologies are used, but now the accepted or probably the better terminology is smoking-related interstitial fibrosis. Like you can see, this is not typical honeycombing. Like it was mentioned, it is lower lobe predominant, but this is not typical honeycombing because it is more like a conglomeration of emphysematous spaces with some amount of fibrosis, which helps you understand that the interstitial thickening is there, but this is not honeycombing, and it is not that thick-walled as honeycombing is, and not as small as honeycombing. It is much bigger than honeycombing and looks more like a conglomeration of emphysematous areas with some fibrosis. So this is something that we need to keep in mind when we make a diagnosis of ILDs also. Another radiological picture showing the same thing, airspace enlargement with fibrosis. So I am going back to my first slide where I said different terminologies are there. There are overlapping descriptions. The pathology and the radiology is overlapping. We don't know if they are the same entities or different entities. So a lot of debate is still going on about it. If you can see this CT here, you have all the findings here. You have emphysema, you have airspace enlargement with fibrosis, you have some nodules here, and some amount of ground glass. So in the same patient, you can have all of them coexistent also. And smoking cessation is one of the most important interventions to be done if the diagnosis is made in these patients. Thank you.
Thank you very much, Kavita. Very nice lecture. So we have not heard much about smoking-related ILDs in various ILD sessions and workshops. So it was quite an eye-opener for many of us. So now we will come to the discussion for the entire session of idiopathic interstitial pneumonias. And I will request all panelists to be present. They may switch on their videos and they may unmute themselves whenever they want to answer a question. So I'll take up the first question, which is from Dr. Ankur Gupta. And I will pose this to Dr. Alok if he's there. If he's not there, then Dr. Puneet can take up the question. If UIP pattern is seen on CT, but the age is less than 70 years, what will be the diagnosis? Dr. Alok?
Hello.
Yeah. Yes, sir.
Yes, Sajal.
Can you take the question? The question is, sir, if there's a UIP pattern on CT, but the age is less than 70 years, then what will be the diagnosis?
If there is any pattern.
No, UIP pattern is there on the CT, but the age is less than 70. So the attendee has put it 70. It must be rather 55 or 60 because even less than 70.
The person he means to say that if a patient has UIP pattern and you have a patient who's a younger age. So actually age is not a very mandatory criteria for making a diagnosis or ruling out a criteria of idiopathic pulmonary fibrosis. In general, if in presence of UIP pattern, if a person is less than 50 years of age or less than 45 years of age, you become more cautious in finding out other etiologies of UIP pattern, like underlying connective tissue disorder or presence of inorganic dust exposures or chronic hypersensitivity pneumonitis, which can sometimes present with UIP pattern. So in a patient with a younger age who has a definite UIP pattern, one should be just careful in making a diagnosis of IPF by excluding other known causes of idiopathic pulmonary of UIP pattern, so that actual or quote unquote idiopathic can be labeled. Sajal, unmute.
Yeah, so we'll take up the next question. Live, yeah. So once you have a low predominant fibrosis dominant pattern, that is probable UIP or indeterminate UIP, is there any additional advantage in going for a biopsy in terms of patient benefit, whether in quality of life or progression-free survival? Dr. Alok, can you take it? If there is a probable UIP pattern or an indeterminate for UIP pattern on the CT, is there any advantage in doing a biopsy? Puneet, will you like to take this question?
So come again, sir. Can I hear the question again?
Yeah. So if there is a probable UIP or indeterminate for UIP pattern on the CT, is there any benefit in doing a biopsy in terms of patient prognosis or improving quality of life or progression?
Definitely there's a benefit. If the patient is fit enough to undergo a biopsy, we must go for a biopsy and possibly a cryobiopsy or a surgical lung biopsy, because diagnostic confidence in a probable or indeterminate forms is very low. And sometimes after the biopsy with an MDD, the diagnosis may completely change. And that is important because the treatment of IPF and non-IPF ILDs are quite different. So the prognosis and the treatment protocols, everything would change. So biopsy should be done whenever the diagnosis is indeterminate or probable UIP.
Puneet, I'll slightly differ here, because if it is indeterminate for UIP, then it might not be a true UIP pattern on pathology, and it may not point towards an IPF or even a CTD or HP related UIP. But in probable UIP, it is mostly seen that the radiologic pattern of probable UIP corresponds to a histologic pattern of UIP. So if you have a probable UIP, you do not need to go for a biopsy really. If you have a setting which is consistent with IPF, you can diagnose IPF and treat accordingly. If you have a setting that is more consistent with the CTD-ILD, again, you can follow the same the algorithm for the particular type of CTD or the particular type of ILD, that is CTD-ILD. So CTD-ILD with a UIP may require a different kind of treatment approach as compared to a UIP which is encountered with IPF. So doing a biopsy, if you're doing it for the purpose of finding out whether there is an underlying CTD component to it, you can do it in some cases. For example, if you don't have a clear CTD, but there are certain features which point towards a CTD, and the CT chest say shows some bit of ground glassing, some bit of mosaic, and you are not able to put it into the basket of IPF. Say an ANA is positive, say it's a female at 35-40 years of age, but you see a probable UIP pattern on the CT, then you might go ahead with a biopsy, because a biopsy can reveal certain pathologic features which suggest a CTD-ILD. For example, if you find a lot of lymphoid follicles, well-formed lymphoid follicles with germinal centers, then it takes the diagnosis more towards a CTD, a connective tissue disorder. If you find a lot of small airway involvement and airway-centric inflammation and fibrosis, it takes your diagnosis towards hypersensitivity pneumonitis. So you have advantage of doing a biopsy if you have suspicion that this may not be an idiopathic disease, this may be related to some kind of exposure or CTD. Okay. So I'll be taking the next question, which is, for an acute exacerbation of IPF, does BAL help in differentiating infection worsening, or that is infective cause of worsening or inflammatory cause of worsening? As in both cases, you will get increased GGOs on CT. So we'll need to decide therapy based on whether it's an infective cause or inflammatory cause. So is there any role of BAL? Puneet?
Yes. So when the patients come with acute exacerbation, infection is always one of our differentials. And if non-invasive methods are not able to give us a clear clue, then BAL may help, provided the patient is stable enough for a BAL, because BAL itself is one of the trigger factors for worsening of exacerbations, and these patients may not tolerate BAL very well. So if the patient is stable and if the BAL can be done safely, and non-invasive modalities have failed to clearly bring out infection or any clear-cut etiology for the exacerbation, BAL may be considered to isolate the organism. In terms of the cell differential, we may not be able to differentiate between infective cause versus non-infective cause even after doing BAL. But if we are able to isolate the organism by any microbiological tool, then that may help us.
Puneet, another question we have for you. What is the preferred antifibrotic in patients with liver disease?
So like I discussed in my talk also, that if the patient has got mild liver impairment, child class A only, then we can start with a lower dose of antifibrotic and just closely monitor the patient. And many of the patients may tolerate the antifibrotic quite well without worsening of their liver status. But if the liver impairment is more, child took B or C, then antifibrotics should better be avoided. Both the antifibrotics that we have, nintedanib and pirfenidone, are potentially hepatotoxic. So if the liver impairment is moderate or severe, then we should avoid antifibrotics. And then the only thing that we are left to offer to the patient is supportive therapy, rehabilitation, but we really do not have any pharmacotherapy to offer to these patients. But in lower degrees of liver impairment, we can give a reduced dose and just monitor the patient very closely.
Dr. Sakshi Batra, are you able to unmute yourself? I can allow you to ask your question. Dr. Sakshi Batra. Okay, I can't see her unmuting. Right. So, a question for Kavita. Dr. Kajal Arora asks, any specific proportion of pigment-laden macrophages in BAL sample which are required for desquamative interstitial pneumonia?
A specific percentage is not really mentioned for the diagnosis, but yes, if it is characteristically present, I mean, you are not seeing any lymphocytes, it is completely studied with these pigment-laden macrophages with an underlying, I mean, a consistent history and radiology, then that should be enough for diagnosis.
Okay, the next question again for Kavita is smoking-related interstitial fibrosis and CPFE. Are they in any way similar, especially with respect to imaging and pulmonary function tests?
No. CPFE is a totally different entity. SRIF or airspace enlargement with fibrosis is not a specific IIP in itself, that we should remember. It is just a radiological finding. It is not a separate type of IIP. I just mentioned it for the importance of the radiological presentation. So airspace enlargement with fibrosis is more of a emphysema with some increase in amount of fibrosis, but CPFE will be definitely much more symptomatic because patient has both COPD and emphysema findings, and probably a most common type of associated ILD is IPF, though even other kinds of fibrosis are now clubbed as CPFE. If you see PFT wise, I think CPFE should be much more symptomatic and much worse lung function wise compared to AEF. AEF is just a radiological appearance of things which you need to differentiate from honeycombing and other fibrosis related findings. It is not a separate IIP in itself.
Yeah, so with CPFE, studies have reported mostly a worse prognosis as compared to emphysema, and even as compared to IPF sometimes. But some studies have also reported a prognosis which is intermediate between emphysema and IPF. And sometimes the obstruction may not show up. If you have a CPFE patient, the spirometry might not show obstruction. It might sometimes show normal lung volumes. But the radiology will be very stark. It will be extensive involvement. Still, the patient might show normal FVC and normal FV1. So you have to be careful while interpreting these values. DLCO may be a very helpful test because it will show a marked reduction in such cases. So another question is familial IPF criteria. Is there any kind of diagnose? How do we diagnose that disease? Do we do genetic studies for that? So Dr. Alok or Dr. Puneet, can you take up this question?
So familial IPF, there are a lot of genetic markers which are known, but there are a lot of unknown genetic markers also. So a whole exome sequencing can be done if close history is there of close relatives, first degree or second degree, have had IPF, especially at early age, and other markers are there. Then genetic studies can be done, especially whole exome sequencing. However, all the genetic markers are not well known, and by familial association also a provisional diagnosis of familial IPF can be made.
Yes, so several of the familial disease might be due to rare mutations in very well known genes. So surfactant related genes, telomere maintenance related genes. These are the two most important where rare mutations can arise. So there'll be individual variations between different families or different individuals. They might harbor some new mutation which occurs, but it occurs in these particular genes itself. So that is one set of familial IPF. then there are certain genes in which intronic mutations take place, and they are somehow associated with IPF. So these mutations may be carried by a lot of normal individuals in the general population, but some of these individuals will develop the disease. They will be more prone or more susceptible to develop the disease. So those are intronic variants, which are common variants. They are common in the general population, just increase the risk. And there are certain rare variants which mostly occur in the exonic part of the genes, mainly surfactant genes and telomere maintenance genes, which can cause disease. And they are a set of rare mutations occurring at various places in these particular genes. Yeah. So Puneet, another question: what is the role of combination antifibrotics, that is nintedanib and pirfenidone, in IPF treatment?
So I discussed this during the talk. So this possibility is being explored. Combination may be effective, but however, there's a risk of added risk, the side effects, because side effect profile of both these drugs is not very good. So it has been shown till now in Journey trial and another large study that the safety profile is acceptable. So both the drugs can be combined together and the safety profile is acceptable, but the efficacy is still not known. And in what doses they should be used, how they should be used together, how much will they be efficacious, what will be the added benefit over a single drug, that is yet to be seen, and the evidence is evolving. As of now, it is promising and may come up in future.
Okay, then we have another question: can pollution cause ILD? So I can take up this question.
Yeah,
Please.
I
Kavita?
just answered this, I mean, on the Q&A chat box.
Yeah.
I can only answer this intuitively. It is not that I have any evidence for this answer, but since the materials or the toxins that are seen from cigarette smoke and the pollution are probably comparable. We have tar, we have carbon, we have iron, we have kaolinite. I mean, these are the things that have been shown to be accumulated in the macrophages in smoking-related ILDs also, and these are probably present in a significant quantity in the pollution also. It may intuitively cause, but there is no evidence that I can quote.
So I will also add to it that air pollution has been shown to increase the risk of exacerbations in several ILDs, especially IPF, and even it has been found to be associated with HP in a relatively recent study from India. But as such, it being the only cause, this has not been conclusively proven. So studies have focused mainly on taking the prevalence of these ILDs in various cities and correlating them with the kind of pollution that has been recorded by the meteorological departments, looking at the PM 2.5, PM 10, or nitrogen, various nitric oxides and nitrous oxides levels, sulfur dioxide levels. So those pollutants have been correlated with the prevalence of ILDs, but as such, to prove a direct cause and effect relationship has not been done till date. So somebody has asked point of starting OCS and duration in ILD. So this is a very general question. We are discussing ILD in a very detailed manner, the different subtypes. So please ask a specific question. Which ILD do you want to refer to? Another question which Puneet has possibly answered is whether there is any role of adding steroids to antifibrotics in treating IPF.
No. So like I mentioned, steroids have clearly been shown to worsen the prognosis, increase the mortality, and steroids have no role in management of IPF. So in stable IPF disease, definitely steroids have no role. In acute exacerbations, some studies have shown that steroids may help, but well-designed randomized controlled trials are not available. A few which are available have not shown any efficacy of steroids, and there is possible harm. So steroids have, with the current evidence, steroids have no role neither in stable IPF nor during acute exacerbations of IPF.
Yeah, I completely agree with Puneet. There is no proven role, but still some experts use it, especially for exacerbations, and sometimes low-dose steroids are used for some kind of symptom control, like for controlling cough. Sometimes it might help with the feeling of dyspnea. It might reduce the feeling of dyspnea, but no proven role exists for these steroids. Even it was mentioned that acute exacerbation might require high-dose immunosuppression. Dr. Ashu had mentioned in the lecture, but I would disagree on that, that the role of high-dose immunosuppression is not proven. Cyclophosphamide has been found to be ineffective, rather harmful in treating exacerbations. I think Puneet showed that. So another question is, what if in fibrotic NSIP, if the CT shows fibrotic NSIP, but ANA and rheumatoid factor are negative, how to proceed further to diagnose etiology? Puneet, do you want to take it? Kavita, do you want to take it?
I would rule out other rare causes also if it is negative. I mean, ANA and RF has come negative, ANCA, and probably, I mean, if available, myositis panel also would be required before saying it is totally idiopathic, where we don't know the cause at all. So if everything is negative, then probably treat it as idiopathic NSIP.
Yeah, I will agree with
Can I ask one more thing?
Yeah.
So if in this case you have a negative RA, will you go for a anti-CCP? Because RA and CCP do not need to be present in all the cases. If you have a clinical picture which supports that of an NSIP pattern, will you go for both an RA and CCP?
Dr. Abhishek, I would like to answer that question. Actually, this is a very gray area. How many and how extensive should we go about the autoantibodies? Because the latest IPF guideline mentions a whole list of antibodies which need to be performed. But in practical scenario, those cannot be performed in all patients. And sometimes they are not useful, can rather mislead you. So if you say send a patient to a rheumatologist, and you ask him to evaluate the patient for CTDs, if there are no clinical signs, a good rheumatologist will not order any of the antibodies at all. So there are no signs at all. If the rheumatologist has performed a good history taking an examination, they will not go for any antibody. They will ask for antibodies only which are relevant to the disease they might be suspecting. For example, rheumatoid factor and CCP if they suspect rheumatoid arthritis, systemic sclerosis if they suspect systemic sclerosis, if they say Raynaud's is there or some skin thickening is noticed on examination. But otherwise, they do not advise. And if you get these done and then sent to a rheumatologist, they often will tell you, why have you got these antibodies done? Sometimes they can be very non-specifically positive. For example, a 1+ antibody, especially an ANA subtype or a myositis panel antibody, which is 1+, without any clinical sign or symptom, might be 1+ meaning low titer. So there may be different ways of assessing these antibodies. And so a low titer antibody might not be meaningful at all. So we have the next session on this, where a lot of good rheumatologists will be there with us. So all of you should be there, and there a lot of these questions can be really answered, and that will be really enlightening because they come from a different specialty with a different outlook.
Can I make one point, sir?
Yeah.
So, though what you said is, I fully agree with that, but there are certain situations and certain antibodies which may affect only the lung. Patients may come with antibody positivity and lung involvement without any systemic involvement, like in Rho52 positivity or anti-Sjogren positivity. Sometimes in other myositis specific or myositis associated antibodies, patients may come only with ILD. So, in a setting of fibrotic NSIP, for prognosis and for possibility of efficacy of immunomodulator therapy, I feel there is no harm in doing an extensive workup specifically for these antibodies which are well known to be associated with lung limited involvement without any systemic involvement.
Yes, true, Puneet. I will agree with you on that. So that's why I said that it is a gray area, and people may have very different perspectives on that. And in several cases, you will really find that, as you said, there are no systemic signs of the disease. For example, Sjogren is there. So it is associated with an anti-synthetase syndrome. So it has some systemic signs also, but sometimes lung may be the predominant area involved, and you might not have systemic signs, and you are really you need urgent treatment for that patient, because otherwise the disease will really progress. So correct, that is true, that if you have an NSIP pattern or an OP pattern especially, or an NSIP and OP overlap pattern, and even if you are not finding a particular sign of connective tissue disorder on examination, at least in our practice, as we have seen, we also go in for large autoantibody panels. But what I wanted to impress upon the audience was especially that don't do them blindly. But according to the question, if you just are focusing on NSIP or OP pattern or on overlap pattern, then definitely sometimes this kind of screening might be very important. Also, say if you get a UIP pattern in a non-smoker at a younger age, say 40, 50 years of age, say in a male, right? So there sometimes vasculitis might also be a possibility. So vasculitis associated ILD might have a UIP pattern, and there you might need to go ahead with an ANCA, assessing of ANCA. So in our practice, we do rheumatoid factor ANA by immunofluorescence, an anti-CCP and an ANCA in all patients, because we have a research kind of setup, so we do it in all patients. But in practice, sometimes you have to choose judiciously. But at least blindly do not order. Say if you have an elderly smoker who has a UIP pattern and no other feature to suggest any particular exposure or say CT, then don't go blindly for large panels, making the patient pay rupees 10,000, which is completely unnecessary. So that is the point I was trying to make. Okay, stem cell therapy, somebody has asked. I think we have already overshot the time and now it is 1:45. We'll take a 15 minutes break and we can join back at 2 o'clock or just 5 minutes before that. And then we'll have a very nice CTD-ILD session. And some of the questions which have not been answered, we can take up in the very end, at the very end of the day, or we can answer by typing them in. Methotrexate in ILD was a question which can be taken up in the next session. And if you have any such questions which are related to other sessions which are going to follow, you might ask there and then. Okay, so thank you very much for being there, and we'll join back in about 10 minutes. You can have your break, especially I also need a break. So maybe 10 minutes later we join, and I will also request the panelists to make an effort to join back, because it will only add a lot of value to the discussion. Thank you. Welcome back. We'll start the next session in about 5 minutes.
And I have requested for this one man जो मेरी बेटी पूजा का केस हैंडल करेगा. कौन? ACP अविनाश.
Let's begin. Postmortem reports आ गए. Body इस पोजीशन में मिली थी.
Flat on the ground.
Welcome back. So after the break, we are going to start this next session, which is on connective tissue disease related ILDs. Dr. Shinoy, are you there?
Yes, Dr. Sajal, I am here.
All right. Thank you so much. Navjot, can you change the name to Dr. P. Shinoy, the one with Benzita Pinto, and we'll keep on changing the name. Just write P. Shinoy.
Okay, sir.
So our next speaker will be Dr. Padmanabha Shenoy, and he is the medical director of the Center for Arthritis and Rheumatism Excellence. He is a DM Clinical Immunology from SGPGI Lucknow. He is one of the most prolific researchers that we have in this field in our country. in the field, especially of systemic sclerosis and related ILD. He has won several awards and has more than 50 publications in top journals of the world. We are very fortunate to have a lot of rheumatologists with us who are there in the national conference IRACON, and they have really done me a favor by accepting this invitation, and they are making an effort from there to connect to us, and they'll come live to talk to us, and we will listen to them one by one on each specific CTD-ILD, which we generally do not do in pulmonology sessions, but this time we are going to do it. We'll deal with RA-ILD, SSC-ILD, Myositis ILD, Sjogren's ILD, and IPAF separately. So over to Dr. Shinoy for starting his lecture.
I am unable to share the screen.
Please try again, sir. Yeah, we can see now. Could you close this office window?
Yeah, one second. I'm doing that.
Yeah, could you make it full screen?
Yeah.
Yeah, it's fine now. So can you just go to the next slide and see whether we are able to scroll?
Can you hear my?
I can hear you. I can hear you. Just
Yeah.
go to the next slide just to make sure. Yeah.
Yeah.
Slides are moving also. So you can take up now, sir. Thank you so much.
Good afternoon, Dr. Sejal, for kind invitation. And it's a pleasure. And it's such a topic which is close to my heart. That's why I thought I should be on board. Despite it should be, and talking to pulmonologists is always fun because we have so many clinics where we work together. And starting the case is an index case, a 30-year-old lady who is symptomatic for 4 years. She had dry cough and breathlessness. Breathlessness caused, basically, she had a functional class 2 breathlessness, and her forced vital capacity was 56%. Garden variety case of interstitial lung disease. You can see the NSIP pattern. And her hands had good going Raynaud. There was gangrene. You can look at face. There is scleroderma facies, and anti-SCL70 is positive. And the diagnosis of scleroderma interstitial lung disease appears to be very straightforward in this case. The question is whether to treat this patient, when should we treat this patient, and out of which should we treat all scleroderma patients, and last question is with what. So always remember this. If somebody, always when you see a scleroderma patient, look at whether there's a composite categorical decline over time. What do you mean by CCD? CCD is decrease in FVC more than 10% or decrease in FVC by 5 to 9% with a dip in DLC of 15%. If we have a dip in FVC over 10%, because if somebody has a FVC of 60, after they come after 1 year, it's 54%, it indicates that the chance of death is very, very high. You look at the survival, 10-year survival is around 20%. So when somebody's FVC is dropping by 10%, it is even worse than another person developing a cancer. Please remember this throughout this talk. We are dealing with a deadly disease, which is a killer disease, and the prognosis of which is not at all great, and is as comparable to CA lung or CA colon. They are 70 to 80% 10-year mortality. And what is the most important predictor? FVC less than 80%. In scleroderma, if somebody's FVC is less than 80%, that predicts bad prognosis, 3-year mortality of 25%. So should we really treat all the scleroderma ILD? Okay, the scleroderma ILD is deadly. Should we treat everyone? The answer is big no. Because not every interstitial lung disease progress. Treat those patients who progress, or treat those patients who are at high risk of progression. So, does the pattern really matter? The answer is big no. Be it NSIP, be it fibrotic NSIP, be it UIP, the outcome is almost similar. Initial data suggests NSIP had a better outcome in scleroderma interstitial lung disease. But later on, the people have shown very clearly with lung biopsy, be it NSIP and UIP, the prognosis is almost similar. Only thing practical use is in UIP, probably in Interani may be useful. Still, we don't have the data yet. So the pattern really doesn't matter. Only thing what you need to really see is treat those who are at risk of progression. I told you all this. What is the risk of progression? The risk of what is progression? Treat those who progress. That is very clear. What is progression? FVC more than 10%. Dip in FVC more than 10%. 10% means 60, what is the 10%? 6% dip. So 60 becomes 54, 70 becomes 63, 50 becomes 45. That is a progression. If somebody progresses, it is a no-brainer, you treat them. But wise people don't wait for progression. Waiting for progression is allowing the lung to destroy. Why should we allow? Should we allow? No. What should we do? We should predict who is going to progress. How can we predict? Look, it has been very clearly shown from a lot of data that those patients who are having early disease, scleroderma within maximum lung loss, volume loss happens in the early years, first 6 years, and rate of loss is around 6 to 7% per year. And antibodies help to predict development of progression of ILD. For example, anti-SCL70 antibody, you can see here, people have very clearly shown this is not the pattern of disease which matters. In our own cohort of 1,000 patients, close to 1,000 patients, the clusters are very clear. It is not the type of disease which matters, it is the antibody which matters. If it's a diffuse disease with SCL70 positive, or if it's a limited disease with SCL70 positive, the risk is around 75% chance that they develop pulmonary fibrosis at the end of 5 years or 10 years. So, and look at the antibody. If anti-centromere is protective, topoisomerase 1 or SCL70, it's at a high risk of progression. So look at antibodies, they will help you. So 2 things I told you. So can we identify those at risk of progression? The answer is yes, 2 part. Early disease, progress better, worse. SCL70, they lose volume. Low FVC presentation, they lose volume. More than 20% lung volume involved at the baseline, they progress. Other factors, decide, look at age. Whether to immuno, somebody 75 years, I won't be so aggressive to immunosuppress. Somebody who has duration of disease is very early disease, 2 years disease, FVC 55%, I will be very aggressive. If somebody has
remember anything. So
somebody who has
having long sleep pattern like 10 hours, 12 hours.
Somebody who has 15 years disease, I won't be that aggressive. Comorbidities like CKD, I won't be very aggressive because I know CKD has its own mortality by itself. And lung volume at presentation, if somebody has FVC already of 25%, what is the point in immunosuppressing them? Because immunosuppression will add added risk to the entire infection, and it can cause death by itself. So, and again, I tell you, type of ILD does not really matter in CTD-ILD in the decision to take whether to immunosuppress or not. Look at the armamentarium, the way it has increased from 2010 to 2020. There are a lot of drugs has come in last 10 years or 12 years. It was only Sjogren and cyclophosphamide. Now we have mycophenolate, tocilizumab, rituximab, tofacitinib, nintedanib, and what not. So this is the landmark study, SLS1 study, where they compared cyclophosphamide vis-a-vis placebo, and at the end of 1 year, they had a marginal difference of 2.5% in FVC. But what was in store was when they followed these patients, what they could see was at 1 year, there was only a marginal difference of 2.5%. But at the end of 18 months, there was a difference was around 4.5%. What does it indicate? If you control inflammation, you can prevent fibrosis in future. So it is not immediate reward. If you immunosuppress now, you are going to prevent the fibrosis after 1 year or 1.5 years. So, and there was no maintenance given to these patients. So because the maintenance was not given, and then what happened? The FVC dipped, and at the end of 2 years, both of them merged. There was no difference. So this study only taught us that one, control inflammation now prevents fibrosis later. Second, if you don't give maintenance, the patients will deteriorate. Also, you should give continued drugs for longer time. This is our own study, which was published in 2016, where we compared cyclophosphamide vis-a-vis mycophenolate, and we had our patient had a low FVC at presentation, around 48-50%, moderate severe disease. And what we could see was that both cyclophosphamide group and mycophenolate group improved the FVC by around 4 to 5%, and they were equally effective. This is the similar time SLS2 it's a randomized control trial which was published. Mycophenolate vis-a-vis cyclophosphamide. Mycophenolate for 2 years was compared against cyclophosphamide for 1 year. As you can see here, both the group again showed almost similar improvement. Mycophenolate 1 year, 2 year of mycophenolate was similar to 1 year of cyclophosphamide. So it is proven beyond doubt that if you treat these patients, FVC improves. FVC really improves in this patient. And between mycophenolate and cyclophosphamide, mycophenolate is better tolerated. How long to immunosuppress? This is our own clinic data. In India, what happens, all of you know, after induction therapy, certain people default. So in our cohort, after 57 patients, where I showed the initial data, 11 patients default. They stopped coming for treatment because of various, and 46 were under follow-up, and they were continuing their maintenance. And what happened? Those who are defaulted, out of 11, 9 could be traced, out of which 4 died, around 44% mortality. And those who were on maintenance, the mortality was only 10%. You can see the Kaplan-Meier curve, how it looks like. I don't want to go into details, but the message is very simple. You need to keep these patients on maintenance for 5 years or 6 years or longer time, till and closely follow them up. So I told you mycophenolate or cyclophosphamide is the first choice, and mycophenolate, because of less side effect the patient can afford, is the first choice. And what to do with those who do not respond to mycophenolate or cyclophosphamide? One, switch from mycophenolate to cyclophosphamide. Second, switch to add rituximab. Or third is to give hematopoietic stem cell transplantation. Let's look at the data. This is rituximab data from our own colleagues from Kolkata, our own group, where they compared intravenous cyclophosphamide vis-a-vis rituximab. And you can see they have moderate severe disease. FVC was 59% or 60% at baseline. And in this study, what they could show was that rituximab improved the FVC from 61 to 67%, almost 10% improvement, while cyclophosphamide or stabilized it. And look at all the p-values, FVC, skin scores, all of them were better in rituximab when compared to cyclophosphamide. Again, very recently published study, last 6 months back, Recital trial, where they compared IV cyclophosphamide with rituximab. So IV cyclophosphamide, but it's not a scleroderma per se. It is basically, some of them were myositis, some of them scleroderma, some of them were MCTD, but predominantly it's a myositis cohort. And what they could show was that rituximab and cyclophosphamide both improved FVC to the similar extent, and both were equally effective. But both of them improved. So rituximab is equal to cyclophosphamide according to the current data. Tocilizumab is an interleukin-6 blockade, and this is the largest trial which was conducted, which is called FOCUS trial, where there are 210 patients. They are randomized to tocilizumab vis-a-vis placebo, and you can see here tocilizumab stabilized the lung function, while placebo arm there was a dip of around lung function to a great extent. Around 190 ml the placebo patients lost. So tocilizumab stabilized lung function. What was more interesting to me was, see, you can see the placebo arm, the blue line. After 48 weeks, they were given open label tocilizumab. What happened? It was dipping. It came here, then it stabilized. So tocilizumab, now we have more and more data coming up. In early disease, tocilizumab stabilizes lung function in these patients, and it's an effective drug. But the cost and the injection, it has to be given as injection, and risk of infection, we have to always remember. And for last 4 or 5 years, we have now the data on stem cell transplantation, SCOT trial, where they have compared to SCOT trial is one of the landmark trials we have published in New England Journal 5 years back, where they compared stem cell transplantation with 1 year of cyclophosphamide. The red line is transplantation, and the other blue line is cyclophosphamide. There's no difference. At the end of, after 3 years, what happened? The cyclophosphamide arm performed worse when compared to transplantation. Look at the lung functions. Obviously, FVC at 5 years, transplant arm did much better than those who are on cyclophosphamide. Then, so is it the end of immunosuppression for scleroderma? Should we directly refer all patients for transplantation? The answer is no. This is our rebuttal. We have published a correspondence in New England Journal. There are 2 points. There was no maintenance given in cyclophosphamide arm. So we need better studies comparing long-term immunosuppression with bone marrow transplantation. And difference appeared at 2 years, because in the cyclophosphamide, I told you, if you give cyclophosphamide 1 year, the effects last for another 1 year. So you need the ultimate difference appeared at 2 years is because of this. And third thing, which we never should forget, that transplant-related mortality, which happens in the patients of scleroderma who have been given bone marrow transplantation, is something close to 15 to 20% in major centers. So we should be very careful when we transplant these patients. And nintedanib, all pulmonologists know this better than me, is an antifibrotic. And this is the landmark trial again, 576 patients randomized into nintedanib versus placebo. Both arms lost lung volumes, but those who had nintedanib lost less volume when compared to placebo. So you can see here what happened. They are saving around 80% of lung volume. But what is more interesting to me is when we compared mycophenolate plus nintedanib versus no mycophenolate, no nintedanib. Because in this study, there were some patients who are on background mycophenolate. If you compare those patients with mycophenolate plus nintedanib, they lost only 40 ml at the end of 1 year, while the patients who were neither on mycophenolate nor on nintedanib, they were lost around 120 ml. So ultimately, they were getting around 75 ml per year of lung volume was saved at the end of per year. That is around 5% of FVC. So I think what the future looks like currently is combination of mycophenolate plus nintedanib appears to be very bright. The very recent trial, which was published in European Respiratory Journal now, rituximab plus mycophenolate versus placebo plus mycophenolate. So as you can, so whether B cell depletion with a combination of mycophenolate performs better than mycophenolate alone. You can see here the majority of the patient had CTD-related ILD or IPAF, and results are very clear that rituximab plus mycophenolate is better than mycophenolate alone. So I have told you how to diagnose, how to stratify the risk, we have to treat. So we have to do how to use these drugs. That is the most important, because now we have many drugs to come already there, and a lot of drugs are going to come. So we should do regular pulmonary function test. Like all pulmonologists, we have to do regularly pulmonary PFT and treat to target. This we have learned from rheumatoid arthritis or lupus. Treat to target is a concept because we have to set a target and try to achieve. In diabetes, we do that. In blood pressure, we do that. Rheumatology, we do in rheumatoid arthritis. So what we should do, we should target to stabilize. If somebody's FVC is 60, we should stabilize it to 60. We should change drugs in such a way that it remains 60. So what are the drugs? First line drug, I use mycophenolate or rituximab as my first line drug. And if the patient is stabilized, I maintain on those drugs. If the patient is not stabilizing, patient is progressing. So what is progression? Progression is nothing but if FVC falls by more than 10%, I take it as progression. And progression of disease by HRCT. So do have 2 or 3 readings of FVC, maybe 1 month apart. If everything is showing a falling trend, really you need to consider progression and change therapy. So if somebody is on mycophenolate, I add rituximab, or switch from mycophenolate to rituximab, or switch from mycophenolate to cyclophosphamide, or add nintedanib. These are all options in those who progress. What percent progress? I told you 20 to 25%. Out of 100 patients, only 25 progress if you treat them well. And after maintenance, what happens? If the patient is stable, I continue maintenance or slowly try tapering. On tapering, if the patient progress, switch back to the original therapy. So basically, this is how we should do. But extremely important I want to convey one message is treat to target. And what is the target? Stabilization. You prevent the lung volume loss in these patients. So food for thought. All of you had food. So what should we think? Disease is deadly if untreated. Very clear. We have reasonably good investigations, but most of the investigations, unfortunately, are underutilized. Most of us don't do regular pulmonary function tests in scleroderma patients. Still, the rheumatologists are at fault. We have drugs which is effective in close to 90%. And evidence emerged over last decade. We all of us know that. But the problem is, underdosing is so prevalent. Mycophenolate, 1 gram people give, and people don't switch. If somebody is getting mycophenolate, that's a big thing. People don't switch from mycophenolate to cyclophosphamide or cyclophosphamide to mycophenolate, or they don't switch. And monitoring tools are available. The problem is no target set, and we need to set one. And I think the easiest target is stabilization. Improvement is a bonus. If you can stabilize, that is more than enough. And treat to target, stabilize FVC, preserve lung. Thank you. And good outcome can be really obtained by optimal monitoring, optimal investigations, and optimal treatment. This is my team. Thank you for patient listening.
Thank you so much, sir. It was a great lecture to listen to and very crisp. A lot of evidence, a lot of personal thinking going into it. So will you be here till the end of this session? So that
if you could, I would be very happy if you could let me go, because.
Okay. All right. So
my camera is some issues, Sajal. Sorry, my camera is not.
No problem with that. So you will take up the questions right now, sir. If any panelists want to ask any question, I'll ask them. I'll request them to please ask now. Any of the panelists, if they want to put up any question. Okay. So we'll take up the audience questions first, and then I'll ask a few questions of mine. Dr. Sharda Vinod asks, with respect to focus trial, was only placebo given? Any other immunosuppression was given or not? And whether it was ethical, whether it was ethical to perform the trial, was ethical approval?
Yeah, very true. The focus trial did not have any background immunosuppression. They were having very early trial, and it's a very interleukin-6 blockade. So these patients did not have, some of them did not have interstitial lung disease at the baseline. So it was basically when the patients were received, they could be rescued at any point. They could have taken out and given mycophenolate or anything, whatever the investigator feels. So that's how it is. If the patient is progressed, see, in scleroderma, what you should realize is scleroderma is an orphan disease, and actually this is how the trial was done. And some of the, but as you can see in this trial also, there was not much major mortality which happened, and that's how it was done.
Okay. Any other question that participants want to ask? I can even unmute you if you raise the hand, and if you want to ask a question by yourself, I can unmute you if required. Just raise your hand if you want to ask a particular question, or you can just type it in if you want me to read it. Okay, so I'll ask a few questions, sir. Again, I'll come to the basics. That when do you really use rituximab upfront? For example, if a patient comes to you and has a particular FVC, say we'll take 80% and possibly 70% and 50%. And do you base this decision of using MMF or rituximab or cyclophosphamide on just the pulmonary function test or on CT appearance? How do you take that decision of upfront therapy?
Basically, why we love scleroderma, there's a lot of gray zones, a lot of art is involved in it. Basically, and it is not very straightforward decision. Why we choose cyclophosphamide? The choice is, if the patient usually affords, I give rituximab or mycophenolate upfront because toxicity is less. Between rituximab and mycophenolate, I usually use mycophenolate upfront. Will be my first choice because it has more data, less risk of infection. Rituximab, whatever you say, you are just depleting the B cells. And once you given rituximab, it's like Ramban. You can't take it back. And the effect lasts for 6 months. So that's how I give mycophenolate first. If the patient is not responding, I give rituximab. Where I give first rituximab is basically those patients who cannot tolerate oral therapy. There are some patients who have severe GERD. The moment you give mycophenolate, they have severe GERD, they are unable to tolerate. These are the patients whom I give rituximab upfront.
What dose you target with MMF, and when do you decide that MMF is not working, sir?
Mycophenolate, I usually give 2 grams, 1 to 2 grams. And another very important point, we have recently published a article on seminars in arthritis rheumatism, which has shown that even if by using a pantoprazole or ranitidine, the bioavailability comes down by 50 to 60%. So extremely important to give it at empty stomach. If the patient is having GERD, or if you want to use PPI, try sodium salt, mycophenolate 360 S salt is there now, 360 MMFS or mycophenolate S. Sodium salt 360 milligram, the dose conversion is almost similar. 1 tablet to 500 is equal to 1 tablet of 360. And then after giving mycophenolate, repeat a PFT, pulmonary function test, 3 to 6 months. And 6 months, if the patient's PFT is falling, patient is most of the time scleroderma ILD does not progress as fast as myositis ILD, what Dr. Bensita is going to talk now. It is a it's a marathon. But in scleroderma ILD, couple of patients who have BOOP. It's a surprise finding. Somebody who has NSIP, suddenly cough is increasing. You do a PFT is falling, patient is breathless, you do CT is BOOP. Then the entire scenario changes. But these are rare scenarios. Most of the time, you can wait for 6 months, repeat a PFT. Then if the PFT is falling, and do a CT or 6-minute walk distance, whether it is, and another very, very important point, which I have recently learned, is do PFT at the same time of the day. Extremely important. PFT doing in the morning and afternoon and evening gives us different value. I don't know whether pulmonologists may be well versed with this, but as a rheumatologist, this was a new learning for me. Do at the same time. If somebody has done at 10 a.m., do at 10 a.m. because 10 a.m. to 4 p.m. there is a dip of around 4 to 5%. And second thing, 6 minutes walk distance. Ask them to walk and do a desaturation. It is much better. The very gives a lot of functional information. That's what these two things. And if there's a 6-minute walk distance is dipping, FVC is falling by 10%, HRCT is showing progression, there's no doubt I'm going to add rituximab or add nintedanib.
So what do you do if somebody acutely worsens, somebody with systemic sclerosis ILD worsens acutely in the form of an acute exacerbation? The PFT dips, sometimes ground glass opacities come on the CT. So in other ILDs, we'll use steroids, although there is no clear evidence, but whatever observational data we have is divided between just observation, treating any infection if found, and if no infection is found, giving them steroids in some of the series. But in systemic sclerosis, we cannot go more than, say, 10 milligram of prednisolone. So what do you do if there's acute worsening?
Most of the time, scleroderma acute worsening is either BOOP or, more importantly, is infection. 95% of it is infection. So we give them whatever antiviral, whatever infection, but we are treating, treat the infection. And sometimes if the bronchospasm is very severe or patient is acutely deteriorating, we give short course of 4 or 5 days of hydrocort or intravenous steroids and just rapidly taper it off. And scleroderma renal crisis, although in the West they have seen a lot of patients, our prevalence is not that high. I was just discussing with SGPJ cohort of 25 years, they have less than 20 patients. So it's not very, very common in probably our ethnicity, our antibody patterns. We see scleroderma renal crisis very infrequently. So my take is acute worsening of scleroderma ILD is usually infection unless proved otherwise.
Okay, sir. Then when do you combine MMF and rituximab?
When MMF is the patient is either patient has a very severe disease, young girl having a MRS score of 25, 30, 40, or already 20% of lung is involved at baseline, then you know mycophenolate is going to take time. Then you hit with rituximab plus mycophenolate. That's one option. Second option is if somebody has been given mycophenolate, patient has followed up for 6 months, patient is deteriorating, combine rituximab. Add rituximab to mycophenolate.
No, but shouldn't we switch then if you feel
that's what ever ILD trial I showed. I showed you the ever ILD trial. The combination of rituximab plus mycophenolate is more effective than giving mycophenolate alone.
No, but if MMF has not worked after 6 months or more, then shouldn't we stop MMF and just go to rituximab?
Yeah. That also is another option. But rituximab is a pure B cell therapy. So mycophenolate has also T cells involved. So combination works slightly. So for example, adding another drug, that's what usually rheumatologists do, keep adding drugs. For example, somebody's methotrexate doesn't work, you add anti-TNF to it. That comes from that RA background, how we treat RA. Maybe it is the way you asked is maybe the right thing, but we don't know the answer. But anti-TNF plus methotrexate, even if methotrexate is inadequate responder, adding TNF is better than just switching to TNF. That's how immunology works. But maybe what you are saying is correct. Switching may be better than adding, but we don't know the answer.
So when do you add nintedanib when do you use MMF and nintedanib both? Should it be given upfront or should we start with one drug and go to the next? Because in pulmonology, like if in non-CTD ILDs, we have the progressive pulmonary fibrosis thing where we do not give antifibrotics to any fibrotic ILD unless it progresses. So if we have a fibrotic HP, the current understanding is that you start with immunosuppression and then go to antifibrotics if progressive pulmonary fibrosis occurs because of the kind of evidence we have. In systemic sclerosis ILD, the census trial had recruited patients who had just systemic sclerosis ILD with significant lung involvement. They did not look for progression before starting antifibrotics. So what should we do? Should we go ahead with an upfront combination of MMF or nintedanib, or should we start with MMF first?
We should go step by step. Very clear, very simple. We should give mycophenolate. If the patient is progressing, you add nintedanib. That would be one is cost, second is tolerance, because already these people have GERD. On top of that, you are giving mycophenolate, then you are adding nintedanib. So if you are adding 2 drugs, it is going to be, tolerance is a huge issue in these patients. So better to go step by step, and mycophenolate alone is going to be effective in 65 to 70% of patients. Why to unnecessarily burden these patients?
Completely, sir. I completely agree with you. And the last question will be, maybe we'll have some audience questions if required, but my last question is, tocilizumab, we have the trial, focus trial, but in that trial, the FVC was a secondary outcome. So can we really presume that that tocilizumab will work for systemic sclerosis ILD? Can it be introduced into clinical practice right now?
My take, somebody has asked in the audience question also the same thing. See, tocilizumab is only effective in early scleroderma. And within 1 or 2 years, 3 years, it's effective. In my practice, I don't use at all, being very frank. Because of one reason, one is cost. Secondly, I find mycophenolate much better, rituximab much better than tocilizumab per se. And tocilizumab very rarely we use when the patient has severe overlapping arthritis or persisting. But in most of those cases also, rituximab works equally well. So this is tocilizumab, early disease, very high CRP. Some of the scleroderma patients have CRP of 30, 40. So those kind of patients, when interleukin 6 is the main driver, then we can use tocilizumab. Otherwise, I don't use tocilizumab upfront.
Are we ready for this kind of tailoring of therapy based on IL-6 levels? Because in COVID, we saw that, but there also it was found that IL-6 levels were not correlating with the effect of tocilizumab.
But if we can do a skin biopsy there's two phenotype. And doing a transcriptomic study, looking at an inflammatory phenotype versus fibrotic phenotype, that may tell us. But looking at IL-6 levels is not going to help, because what is happening in tissue, what is happening in the blood is not reflective of what is happening in the tissue.
Right. Audience questions. How long do you wait before switching the immunosuppression for
It's about 6 months.
So 6 months, yeah. Is there a difference in efficacy of MMF and mycophenolate sodium? Is one
No, same. Only thing is whether the tolerance is better with sodium salt. That's all.
Yeah. And another question which I really not able to get, I asked him to post the question again. Dr. Sharda Vinod, as discussed in the talk, if FEC is around 25%, there would be no point in aggressive immunosuppression. But should we give immunosuppression at that point of time? Now it is clear. So if it is very advanced fibrotic disease in SSC ILD, will there be any role for immunosuppression for the lung disease?
If FEC is 25%, and first thing, make sure that
we can take it as 30, 35, 40 also.
40. It's a 40-45%. There is still a room.
Yeah.
Because most of the time what happens, FEC is 20-25%, patient would have developed a secondary class 3 pulmonary hypertension, RVSP is around 70 to 80. The moment you give so what I would do is I will give mycophenolate plus low nintedanib if possible, and try to restrict the but don't give rituximab and very high in immunosuppression. What happens is if they catch a small infection at FEC of 25, you are done. You won't be, once they go to ventilator, it's very, very difficult to pull them out. They become dependent, one infection after another. That's what we have seen. So I don't, but try to catch them early. Thankfully, of late, most of our patients presents to us. I am not sure whether, when I started my practice 10 years back, patients used to come with FEC of 25, 30. But thankfully, because now awareness is better, patients are coming much earlier, 50, 60. Most of our patients enrollment is around 50 to 60. So we are able to really make a difference to these patients.
Right, sir. So you have your colleagues there, sir. Benzita is there, and I think others are also there. If somebody wants to add anything here or differ
Dr. Alok is raising his hand, I think.
Who is raising?
Dr. Alok Nath.
Okay. Dr. Alok, you can come in, please.
I wanted to just ask one question which comes to my mind. What are your views on upfront use of rituximab in systemic sclerosis ILD? I mean, moderate to severe disease.
No, nothing prevents, sir. It's Dr. Alok, it is as effective as mycophenolate. It's extremely good. If the patient has GERD, that's what I told you, mycophenolate, somebody has a GERD, severe GERD disease, rituximab upfront therapy is also equally good. No, nothing wrong.
But I mean, we don't have much literature on upfront use of rituximab compared to direct head-to-head comparison with mycophenolate. Does we have any benefit of because we see excellent results as a second-line agent. Lot of patients who have failed mycophenolate therapy get stabilized on rituximab, in my experience, but we have not used it upfront. So,
if you see Dr. Parachar's study, it is very clear. Rituximab is upfront versus cyclophosphamide upfront, and rituximab is better. So that's one. And recital study also, rituximab versus cyclophosphamide. Again, it was almost similar. Rituximab versus mycophenolate, we don't have data, but we have data that shows that mycophenolate and cyclophosphamide are equal. So you can only derive from all this. Looking at things, my take is rituximab and mycophenolate, cyclophosphamide, they are going to be effective in significant number of patients. And 60% or 70% is going to be effective, whatever you give upfront. And if it is not working, then you switch. Which one you want?
My only reason to ask this question was that we always use it as a second line or a salvage therapy. So if the results are so good as a salvage agent, can it be possible that if we compare it with mycophenolate, it turns out to be better than mycophenolate in stabilization of disease?
Very much possible. Very much possible. We don't have the data, but very much possible that it may be better than mycophenolate.
Okay. Thank you.
Thank you.
Benzita, Aadhar, Dr. Abhishek, Benzita, Aadhar, Dr. Varun, Shankar. Would you like to come in here, because we need to discuss this topic very extensively, because this is the only CTD-ILD where we have a lot of evidence. So if you want to add something or differ with sir, please feel free to come in here and intervene.
Benzita is here.
Yeah.
Dr. Sajal, I'm here.
Yeah. Do you want to add to the discussion, because SSC ILD treatment is the only kind of CTD where a lot of evidence is available. So I want you to make any comments if there are any.
Sorry, I lost you.
Oh, Dr. Shinoy, can you hear me?
Yeah, Bensita, you can come here.
I'll go there. Sorry.
Yeah. Okay, I think we can close this particular lecture session and move to the next lecture now.
But anything you want to add to the entire discussion? That's what he was asking.
So I think most of the evidence Dr. Shenoy has discussed, and I think I align with him on decision making, what we do in scleroderma ILD. I think decision making is a little more complicated with myositis ILD because there is not that much in terms of RCTs evidence that we have. So I think that I will discuss in my presentation. I'll present from my laptop.
Yeah, so we invite Dr. Benzita for the next presentation, which is on myositis ILD. Benzita was my MD resident when I was doing my DM pulmonary medicine, and I have fond memories of having our duties together. And she currently holds the position of a consultant rheumatologist in Manipal Hospital, Bangalore. Previously, she has worked in St. John's Medical College. She has about 40 peer-reviewed publications, and she is going to talk about myositis-related interstitial lung disease, and she might cover a bit of antisynthetase syndrome also. Over to you, Benzita.
Dr. Sajal, I cannot share screen.
Now you will be able to share. I have closed my share screen. Yeah, now I can see your presentation. Please make it full screen. And
so just one correction. I am a consultant rheumatologist in Manipal Hospital. Thank you for the kind invitation, Dr. Sahajal.
Yeah,
so
can you go to the next slide? We just check the slides are moving or not.
Yes.
Yeah, okay.
Are they?
Fine. It's fine. Yeah, they are moving.
Okay, so I think Shenoy has already set the ball rolling, so I think that makes my job a lot easier. I'd like to talk about myositis from a rheumatologist perspective because I think here I'm a rheumatologist, so I think rheumatologists have a slightly different perspective of idiopathic inflammatory myositis. So the first thing,
Benzita, your voice is breaking. We are getting an intermittent signal. You can take a minute or two if you want to adjust your settings or do anything to your location. Because Dr. Shinoy was very clear, there was no intermittency. Now there is.
I'll just present from Dr. Shenoy's laptop then. Actually, we're on the same net. I don't know why this is. Am I?
Yeah, no, still I can't hear you, Benzita.
Right. So I'll connect with.
Yeah, you go to Dr. Shinoy's laptop, will be better. Navjot, you can change the name from Dr. P. Shinoy to Dr. Benzita. Dr.
Right.
Benzita Pinto.
Right.
Benzita, you can take your time, your 2 minutes. No problem with that.
Can you hear now?
Yeah. I can hear you, but we'll need to check whether it is a continuous kind of stream because there was some intermittent loss of voice.
Must be computer issue then.
Yeah. Now your voice is quite clear, sir. I think it should work. So as I told the audience, all our rheumatologist friends are joining from Iracon, and I have given them a tough time, giving them a very short notice for this, and they have really done a favor.
Sure.
Yeah, I can see your slides. Please make it full screen. Yes, I think you can proceed, Vincenta.
So, like I said, that myositis is actually a very heterogeneous disease from our perspective, which has a common muscle inflammation, and that's why it's called myositis. So, it's not really the same disease. It has got very different subsets, have got very distinct pathogenesis, and now currently we base our decisions on the organ, the predominant organ of presentation, whether the muscular predominates or ILD predominates. And there's a clinical serological approach, which is very important. So the presence of ILD is a very important prognostic factor. Overall, the difficulty in the management of ILD is, like I said, the lack of RCTs. And this is because myositis is a rare disease as compared to something like rheumatoid arthritis or spondyloarthritis. So this is a review on the prevalence of ILD. So the prevalence of ILD in myositis is quite high, and a global prevalence of about 40% was seen in this one systematic review, with higher prevalences in certain subsets like in Asia. There are certain subsets of disease which has a very high prevalence of ILD, and this is like one particular subset, which is, yes? Clinically amyopathic dermatomyositis subset, which is predominantly associated with the anti-synthetase syndrome and anti-melanoma differentiation associated by anti-MDFI autoantibodies, which I will be coming to. So first are the points to consider in an ILD. One is the clinical phenotype, the serology, the risk factors, the subtype of ILD, and the rapidity of onset. So when we look at the clinical phenotypes of muscle disease, we have these subtypes, which are polymyositis, dermatomyositis, which we are all well versed with, juvenile onset dermatomyositis, again, an entity that we are well versed with, clinically amyopathic dermatomyositis, in which we have predominantly these two subtypes, the anti-synthetase antibodies and the MDA5 antibodies. And we have immune-mediated necrotizing myositis, inclusion body myositis, and overlap myositis with other connective tissue diseases like scleroderma, MCTD, and PMSCL being important autoantibodies in these subsets. When we look at these various clinical phenotypes, one important point that I would like to raise is polymyositis is a disease that most of us have stopped seeing, and I think most of the patients whom we used to refer to as polymyositis are just patients who are incorrectly diagnosed, and they either belong to patients who had inclusion body myositis or anti-synthetase syndrome, who are inaccurate, or overlap myositis in whom autoantibodies are not done. So the true polymyositis, in which we see the endomysial inflammation, is a disease that at least I haven't seen in the last 5-6 years, ever since I started practice. So the other subtypes are very, we do see all the other subtypes in practice. So what is there is, like I said, and I'm just putting this slide so that we know that each of these diseases has a different pathology and pathogenesis in terms of immunology. So when we look at the muscle biopsies, for example, polymyositis is an immune complex associated disease with some subtypes having interferon signatures. So we see there is a perifascicular atrophy and this vasculopathy that is associated with dermatomyositis. Polymyositis is, on the other hand, T-cell mediated disease with an endomysial infiltrate of T cells with the CD8 MHC complex. Anti-synthetase is slightly different from DM, although there is a tendency to lump it together. It is not, there are differences between anti-synthetase and dermatomyositis, with florid perifascicular myofiber necrosis being a feature of anti-synthetase syndrome. So this is a different disease. And inclusion body myositis, this is a disease that predominantly seen by neurologists and does not really have ILD. So this is a slightly different disease than the rest. So this is the most important problem when we are dealing with myositis, is the heterogeneity. And that sort of has led to this sort of clinical serological approach, in which the clinical phenotype as well as the serological phenotype enables us to kind of understand the disease better, and also try and kind of have certain broad or algorithms on what drugs might work in a particular setting. So we have this very popular, I think, among the pulmonologists, the anti-synthetase syndrome, because of the high incidence of ILD in this subset, which is characterized by typically 5 features. We say fever, mechanics hand, Raynaud phenomenon, arthritis, myositis, and ILD. This is the classic antisynthetase syndrome. Very important to note is that most of the blot tests that we do, myoblot tests that we do for the diagnosis of this antisynthetase syndrome currently has only 5 antisynthetase autoantibodies in the blot, that is PL12, PL7, EJ, OJ, and JO. So that is why a subset of them obviously are being missed, and there's obviously as many tRNA synthetase as we have, that many autoantibodies are theoretically possible. So I'm sure there are a bunch of us who see a particular disease which we feel looks very much like antisynthetase, and you may draw a blank on the myoblot. It doesn't mean that this is not antisynthetase syndrome. So we have this particular subset MDA5, which leads to a very severe form of ILD and a rapidly progressive ILD, which is associated with an amyopathic or a rather mild muscle disease with a skin involvement. And the overlap. So these 3 subsets, as far as lung disease is concerned, are very important. The antisynthetase syndrome, the MDA5 subset, and the PMSCL subset, which is in the CTD overlap. The other disease that is associated with ILD in the CTD overlap is the U1RNP or the MCTD subset, and other than the scleroderma subset, which is maybe associated with the Q overlap, and the ROLA subset, which is with Sjogren's. So what are the risk factors for the development of ILD? The risk factors are the amyopathic variant, because both antisynthetase as well as MDA5 may be amyopathic, older age at disease onset, male gender, and these autoantibodies, increased CRP, ESR, and ferritin are described as risk factors for the development of ILD. So coming to the clinico-serological syndrome, the antisynthetase syndrome, which I mentioned, the autoantibodies that are associated. So when you do an ANA in this, you get a cytoplasmic pattern. So previously, most labs were not reporting cytoplasmic ANA positivity as a positive ANA. Only the nuclear autoantigens were reported as positive, and cytoplasmic, most labs would put in the subscript that, okay, ANA is positive in cytoplasmic, but this is in context of myositis an important pattern. So if you're getting a cytoplasmic pattern, it's important to consider it important and think of antisynthetase. So the common, I'm not going to go into detail about the ILD subtypes, because I think all of us, I'm talking to a pulmonology audience, will be well versed. So the cellular variant of NSIP, OP plus NSIP, that is organizing pneumonia plus NSIP, are 2 very, very important subsets as far as antisynthetase ILD is concerned, with UIP pattern being less common. Anti-MDA5, which is associated with again a cytoplasmic positivity, as well as certain phenotypes which one must remember. It can present with an acute, subacute, or a rapidly progressive ILD. The rapidly progressive ILD is important to identify, because unless you treat it very aggressively at the outset, it's likely to have a rather poor prognosis, and can have an acute interstitial pneumonia or an NSIP as the subtype of ILD that you get. These are clinical images. These are the type of skin ulcers that one gets in MDA5. This is not a Gotrin. This is actually a skin ulcer that is occurring over the extensor surfaces. This is one of my patients who had both an ILD as well as these ulcers. He did not have, in a dark-skinned individual, sometimes you do not get the typical rash of dermatomyositis, or it may be very faint for you to recognize. So this is what he presented with, an ILD and these ulcers. He was labeled lupus outside, and this is after he was given tofacitinib. He had failed triple therapy and then subsequently had responded well to tofacitinib with healing of the ulcers. I mean, the ILD had responded, the ulcers responded finally only to tofacitinib. So MDA5, very, very difficult to treat, but we have more and some more series coming on now after myoblots are being commonly done as to, it has a very predominant interferon signature, and that is why tofacitinib is thought to work well in this disease subset, and most experience is also suggesting that. PMSCL, there was one very nice suggestion by a myositis expert that PMSCL should be renamed DMSCL because it actually kind of has cutaneous features that may mimic dermatomyositis and may be associated with the scleroderma myositis overlap, although you may get just the PMSCL antibody positivity with just some mild Raynaud's arthritis without too much skin thickening, and that's the common subset that we see in practice, gives a nucleolar positivity, and organizing pneumonia plus NSIP of fibrotic organizing pneumonia are the two commonly known presentations in this particular subset of myositis. So this is from one of my patients. We think that this is the classical mechanics hand. You can see here the hand showing creases. And this patient, and this looks very much like a Gottron's rash. So this patient had actually a very strong PMSCL positivity and was not antisynthetase, was PMSCL. So like I said, the assessment will be like for all other, and I think these assessments would have been already spoken about, that the diagnosis would rest on various, one is the clinical features, one is the type of ILD, as well as the serology that we would be ordering for. And now currently we are trying to look more and more for these serologies in patients with ILD. And I do think that MyoBlot should be included in most algorithms for the diagnosis of idiopathic interstitial pneumonias, because I feel that a whole lot of patients are we don't label them appropriately and they lose out on the initial years where probably treatment benefit would be most. So of course the standard spirometry, HRCT and 6-minute walk test most of us would do, and a BAL plus or minus biopsy if there is any diagnostic ambiguity. Mostly we do not get BAL or biopsies done nowadays. It would truly be just based on imaging plus the serology. And then the most important thing here is to kind of figure out whether your patients require treatment, how severe is your ILD, and that would be based again on both clinically, radiologically, as well as based on the spirometry findings and the risk benefit for immunomodulation. So when we say severe here, mild to moderate subacute, or when we say severe ILD, one is we would factor in the FVC as well as the HRCT. FVC less than 80 and the presence of an HRCT score of greater than 20% of involvement of the lung would be considered a severe disease in this context and would be a candidate for immunosuppression. Even in mild to moderate case, because this disease tends to be responsive to immunosuppression, and you more likely than not would have other indications to treat, you would give a second line treatment along with steroids, which typically would be either MMF, azathioprine, or tacrolimus or cyclosporin. Over the years, we have, I would say that 10 years ago, tacrolimus, CNI was not typically, or cyclosporin was not typically used, but there has been more and more data on the on how both the muscle as well as the lung disease responds well to CNIs, and I think currently a lot of us do favor these agents, especially when there is a lung involvement. And rituximab versus IV cyclophosphamide will be rituximab would be usually an agent that most of us prefer when there is a muscle and a lung involvement, because rituximab works very well in muscle disease. And when there is a rapidly progressive acute life-threatening situation, it would be pulsed steroids followed by cyclophosphamide, rituximab, or tacrolimus. There is a triple therapy approach that I will come to. The other agents that we do give in desperation would be IVIG and plasma exchange. Don't have much role actually in the treatment of myositis ILD, but IVIG does work well on myositis, and thereby in a kind of desperate situation, one would use, and especially if there is a concomitant respiratory muscle weakness, it would be a good choice. So this was a systematic review that was published in Autoimmunity Reviews in 2019, which included all the studies done till then. There are no trials in this. One must be aware that most of these are series of patients who are included and includes various subsets of ILD. And that's why there is, of course, a problem that different subsets may respond differently to treatment. So when they looked at most of the immunosuppressions, even corticosteroids alone, cyclosporin, cyclophosphamide, all of these showed a corticosteroids, and cyclosporin especially showed a much better improvement, although the heterogeneity was high. All the patients in most, I will just come to the others also. Tacrolimus, about 80%, cyclosporin and tacrolimus seem to do well as rituximab also seem to have about 80% improvement in the, but you have to see that most of these that are described are very small total series of patients, 18 patients. This one is a slightly larger series, but very small series overall, which makes an interpretation actually very, very difficult. And most of them do not have a very long follow-up, which would really make a difference to the way we treat. So this is for rapidly progressive ILD. Also similarly, not much data and very small series that we have, which show about 60 to 80% improvement in some. This one study which was done for infliximab showed a slightly higher kind of improvement, but most studies have shown quite high mortality with MDA5 associated rapidly progressive ILD. So this was one recently done study which looked at prednisolone and tacrolimus versus prednisolone and cyclosporin, a 48-week trial. And tacrolimus, this is the blue line, did slightly better than cyclosporin, but otherwise both of them did similarly in terms of improvement or free from progression, which was their outcome measure. And so I think both are good choices. It was about 80% patients did improve. And so I think both of them are actually good choices for treatment of myositis ILD. The other subset, which is very, very important, is the anti-MDA5 disease. And this was a small series, but rather a very important series, because this has really made a difference to the way we treat this rapidly progressive ILD with high-dose steroids, tacrolimus, plus cyclophosphamide, something that's called the triple therapy that is currently we are using. And you will see that with the use of each drug, the likelihood of survival has improved. And you can see the survival without this is 30% versus 85%, which is very good for a disease like MDA5 associated ILD, and all other parameters also seem to show improvement. So this has definitely something that has made a difference to practice, although it was a rather small study, I think 40 or 50 patients only, but it made a big difference in the sense that most of us have adopted this regimen now for a rapidly progressive ILD, this aggressive immunosuppression, immunosuppressive regimen. Also in a patient who does not respond or is progressing while on cyclophosphamide, I would currently add on tacrolimus. So it has made that kind of a difference, because there is also safety data that's available from lupus. In lupus, when we treat nephritis, tacrolimus is commonly used in a multi-drug therapy. So I think we are kind of comfortable with this triple therapy protocol. And that is why I think this has definitely come into practice after this study. So rituximab, there is data for rituximab, even a trial which is called RIM trial, which was done in myositis. However, ILD was not part of that trial. So of course, there are several series, and there are two regimens that we commonly use, 1 gram into 2 or 375 milligram per meter square, which is like the CHOP regimen. Most rheumatologists are comfortable giving 1 gram into 2. And there are many reports for both MDA5 as well as antisynthetase with improvement. So this was the trial, the recital trial that Dr. Padmanabhan Shenoy was alluding to, which compared IV cyclophosphamide at a dose of 600 milligram per meter square versus rituximab, so which was given 15 days apart, 1 gram into 2. And this was a 48-week trial. After this 24 weeks time point, patients received immunosuppression as per the discretion of the treating physicians. Up till 24 weeks, there were six cyclophosphamides given or 2 rituximab based on the trial arm. So rituximab, actually, both of them did reasonably well in terms of improvement. And the predominant subset in this trial, although they took all forms of connective tissue disease ILD, was inflammatory myositis. I could not find the subgroup analysis, but from both of them did pretty well. But it was to note that the safety was a little higher with rituximab, so that may weigh in when we make treatment decisions with this. Also, like I said, when we think of myositis, because the muscle disease tends to respond very well to rituximab, this may be a point in favor for choosing rituximab when we choose to treat myositis ILD. So this is the new kid on the block, which has come in for dermatomyositis predominantly, because dermatomyositis has an upregulation of interferon pathways, and MDA5 is a unique disease in which tofacitinib seems to be, and there are more and more case reports and also personal experience in which we have seen that in patients who have really refractory disease, tofacitinib kind of really makes a change. So this was a really small series of tofacitinib, 18 patients versus historical controls. And you can see tofacitinib patients had 100% survival compared to the historical controls, which were about 80%. So, and all other poor prognostic markers, which are considered to be like ferritin, FVC, and DLCO, all of these improved with the use of tofacitinib. And most of the patients had some prior immunosuppression, which included cyclosporin, mycophenolate. So this is a drug which I believe is going to come in a big way in this, at least MDFI subset. Unfortunately, I don't think, again, this disease lends itself well to a trial, but definitely a lot of retrospective data in favor of tofacitinib. This is again another series which had looked at tofacitinib in rapidly progressive interstitial pneumonitis and MDF5, which looked at various parameters, and these were the poor prognostic factors that they identified: ferritin greater than 7, GGOs or consolidation in all 6 lung fields, and presence of worsening while on treatment to be the 3 poor prognostic factors. And use of tofacitinib was associated with better survival in these patients. So again, some evidence, of course, very, very small subset, but still gives us faith in this drug. And these, important to note was here, these patients who were taken in the tofacitinib arm were actually patients who had failed the triple therapy. So again, very, very positive results that the patients who have failed triple therapy are definitely a very, very refractory subset. And thereby, I think this drug, I feel, is going to come in a very big way in MDFI disease. Again, the role of antifibrotics, there is very little data actually. I tried to specifically look for this question, but I couldn't. I found review articles which were in which they based their recommendations or suggestions based on other connective tissue disease ILDs. But as such, for myositis ILD, there is no real data available for use of antifibrotics. And this one particular small study showed that this subset of this was again rapidly progressive ILD. I mean, the 3 subsets basically: CADM, acute, rapidly progressive, or subacute, in which subacute seemed to have some response with the better response with addition of pirfenidone to standard of care. So again, I don't think again, this is not well studied, and most of us, as far as practice is concerned, most of us don't use antifibrotics in this setting, and unless, of course, the pulmonologist would recommend it, there is really no data. So several unmet needs, I think, in myositis ILD, the lack of controlled trials, biomarkers are not well defined for us to, right now we do have the serological approach, which provides us some kind of biomarkers to identify certain subsets which may and kind of have some idea about prognosis and which drug we might use. Duration of treatment is another very tricky area, and we usually draw from scleroderma ILD, which is, I think, the best studied subset among connective tissue disease ILDs, and we will usually treat for long, although even for scleroderma ILD, the data is 2 years, but most people would treat for longer depending on the progression and the risk of infections. Role of antifibrotics, and of course, we have to move towards precision medicine, where we actually combine the understanding of pathogenesis and immunology and we are able to translate that to our to how we treat the disease. Thank you.
Thank you so much, Dr. Benzita. So we have a few questions from the audience. First of all, I'll invite the panelists if they want to ask any question.
A question from my side, Sejal.
Yes, sir, Dr. Alok, please go ahead.
A small question, actually. The one slide was regarding the management plan, mild to moderate, severe, and acute life-threatening. So acute life-threatening is quite clear, and patient with impending respiratory failure or ARDS-like situation. But for mild to moderate and severe, apart from my question to Dr. Benzita would be that apart from the FVC criteria of less than 70% and DLCO less than 50%, which was cited in the paper which you have referred to in that in your presentation.
Right.
Do you have any other objective scoring system? Because FVC less than 70% is not so severe for a pulmonologist, actually. So, do we have any other objective classification for mild, moderate, and severe, or is it just on the basis of FVC?
No, sir, we do not really have. It would be based on both HRCT and FVC. And like I said, in myositis ILD, we draw mostly from scleroderma. But the thing is that this variant, if like I one would tend to treat, because inherently when you see a cellular NSIP or an OP pattern, one does feel that this is amenable to treatment. And that is why, and other than that, ILD tends to be a progressive disease in this particular subset. So I do think that is why this kind of FVC criteria have been taken. It's not really, it's empirical. I have not found any data. I can go back and look, but I don't think.
Because HRCT involvement more than 20% and FVC less than 70 and DLCO less than 50% has been taken as the criteria which you have been referring to.
Yes.
But actually, I mean, disease extent of more than 20% involvement of the parenchyma and this amount of FVC involvement is quite not, I mean, qualifies for a severe disease, which I think Sejal would also be agreeing to in his clinical practice. Nowadays, we are increasingly identifying myositis-related ILD due to improvement in diagnostic and availability of the tests.
So that has also been seen in a lot of data, because as compared to previously, we will find the prevalence of ILDs going up steadily in myositis because of the diagnostic modalities.
Yeah, increased identification.
Yes, because but I do feel that, like I said, purely from a rheumatologist perspective, that when we are looking at a disease that we consider progressive, we consider that there is an ongoing activity, and this is also a disease that is inherently probably responsive to immunosuppression, and that would, I think, weigh on the way we classify and treat, because this is what I think, because most of the data that I saw also concurred with this sort of cutoffs, which I do understand from a pulmonologist perspective is not very severe.
Right. Thank you.
Yeah, so I also believe conceptually other specialties like rheumatology and dermatology are now treating systemic sclerosis and the associated ILD very aggressively, more aggressively than we pulmonologists are used to treating. Possibly because in general, pulmonologists are not very well versed with the biologic treatments that are coming in, because rheumatologists use it in an extensive manner, as they use it in all forms of manifestations of all the different CTDs. But ILDs for us are like a rare disease, except for referral centers. So that kind of, because there are no recommendations, no evidence-based, no RCT-based evidence available. So in clinical practice, the aggression is much lesser in terms of the use of biologic agents. That's what I believe. So that's why this kind of multidisciplinary discussions, during lectures and during such conferences, are very important. So I think we'll take up some questions quickly. Benzita, there's a question: radiological patterns in MDA5. So apart from NSIP and COP, can cysts also occur?
in the acute, most of the MDF5 will present acutely or subacutely. I guess in the chronic variant one, I'm not aware particularly of this question, sir.
Yeah,
don't
I'll
really-
agree with you. So it mostly presents with ground glass and consolidation.
Consolidation.
And a rapidly progressing fibrotic signs like traction will appear very early. Cysts might appear secondary to the fibrosis. So if a lot of traction and a lot of shrinking of the lung parenchyma occurs, then secondary cysts, which are called cicatricial cysts, might appear, but primary lung cysts will not generally appear with anti-MDA5. So the next question is, can a diagnosis of anti-synthetase syndrome related ILD be made in the presence of clinical findings, but with a negative blot? So say all the anti-synthetase antibodies are negative, but clinical findings, as you told, such ulcers and the inverse Gauterons, all those are there. So can it be made in that case?
See, I think if you have the classical findings of antisynthetase, like you have a mechanic's hand, you have some inverse Gauteron kind of features, you do have, so and you have an ANA in a cytoplasmic pattern. I do also think that some patients in whom we find isolated Rho52 positivity actually belong to the antisynthetase subset, where we cannot demonstrate an antisynthetase. I want to communicate. This is one point that I would like to make. In rheumatology practice, we don't base so much on a negative blot. When we have an ILD that looks like an NSIP, and we know that this is usually NSIP is a connective tissue associated ILD, and if we have any other additional clinical finding, then I think that is where the other classification, interstitial pneumonia with autoimmune features, really helps us, because even if we don't give the label of an antisynthetase syndrome, which really does not matter in terms of treatment, because the immunosuppression that we will use will be based on the organ of involvement and the severity of the organ involvement. So I think that definition is something that again has made a great difference to practice, because now we do label them as connective tissue disease associated ILD, or we label them as interstitial pneumonia with autoimmune features, and we are able to kind of treat them. So you could suggest the diagnosis, definitely, because this syndrome is called antisynthetase. You need to demonstrate antisynthetase autoantibody, if you have to call it that. But like I said, you can always put a query, and in clinical practice, nobody would fault you for treating.
So I made the exactly same point in the last session, Binsika, when I said that we pulmonologists are more obsessed with the autoantibody positivity. Our rheumatologist friends go more by clinical symptoms and signs.
Yes.
So, but you also made the point that some of the antisynthetase antibodies are not done in the routine blot that we have. We have just 5, so there are many others, at least 3 you showed. So in that way also, if you have some clinical signs but a negative blot which covers those 5 antibodies only, you might still be having an antisynthetase, which might be picked up in a, say, research setting where you have other antibodies also. So another question is, what regimen of rituximab is found to be useful? Weekly or fortnightly? So you addressed this, but he's asking a pointed question, which will be more useful?
So frankly, I have used 375 milligram per meter square very few times, probably in the context of ANCA vasculitis. I usually go for the weekly regimen. One has to understand this is just a historical aberration, this sort of rituximab dosing. It's very empirical. It was just the 4x4 was derived from CHOP regimen. It was just derived based on the fact that it was started like that, the trials were done like that, and rheumatologists just borrowed it. So either of them has, and there are no comparative trials between the two regimens. I use weekly, the fortnightly regimen.
Yeah, so what I heard somebody, I think a rheumatologist, or I don't know, I don't remember who was the expert who said, so when we use the weekly regimen, we use the 375 milligram per square meter dose. So that might lead to a higher dose in higher body weight patients. So it is supposed to be more profound in the immunosuppression rather than the 1 gram 2 doses.
It would really make a difference in a patient with sort of, depending on the body weight and the body surface area. If you're looking at the total dose, maybe, but in most Indian patients, I think it would match because most of our patients
Yes,
are kind
yes.
of within that.
So if somebody has a lower body surface area, will 1 gram dose be too much, or is it fine to give?
It's fine. I would say that 1 gram into 2 has a large body to support safety. And
irrespective of the body weight and body surface.
Yes.
Yeah.
I do think that, there is a debate on the fixed dosing regimens versus this has been kind of debated, but in ANCA vasculitis, I think Dr. Aman itself had published his data on 1 gram into 2, which is not the standard regimen, ANCA vasculitis 375, and that had shown kind of similar kind of results comparing to the 375 milligram per meter square, which is used as standard of care. So I would say that because that is a B cell proliferative disease in the CHOP regimen, you're talking about that kind of, a neoplastic B cell clone. Here you're talking about definitely a hyperactive or hyperplastic B cell clone, but not to the extent of a neoplasia. So I do think that most of our patients do go into sufficient B cell depletion with 1 gram into 2. There are a lot of there is some data in which lower doses also have been used, 500 into 2. So, of course, this is all the problem I feel clinically, and I have used 500 into 2. In fact, I've used lower dose regimens, but I feel that they tend to relapse earlier. So that is why my choice of 1 gram into 2. When I've used 500, I have found relapses.
Okay, right. So how long do you generally go for maintenance doses of Rituxan, say myositis ILD?
So 2 years is something that I would treat any ILD for a minimum duration. And that is why usually what we do is now say you're using MMF, then definitely because of the SLS-TRUE trial, most of us would treat for a minimum of 2 years. It's mostly longer than shorter, unless the patient goes on to have recurrent infections in which you feel that you should probably withdraw the immunosuppression. When you use cyclophosphamide, you use that's a little different. Our practice is different here. We use only 6 pulses of cyclophosphamide. What is used in the SLS trial is oral cyclophosphamide for 1 year, but most of us are not comfortable using oral cyclophosphamide. So we follow it up with an MMF, or in certain situations, you use azathioprine less now in ILD, but if in patients who cannot afford, we would probably give azathioprine. Rituximab, yes. See, rituximab, most of us would be comfortable using once, but maintenance regimens for ILD have not been well defined, like giving 500 milligrams 6 monthly, like we do in ANCA vasculitis. Well, that's not really well defined and well studied for myositis ILD, but in practice, we would truly base that on how the patient is doing, and if there is any relapse, we would then add on an immunosuppressive agent. But once we give rituximab, typically we would wait at least and see how the patient goes. And after 6 months, I think most of us would give it need-based. When we see that the patient is deteriorating, we would give it again.
Okay, so mostly the default will be to give once, that is 2 doses, and then just wait. If required, give. Otherwise, just don't give the maintenance Ritux, right?
Yes.
Okay, so myositis patient with UIP pattern who is not amenable with MMF and steroids, so who is not responding to MMF and steroids. So what to do next?
So myositis.
I think I'll take up this question. Then you can also answer. See, as in other ILDs and pulmonology, what we do is that if there is progressive pulmonary fibrosis on standard therapy. So for CTD-ILD, standard therapy is immunosuppression. So on standard therapy, if there is progressive pulmonary fibrosis, we will go ahead with antifibrotics.
Antifibrotic. I understood that.
Yeah. So the UIP pattern is more prone or more susceptible to go into progressive fibrosis. So maybe you can wait a bit, but have a very low, low threshold to start antifibrotics in such patient. But you should monitor them more closely. Sometimes even UIPs might not progress, even with especially with CTD-ILDs, right?
Right. Yes, sir. Inherently, the UIP patterns also in CTD-ILD has obviously a far better prognosis than the IPF, and they usually tend to stabilize with immunosuppression. But I think this is the only pattern in which a little bit, most of the times I usually refer in this situation to a pulmonologist, and most pulmonologists would add an antifibrotic and watch. But if the patient is rapidly progressing and there are other indicators of inflammation, then I think we would change the immunosuppression. That would be the only situation in which in an UIP, if I I would feel that I would change the immunosuppression. Like if it's MMF, then I would consider something like tacrolimus if it's a myositis ILD.
Yeah. So do you see HLH with rapidly progressing CTD-ILD?
I haven't seen too much of rapidly progressive ILD. Typically, the ferritin would be high, but I've not seen a HLH, so to say, the full definition of an HLH.
Yeah, possibly I'll agree with you. So it's not particular to ILD or MDA5, that's to my knowledge. And but macrophage activation syndrome, which is the kind of HLH which occurs with CTDs, it can occur in CTDs as a standalone entity. It might not be, to my knowledge, it is not related to the ILD, I think.
Yes, and it's relatively rare in myositis compared to other subsets
SLE,
like
SLE,
lupus and AOSD, Still's disease. That's a subset. Myositis, I totally, in so many years, I've probably seen just one HLH. So I think it's rather rare in this subset.
Right. So is there any criteria when to start treatment in SSC ILD? Possibly this has been already taken up. We'll skip it.
Yes.
When to start, all other no clinical symptoms of OP pattern. So yeah, so serology negative, there's an OP pattern and there is Rho52 positivity. Then what to do? Do we call it antisynthetase? How do we treat that kind of? So Rho52 ILD is a very kind of typical subset which progresses rapidly, and you made a good reference that it is suspected that it may be one of the anti-synthetase, at least the phenotype might be like an anti-synthetase syndrome. So do we have any defined treatment for this particular subset, or should we go aggressively? So please, your thoughts on that. And if any of your rheumatology colleagues want to intervene here, especially in this particular thing, I'll be most happy. Yeah, Manjita.
Yeah, so I would say that Rho52 tends to be a very unusual autoantibody, but in this particular context of ILD has been found to be a poor prognostic marker and has been associated with more severe forms of ILD, especially in antisynthetase ILDs. This isolated Rho52 positivity with an OP, then you would treat it like an autoimmune or myositis associated. But like I said, we don't obsess so much about the autoantibody as much as the clinical presentation and progression. So it would be treated like how we would treat OP otherwise. If there is a Rho52 positivity, then we would add on immunosuppression. So either that's what I'm saying, which is the best immunosuppression, which should be started first. These are very, very debatable in the absence of basically, we do not have head-to-head trials to say that you must start MMF I would say, or you should give tacrolimus. So like I said, MMF is a commonly used choice, MMF or tacrolimus in these settings. So that's labeling is an issue. Labeling, I don't think, like I said, I often end up keeping diagnosis a little open, put a query somewhere and say this is not very clear. And I don't let that come in the way of me treating a disease. And I think this is how all rheumatologists are aligned here. So Rho52, poor prognostic factor, treat. Yeah.
So in a rheumatology workshop, in an ILD workshop with a rheumatologist, I heard that Rho gives different shades to diseases in different CTDs.
Yes.
Rho positivity means something different. Yeah, means different things in different CTDs. Could you just tell me in brief in 1 minute that Rho52, Rho60, and when Rho unqualified Rho. So what is the difference? How to interpret?
Actually, when we say unqualified Rho, it's mostly Rho60. Rho60 is the one that is associated with primary Sjogren syndrome. Now, Rho52, on the other hand, it does occur in primary Sjogren syndrome, but when we typically find a Rho52, you will not label it primary Sjogren's because it's not, 60 is the one that's specific. So when we find Rho52, like when there have been studies of Rho52, it has been positive in other autoimmune diseases and myositis, and also has been found in the general population without any autoimmune disease, a certain subset. So that is why interpretation is very important. So what has happened with this Rho52 is because of people getting random blots done without any pre-test probability of an autoimmune disease, you end up with a lot of patients having a Rho52 positivity, which you are left to interpret without any autoimmune disease. So I think context is very important. So like I said, it can occur in the presence of Sjogren's, it can occur in presence of systemic sclerosis, it can occur, Rho52 can occur. And typically only in myositis and ILD setting, it is thought to have a poor prognosis. In other situations, like if I have Rho52 positive in systemic cirrhosis, but there's no ILD, yes, I would be more watchful for an ILD, but nothing else. It would not change the way I treat. On the other hand, if I find immunoblot positivity in patient who has some fibromyalgia-like features and a Rho52 positivity, I would ignore it. So context is very important. Dr. Sarjan?
Sorry, Banzita, we'll end the discussion here. Please stay back for the discussion at the end if we have time. And
Right,
we'll have Dr. Varun joining here. So please unshare your slides.
Right.
And we'll have Dr. Varun next.
1 second. Thank you, Dr. Sarjan.
Thank you so much. So next we have Dr. Varun Dheer. He has done his MBBS MD from AIMS, and then he joined SGPGI to complete his immunology fellowship. And he's now professor in the Division of Rheumatology and Clinical Immunology in the Department of Internal Medicine at PGI Chandigarh. His research interest areas are rheumatoid arthritis, spondyloarthritis, study of methotrexate, especially in rheumatoid, and T-cell immune-based mechanisms in CTDs. Dr. Varun, are you there, sir?
Yes, Sajal, I'm here.
Yeah, you can share your slides. Extremely sorry for the delay, because we had planned the discussion at the end, but some speakers wanted that they be free after their lecture itself. I can see your slides, sir. Please make it full screen and just go to the next slide so that I can check the movement of the slides. Just go to the next slide once. Yeah, sure. It is moving, sir. I can hear you well. I can see the slides. Please start, sir. Thank you.
Okay. Hi. Good afternoon, everybody. It's a pleasure to be part of this INPF comprehensive ILD program. And Sajal, if there's a problem in between, just give me a WhatsApp. Thanks, Sajal, Dhuria, and Vijay Hadda for inviting me here. So I'll straight away start off. Unlike the other connective tissue diseases, rheumatoid arthritis is special in the sense there's a lot of things which go on in the lungs, much more than interstitial lung disease. In fact, if I were to say that interstitial lung disease is much less common in rheumatoid arthritis, and probably airway diseases would be equally common, if not more common, and especially lower airway diseases, bronchiolitis, it has been shown to be pretty common. And especially on, HRCT or autopsy have been found. But the topic here is interstitial lung disease. So interstitial lung disease is found in around 30%, and on HRCT and autopsy. That means when you're really looking for it. And obviously, you would all contrast this with the previous speakers like myositis and scleroderma, where interstitial lung disease is much more predominant. Clinically significant interstitial lung disease, that is that if the patient is symptomatic, or you find, as a clinician, we find the patient's chest to be active, having crackles, is much less common. It's around 10%, and probably I would say maybe around 5% of what we see, just a random figure. And going on to the risk factors and epidemiology, so typically it postdates the onset of arthritis by around 5 years, more common in males than females, more found in a seropositive disease, typically associated strongly with strong RF titers, but also CCP to some extent. CCP, in fact, is also related to the lower airway disease. And obviously, having an aggressive baseline disease, that means having aggressive rheumatoid arthritis, or having extra-articular manifestations like nodules, which is again a manifestation of a severe RA, all have increased the risk of having interstitial lung disease. And obviously, heavy smoking, just like in this IPF, is an association. Of course, this I think there has been a paradigm shift with the genetic polymorphisms which have come in, especially MUC5B promoter variant, and which has been shown now, apart from IPF, to be strongly associated with RA-ILD as well. And this was a study which had around 60 patients with RA-ILD, 60 patients with RA without ILD, and around 200 or 250 controls, if I'm right. And they found that, there was a significant, whether you looked at RA-ILD versus the controls or RA-ILD versus RA without ILD, all of them, the odds ratio was around 3 to 4. But if you looked at UIP pattern, the odds ratio was much more, around 6.1. Again, going, somewhere aligning with the fact that IPF has a strong association with this variant. Now, obviously, I don't need to go through this slide. It's the same. Majority of our patients, depends on the series you're looking at, but supposed to be, the traditional teaching has been that RA has more of UIP, unlike, let's say, what Benzita talked about, myositis ILD, or even scleroderma ILD. So RA-ILD has much more of UIP. That's the standard teaching, but would depend on series to series. And obviously, I'm sure pulmonologists know it better than us, that one pulmonologist to another and one radiologist to another, this NSIP and UIP changes quite often. But of course, organizing pneumonia, again, one of the things which has been talked about, generally can be rapidly progressive, is also a feature of RA-ILD. So typically, how do we detect RA-ILD? And typically, these are patients who, RA patients who come to us rheumatologists, and they're symptomatic or on the general screen at baseline. We find crackles in their chest, or they complain of dyspnea or chronic cough. And then we do a chest X-ray and an HRCT often. And once we find these reticulations or some traction bronchitis, we refer them to pulmonologist. And that's how this goes on. Sometimes it also happens that these patients actually reach a pulmonologist. And these are often the patients in whom the rheumatoid is not very florid. It's like palindromic. That means it comes and goes. The patient currently comes with mainly ILD, but there's a history of arthritis in the past. And when you do the serology, it's strongly RF positive and strongly CCP positive. Now, it's a moot question whether you would label these patients as RA-ILD or IPAF. But that is where I leave it. And of course, generally, that's about all the evaluation we do. A pulmonary function test and an HRCT, very rare to go for any kind of biopsy, especially as I'm sure it has been alluded to in all the talks till now, for at least CTD-ILD. For us, at least as rheumatologists, I know pulmonologists would differ. The patterns are not very important. What is more important is how severe is the ILD. And I'm sure, obviously, pulmonologists would differ, especially for antifibrotic therapy. But for us, so therefore, no biopsies are traditionally done, neither in RA-ILD nor other CTD-ILDs, for just finding out the pattern. And typically, further evaluation is to rule out, concomitant illnesses or something which is masquerading as ILD, which could be an infection. And so some abnormal patterns, maybe some large lymph nodes, necrotic lymph nodes may trigger a further investigation. Now, this I have already covered. So the question is whom to treat. I think this question came up in the last talk as well. And I think that typically there are two things in which we want to treat patients who are severe at presentation. Now, the moot question is whether you take a cutoff of 70% FVC or 65%, depending on center to center. We don't have, as of now, with the study from GO, which was in scleroderma retrospective study, the cutoff used is typically 70% FVC, so which is now used across all, whether it's RA-ILD. That was obviously for scleroderma ILD. So typically FVC less than 70%. I have not written DLCO because we hardly get a chance to get it often to do it in our routine patients. And obviously the second is if you definitely have a patient, if you're lucky enough to have a longitudinal records of FVC and you see that it's declining, then obviously it's not rocket science that all of us are going to treat this patient, because unless you treat, the progression is going to go on and the patient at some stage is going to get into a respiratory failure or severely functionally disabled. Now, treatment is unlike, let's say, scleroderma ILD, where the role of glucocorticoids is not there. but similar to myositis ILD, rheumatoid arthritis ILD, there's a role of steroids. How much remains debatable. In general, in most of our diseases, we are going towards a low steroid regimen. So although we start up, we try to taper down quickly. Of course, the severity of presentation will also determine how much steroid you're giving. So rapidly progressive ILD or organizing pneumonia in RA-ILD would also mandate methylprednisolone in many cases, pulse steroids, I mean, around 500 milligram or 1 gram daily for 3 days. And there is some, again, as has been mentioned by my previous speaker, that there are no actually randomized control trials to say that steroids work and what dose works and things like that. But we have some, evidence from various observational cohorts or centers specifically. Now, so we have a bouquet of immunosuppressive like in the other diseases, which is IV cyclophosphamide, mycophenolate mofetil, rituximab. These would be the top 3, followed by tacrolimus and azathioprine. And now, typically, I've written the doses we typically use, which would be kind of known to most of the people. The more important part is that, obviously, one of the questions is which agent to choose. And I said, among the first 3 agents, if you can see that the cost differs a lot. So the cost difference is almost around, for 6 months cost I've calculated is around 6,000 rupees for cyclophosphamide infusions. Obviously, this is for a government sector where infusions are not charged for. Giving the infusion is not charged for. Apart from this, what do you call it? MMF and rituximab are the 2 costly ones. So MMF, again, the MRP is pretty high, but often companies directly give it to the patients at much cheaper rates. So you can have a variation, which I have written. So MMF and rituximab would be the 2 expensive one, and azathioprine again would be the cheaper one, almost 1,000 a month. So what is the evidence? Which of these is better? So we have evidence for most of the case series, just showing that, individually they all work in all of these. The largest study which has come recently is the study from Matson et al., published in April of this year in Chest. And they've studied 212 patients with rheumatoid arthritis. Now, again, the point I was making is well proven here that, look here, the non-UIP pattern were in fact the predominant patterns in this cohort, unlike the traditional teaching. And again, if you can see here that, the male sex was only around 40%. So majority were actually females. But again, predominant males, what do you call? In general, are supposed to be more at risk of RA-ILD. Again, then you can see here the seropositivity was high in this cohort, and the median follow-up was around 2 years. The forced vital capacity at baseline at treatment initiation was around 67% of predicted, and the DLCO was around 50% of predicted. So what is important just to point out here is that in this study, they had around 200 patients. So they've done 300 FVCs before, PFTs before treatment, and 530. So almost every patient had 1 PFT before starting the treatment, and on an average 2 PFTs after treatment. And this is what they've used to make a trend. The treatments they used, it's an observational study, retrospective database study. See here that no patient received cyclophosphamide, so which is a big difference from what we use at our center. And typically MMF, big favorite, and azathioprine surprisingly was a big favorite at their center. Rituximab was also used. So of course this would change, probably rituximab would come up more, depends on rituximab have come up recently, so probably much more in use now. And what they showed here was typically that, what they used is a model. So they predicted that suppose they had continued on the same trajectory which they are without the treatment, the decline would have been here with the shown in the blue dotted line in the graph. Like suppose it started around 75% FVC, would have gone down to 60% by 24 months. Whereas post-treatment, it actually, the red line shows the actual, and they found that a difference of 4%. So there was a stabilization with the treatments, but they did not find that there was any difference between the various groups. So it didn't matter whether you treated with azathioprine or mycophenolate mofetil or rituximab. They all did reasonably well. The only little bit different numerical difference in DLCO, which found that rituximab was probably the best in terms of went up by 7% versus 4% with MMF, and azathioprine only 2%. So as I said, the choice of immunosuppression, and I think this question would come up again and again, apart from scleroderma ILD or systemic sclerosis ILD, where we have randomized controlled trials, once you don't have level 1 evidence and you have mostly cohort studies, observational studies, and many agents which are useful, no head-to-head trials, very difficult to say this is better than that. It depends a lot on individual center experience and the cost. So like, as I said, we use a lot of IV cyclophosphamide, one, because of the comfort over years, which we've been using it for the other diseases, including vasculitis. And second is obviously for the cost reasons. We are a government hospital. So obviously, immunosuppression also depends on the contraindication. So you get somebody with chronic liver disease, chronic kidney disease, you might avoid MMF. A high risk of infections, elderly individual, you might avoid cyclophosphamide, more go towards azathioprine, a milder agent. If you a female patient, younger one by chance, and wants to conceive in the future, or you're not sure she's using contraception, you like to avoid cyclophosphamide and MMF, rituximab would be a good choice here. And again, prior malignancy, maybe you would avoid cyclophosphamide. Again, in this, if you have a very active rheumatoid arthritis, that is where I think there's a big advantage of using rituximab, covers both the joints and the lungs. And this is the reason why it has picked up to some extent. So I think I'll end here, and
thank you so much. Thank you so much, sir. It was very clear and concise. So we don't have many audience questions, but I have a lot of questions to ask. The first conceptual thing that I want to ask is that several of these autoimmune diseases, they are associated with antibodies, and a lot of times there is seronegative disease. So does the pathomechanism of pulmonary manifestations or other extrapulmonary manifestations, does it depend on whether a disease is seropositive or seronegative? And accordingly, do we opt for different kind of targeted treatments?
Yeah, I think that is a valid question. I'll take up the second part first. That definitely rituximab for RA joint disease has been shown to be effective more for seropositive disease, and typically we hasn't been shown to be very effective for seronegative disease. So typically rituximab is only used in people who have RF positive or CCP positive. The second thing is the pathomechanisms. I'm not sure, but definitely what happens with seropositivity is much more aggressive disease if you compare it vis-a-vis a cohort of seronegativity, and more of extra articular manifestations like ILD, nodules, and things like that.
My next question is, sir, I have seen you use a lot of cyclophosphamide. If you look at the SLS data, the first trial, MMF was supposed to be working similarly as cyclophosphamide and with better tolerance. Although I agree that it was just 1 year of cyclophos followed by 6 months of cyclophos followed by azathioprine. So how do you view it? Like if we get a fresh patient with rheumatoid arthritis ILD or even systemic sclerosis ILD, should we prefer cyclophosphamide over MMF, or MMF is good enough? Is there any way to decide between the two?
So I think the first point is that I'll take up again the second part of your thing, that MMF versus cyclophosphamide. So there's no doubt. Just look at the study I showed you. No use of cyclophosphamide in that study from the West. So the West has kind of, whether it is vasculitis, whether it is lupus, or whether it is interstitial lung disease associated CTD-associated ILD, RALD, the West has basically given up on cyclophosphamide to a large extent. Except West, I mean, especially the United States. If you look at Europe, still rheumatologists would be using a lot of cyclophosphamide in France and all. And in India, we still use a lot of cyclophosphamide. The reason the West gives for going away from cyclophosphamide is the toxicity, which is both acute in the sense that, once you give cyclophosphamide to a patient, the patient can land up in 15 days with the neutropenia. We give a dose of, let's say, 750, 1 gram, how much ever you give. Sometimes it overshoots what the body can take, and you can have a transient neutropenia coming. So what my belief is that it's also driven a lot by the scare in the West that they don't use cyclophosphamide. And again, the risk of future malignancies, which might initiate legal action and things like that. I don't know if that is a concern. For us, why we are using so much of cyclophosphamide, I said, is again, I told you that MMF, the problem with MMF is the cost, number one, for us in the government hospital, scientifically speaking. And the second reason is that our, cyclophosphamide is like a fill it and shut it kind of a regimen, just like rituximab. It doesn't have any pill burden. You get 1 injection a month. MMF, you have to take 2 tablets in the morning, 2 tablets in the evening. There'll be GI side effects, things like that. So,
Sir, I'll just intervene a bit. Like, can we say that cyclophosphamide hits the disease early and hard? Is the concept like that, or it's not like that? Like in intense disease, say intense inflammatory disease, will cyclophosphamide work better initially than MMF?
Yeah, there's no doubt about that. Whether you look at lupus nephritis, crescentic lupus nephritis, RPRF, that means rapidly progressive renal failure. Whether you look at rapidly progressive ILD, in all those regimens, the West will still use cyclophosphamide. The reason for that is the cyclophosphamide is one of the most potent immunosuppressants. So if you have to make a potency chart for immunosuppression, cyclophosphamide will be at the top. And then followed by, MMF MMF and tacrolimus, CNIs and MMF, and then azathioprine, and then methotrexate comes much lower. So that would be and rituximab and things. Rituximab would also probably come around cyclophosphamide, below cyclophosphamide. So you're right, cyclophosphamide is one of the most potent we have. And as I said, there's no, as such, it depends on center to center with your experience and what you've practiced when you've been training and what you're comfortable with, your patient profile, and how much toxicities can you take, and things like that.
Sir, does cyclophosphamide and azathioprine, do these drugs have a good articular action on like articular disease?
Yeah, so that's a good point. That's what I said. Rituximab would be the only drug among these which has a very good articular action. And the other drug which would have a good articular action is azathioprine. Typically, cyclophosphamide and mycophenolate mofetil have a poor articular action. And sometimes
azathioprine works okay with joints?
Yes, azathioprine actually works well. And in fact, there has been a randomized control trial initially, having a head-on-head trial of azathioprine with previous treatments in RA, and it did pretty reasonably well. The reason we are not using azathioprine routinely for RA arthritis is the problem that azathioprine over time, if you use it for a long time, is associated with the risk of malignancies like AML. So typically, we don't want to use it for a long period in people. And as you know, RA is a chronic disease, lifelong disease. So typically, we don't like to use azathioprine beyond, let's say, 3 to 5 years. Whereas methotrexate, we are very much comfortable with. So that is the reason.
Yeah. Where does methotrexate fit in the treatment of RA ILD, sir?
Yeah, so I think that is definitely, I don't think I've ever come across or I've ever treated somebody of ILD with methotrexate. The question is that, more important question is, would you stop methotrexate if you have ILD in an RA patient? And increasingly more and more, unlike when I was training, if the moment you got ILD, you would say, no, I don't want to treat with methotrexate. And maybe I'll prefer sulfasalazine or leflunomide. Obviously, later on, there was data from Japan that leflunomide can also cause exacerbation of ILD, actually. So the scare all the time was that whether methotrexate by itself, because it can cause a hypersensitivity, drug-induced lung injury, which can come at any time. And so would that be a problem, and would that lead to more progression or things like that? But over time, we become more comfortable. But still, if there's a patient of severe ILD, definitely I'll avoid methotrexate. Severe means, again, and this is again empirical, is like an FVC maybe less than 60%. Somebody who has, but if it's just around 65, 70%, we continue methotrexate, and probably now increasingly along with other drugs, we'll continue methotrexate. Most of us would continue methotrexate and not be that scared as we were earlier that, maybe we're causing a problem and it'll cause a problem in the ILD per se.
But can't we treat RALD with methotrexate upfront, like using it as a preferred agent? Rather than, because there's a lot of now data that yeah.
Okay, so I'm not aware of the data, and I've never actually used methotrexate for ILD in RA. There was data that methotrexate can be used for ILD in dermatomyositis initially. There was quite a bit of data, and using methotrexate as a azathioprine combinations also there is data. But that was predominantly what I'm aware in myositis ILD. In RA ILD, whether anybody has used, I was not aware. If there is data, you can share it. Yeah, I have no idea.
The role of tofacitinib in RA ILD, one of the audience
so
questions.
I don't think, unlike what in RP-ILD or MDA5, as Benzita said, where there is a role. But I think, as I've emphasized here, that among all the diseases of CTDs or RA included, if we included them into a basket, RA would be the least common cause of ILD per se. So therefore, the fact of the matter is that you would, I don't think we would have enough experience there. And probably, as you have been seeing, probably if you look at your registry as well, I don't know if you can see that vis-a-vis the other myositis ILD, antisynthetase, and scleroderma ILDs, how much RA ILD. And in fact, much of the RA ILD actually we see is often IPAF as well, where the arthritis is very minimal and there's much more of seropositivity, occasional arthralgia, arthritis, documented, undocumented. So that's my view, that I don't think we have enough data on it, but
yeah. Another question which has been asked in other CTD-ILDs also, that if you have signs of fibrosis, say a UIP pattern, then do you go for antifibrotics upfront or you wait for progression?
So I think that is typically, I think there we defer to the pulmonologist. So we totally refer the patients to you. And antifibrotic is something, at least as a physician, rheumatologist, I'm not comfortable with. So I know a lot of people, and there is a lot of now data building up, and whether you would use them together and things like that as well upfront in some cases, like if you look at a high fibrotic burden and things like that. But I don't know. So I haven't really used nintedanib or pirfenidone, and hardly, just count on my thumb. And generally, we refer them to you. I'm only comfortable with using immunosuppression, but not too much of antifibrotics in these diseases. So I won't be able to.
Again, I'll repeat the same answer which I gave. So with rheumatoid arthritis or any CTD-associated fibrotic patterns, sometimes these patterns are very stable with immunosuppression itself. So we might wait before we really add antifibrotics. And IPF will start with antifibrotics, will not use immunosuppression. But with CTD-ILDs, even with fibrotic patterns, we'll wait for at least some sign of progression, some sign of non-improvement with the immunosuppressive treatment, and then possibly add, because each drug adds to the side effect profile. And the more important drug in case of CTD-ILDs is the immunosuppressive drug. When do you stop? What is the role of glucocorticoids, or how do you place it in the RA-ILD treatment? Do you start
So
with
like I said, that
high doses, low doses?
Generally, yeah. So generally, typically, we would start at somewhere like 0.5 to 1 mg per kg per day, prednisolone or equivalent. Generally, we are using prednisolone. So for a 60 kg person, we start with 60 milligram prednisolone. The difference is that nowadays, after we used to carry on for a month with 1 mg per kg and then slowly taper by 5 mg every 2 weeks. What we now have started doing more and more, and this is across diseases in rheumatology, is to cut down steroids quickly. So even if we start at 60, probably after 2 weeks, I'll be more comfortable getting it down to 40. At 4 weeks, getting it down directly to 20, and then going for that 5 milligram every 2 weeks reduction. So that is what we've started doing. Some of this data has come from ANCA vasculitis that reduce steroid regimen. Some of this data is driven by lupus, that we were finding more and more of steroid toxicity. So, and So that is what, even if we, and sometimes we just start at 0.5 mg per kg and not 1 mg per kg. So that by the end of, earlier by that we were targeting around 10 mg at the end of 6 months. Now we target around reaching 7.5 to 10 by the end of 3 months. That means we are on a maintenance kind of steroid dose. Now the question is, after that, do you continue the steroids or not? That is a difficult question, because 50% of RA patients anyway remain on low dose steroid even for their joints.
Yes. Any questions from the panelists you might ask, you would like to ask yourself? Dr. Abhishek, do you want to ask any question?
Yes, Sajal. Hello, Dr. Varun. Sir, I wanted to ask what if there is any difference in oral versus IV cyclophosphamide for RA-ILD. We know that the evidence is for systemic sclerosis ILD, but is there any difference in two therapies, oral and IV, for RA-ILD?
Oh, so thank you for that excellent question. And I think, yeah, the SLS1 trial, like probably we mentioned it wrong, was an oral cyclophosphamide trial for 1 year. So again, the problem that, again, the issue here is that, as you were talking about rituximab with Benzita, where rheumatologists have started using 1 gram into 2, whereas most of the regimens which came from lymphoma were 375 milligram per meter square weekly into 4. And similarly, IV, majority of the times, most of us from our training have started using IV cyclophosphamide, and we have hardly, I don't think I have used oral cyclophosphamide in maybe I can count them on my fingers patients. The problem is the cumulative dose, because if you're using 100 milligram oral cyclophosphamide per day, per month you're giving 3 grams of cyclophosphamide. Vis-a-vis you're giving IV cyclophosphamide, per month you'll give maximum 750 to 1 gram cyclophosphamide. So over 6 months, you're reaching a cumulative dose of 18 milligram with oral cyclophosphamide versus just around 6 grams or 5 grams with IV cyclophosphamide. And that is an important factor for future development of malignancies, bladder toxicity, things like that, as well as infections. So therefore, again, what your question was on efficacy, and we don't have data for that, but I don't think now across most of the rheumatology centers that anybody is using. Most of the dermatology centers have also shifted to IV cyclophosphamide, although occasionally I still see dermatologists use oral cyclophosphamide. So the reason is toxicity, but efficacy, I don't think there's a head-on-head. There was a head-on-head for the ANCA vasculitis. That was the Cyclops, and that didn't show much of a difference. So ANCA vasculitis shifted to, so we have like this kind of evidence, you know, in one disease for something totally different, and we use it across. So rheumatologists are good at that. we operate with limited evidence, but I don't know whether it's right or wrong, but we often do that.
Thank you, sir. Another question I wanted to ask is, for RA-ILD, my practice is I usually start with steroids and then start tapering the dose as soon as possible, just like you mentioned. And whenever there is a recurrence of the disease, then I start steroid sparing agent, like you mentioned, methotrexate. Usually I prefer, or mycophenolate, or other drugs. So what is your practice? What is your thinking? Then do you start steroids along with immunosuppressive from the start, or you still start with steroids and then you add other drugs?
In which disease?
In RA-ILD, sir.
Okay, so so now again, this is going across, you know, again, as a general rule, we in all major diseases, we are starting now immunosuppressive along with the steroids initially. And again, there are pros and cons of both. Of not starting, obviously, is that some patients would just do well on oral steroids, and why to give them an additional agent. The con is obviously that in the patients who require the additional agent, you would have delayed and maybe some progression would occur by the time you realize, because obviously you will start only when you start tapering or there is a recurrence or relapse. So, but in general, we, most rheumatologists would like to start initially as well. If you made a decision to treat, most of us will treat with immunosuppression plus glucocorticoid, not glucocorticoid alone. In whether it is RA-ILD or other CTD-ILDs.
Okay.
If a decision has been made, then we'll generally use both.
Okay.
Yeah. Thank you so much, sir, for your excellent lecture and a lot of knowledge that we have gained from this discussion. So next we'll move on to the next lecture, which is
thank you.
Thank you, sir. Thank you, sir. Which is interstitial pneumonia with autoimmune features, and I invite Dr. Aadhar Dhuria, who is a DM in clinical immunology and rheumatology from PGI Chandigarh. He is working as assistant professor in the Mahatma Gandhi College and Hospital, Jaipur, as an immunologist and rheumatologist. He has about 25 papers in peer-reviewed journals. He has a special interest in vasculitis also. So over to Aadhar. Aadhar, are you there?
Yes, I am there.
Yeah, so please start sharing your slides.
Yeah. Thank you, Chairperson, for giving me this opportunity. So half of my work has already been done by my peers and seniors. So I'll be briefly talking about interstitial pneumonia with autoimmune features. So I have no disclosures. We'll be talking about definition, diagnosis, clinical relevance, and their treatment principles. The idea is, it is to identify individuals with idiopathic interstitial pneumonias and features suggestive of, but not definitive for a CTD. So on one of the end of the spectrum, you have the IAPs where there are no features of autoimmunity. On the other hand, you have the CTD-ILDs where there are well-characterized CTDs such as Sjogren's or lupus. And somewhere in between lies IPAF. So what it replaces is undifferentiated CTD-associated ILD or UCTD-ILD, lung-dominant CTD, and autoimmune featured ILD. So these are the three things that it replaces. So now we have a single common definition for the same. So how do you diagnose it? Because in diagnosis lies the clinical manifestations. First, you need to have an evidence of an interstitial pneumonia. Then, and it's not compulsory to have a surgical lung biopsy. Then you need to have a thorough clinical evaluation. Patients should not meet criteria for a defined CTD. CTD, ILD, and IPAF are not interchangeable terms. And then you need at least one feature from 2 of 3 domains: clinical, serologic, and morphologic. So in the clinical domains, you have mechanic hands, distal digital ulcerations, inflammatory arthritis or polyarticular joint pains. So just arthralgia is not enough. You need to have arthritis. It is swollen joints, early morning stiffness and pain. And palmar-telangiectasia is something you might also see in smokers. Raynaud's phenomena, unexplained digital edema, that's like a surrogate for puffy hands of MCTD, and the Gottron sign. And so if you look here, these are the Gottron signs. These cuts that you see, these are the mechanic hands. So only these 7 manifestations are in the clinical domain. So what is not there? Alopecia, photosensitivity, oral ulcers, weight loss, sicca, myalgia, younger age, female sex. So whether the patient is male or female does not make a difference for a diagnosis of IPAF. Age does not make a difference. Alopecia, photosensitivity, oral ulcers will go more towards a lupoid, lupus-like phenotype, so they're excluded. Sicca is excluded. Myalgia and arthralgia are excluded mainly because they're very non-specific. Then you have the serological domains. So what we need to note here as a pulmonologist or a non-rheumatologist, that the titer that you require is more than equals to 1 is 320. The pattern is diffuse, speckled, or homogeneous. Why so? Because these are all patterns which are seen more commonly with a defined connective tissue disease. However, an ANA nucleolar pattern or ANA centromere pattern of any titer goes. And that is mainly because of the high incidence of these titers with ILDs. The rheumatoid factor has to be at least 2 times the upper limit of normal. Then you have the specific antibodies, anti-CCP, dsDNA, Rho, La, ribonucleoprotein, anti-topoisomerase, all the tRNA synthetase, anti-PMSCL, and MDF5. Now, there is some controversy regarding the inclusion of anti-tRNA synthetase and anti-MDF5 because a lot of people who are working on IPAF believe that these are actually the myositis spectrum patients who have just come early. But till the time we have that, so this is the current definition. So how might you test? I've shown you so many antibodies. So the first tip for the non-rheumatologist would be always order a rheumatoid factor in right quantitative. Do not go with the latex agglutination tests, which are cheaper, done more commonly, and are reported as positive or negative. That's not good enough. If your RF is negative, your threshold is high, go for an anti-CCP. The anti-nuclear antibody, if you're ordering, has to be in dilution only by immunofluorescence. ELISA is not an acceptable method. Without dilution, won't work, because 1:40 is something you'll start seeing very commonly up to 20% once the age of the patient increases to the 50s. Better is to do an ENA profile by ELISA, which will give you all these separate antibodies. But cost issues and some inclusion of some myositis antibodies might help you choose an ENA blot. And you can consider getting a myositis profile if you still believe there's a higher probability and everything else is negative. Then comes the morphological domain. So you have 4 patterns which are included. You have an NSIP, OP, NSIP with OP overlap, and LIP. Then you have the histological patterns, these 4, plus interstitial lymphoid aggregates with germinal centers and diffuse lymphoplasmacytic infiltration. And then the third part is the multi-compartment. There is an unexplained pleural effusion, unexplained pericardial effusion, and unexplained intrinsic AV diseases. Now, this is what you'll not see usually with IPF. So what about UIP? So UIP is not an exclusion criteria for a diagnosis of IPF. You can still diagnose a patient with a UIP as a usual interstitial pneumonia as an IPF. But the UIP will not carry any weightage. You will require criteria from other domains. I'll give you an example. So this is what I'll suggest. You have a pattern on HRCT, which is an NSIP, OP, NSIP with OP or LIP, or you have a patient with UIP and you have a multi-compartment involvement. Then look for the clinical clues and or serological criteria, and you need 2 of these 3. So let's take this example. So this is a 60-year-old male that came with type 1 respiratory failure. These are published cases. And the CT was organizing pneumonia, anti-OJ was positive, clinical domain was not fulfilled. Patient was diagnosed as IPAF, treated with steroids and immunosuppression, improved. So you have 2 of 3. You have the radiological and you have the serological. Let's come to the second case. An 80-year-old male, the CT shows IPAF, as Madam had beautifully shown in the morning lectures, a lot of honeycombing here. ANA was nucleolar, rheumatoid factor was positive. Now, but nothing clinically. But because I highlighted with these arrows, you have this pleural thickening. So this pleural thickening or multi-compartment involvement makes it fit into the criteria for radiological domain. So had this pleural thickening not been there, even with a positive rheumatoid factor and a positive ANA, patient will not fit into IP. And then you're more likely to go with an IPF. So this is not about prognosis, but you require the multi-compartment. So what is the clinical relevance? So you already have IPF, you have the other IIPs, you have CTD-ILD. So why talk about IPF? There are 2 questions. One is for us, how likely is this patient going to progress to a specific autoimmune disease? And 2, are the outcomes for IPAF different from CTD-ILD and IPF? This was an interesting study published just this year. And it was a multi-center study, and they looked at the progression and prognosis of interstitial pneumonia with autoimmune features. They recruited 191 patients, majority were female, and they excluded the tRNA synthetase patients. 27% of the patients had all 3 domains, clinical, morphological, and serological. And then you have the mix of all 3. And 24% of these patients developed systemic autoimmune disease over time. So there is a relevance to finding the antibody. Because once they develop these specific autoimmune diseases, the management becomes more complicated. You have more domains which you need to take into consideration before treating. And so this was over months 3 to month 75. And over time, the progression was seen. So they had patients with lupus, rheumatoid arthritis, polymyositis, antisynthetase, dermatomyositis, systemic sclerosis. A lot of patients with Sjogren syndrome. So like we have been talking in these sessions about Rho 52, so that's where the importance comes in. So what are the factors predicting progression to systemic autoimmune disease? With Sjogren syndrome, positivity of Rho 52, Rho 60, and a cytoplasmic DNA. For myositis, mechanic hands, an OP pattern on HRCT, positivity for PMSCL and MDA5. For systemic sclerosis, again PMSCL, SCL70, and presence of pulmonary telangiectasia. These are the patients who will have to be a little bit more watchful just from the PFTs and ADLs use. So next comes, are the outcomes different for IPAF? So once the criteria were released, there are a number of retrospective studies. The Oldham cohort, they said IPAF is slightly better than IPF, worse than CTD-ILD. Now, if you divide IPAF into UAP IPAF and non-UAP IPAF, the UAP IPAF is similar to IPF and non-UAP IPAF is similar to CTD-ILD. This is a little bit of an oversimplification. In another study, Ahmed and colleagues found IPAF and IPF as bad as each other. However, UIP pattern is not associated with survival. So they said all IPAF is as bad as IPF. These are the major cohorts published in review. So if you look, the Oldham, Chartrand, and Ahmed. So Oldham had a lot of surgical lung biopsies, and they had 61 patients with UIP on biopsy and a corresponding death as an outcome of a 40% death. Among the other series, this goes down to 12%, where the UIP is much lesser, whether by HRCT or otherwise. So this had almost, Oldham had at least around 54% UIP, it's around 28%. Well, death rate does vary, but still remains significantly high. So these are patients who are not going to be as mild or as benign as a CTD-ILD. And identifying this subset as prognostic significance, and like you're going to see, has treatment significance also. So I tried to put all these studies together. So this is the latest 2021 G et al. And they said, CTD is better than IAP. IPAF is same as IPF. And there's a lot of contradiction, but what people do believe is that just like CTD-ILD is better than IPAF is better than IPF. And I'll probably agree with Limatal at the bottom, that this is how it actually goes. So now comes the tricky part. How do you treat these patients? So this is what I do. So I start with corticosteroids. And so this was a multi-center study from the NRIA registry. And they treated patients with everything. Antifibrotics, tofacitinib, abatacept, TNS, RTX, name it and they've given. And they found that if you look at this Kaplan-Meier survival curve, the NSIP pattern has a slightly better survival. The UIP has a slightly worse survival. Others seem to lie somewhere in between. And what they found was the UIP has a poor prognosis as compared to NSIP. In NSIP, a positive ANA increased the risk. And glucocorticoids are associated with a better outcome. So that's that. Plus, let's go back to the previous cohort. So the steroid usage of 32%, death of 39%. Steroid use goes up, mortality goes down. Now, this is again an oversimplification. But you have to understand that most of these cohorts were actually retrospective, and they have applied the definitions once the criteria were approved. So they do not have the luxury of having a diagnosis of IPAF upfront guiding them regarding treatment. And some of these had a large number of rheumatologists in the cohort And so they believe that there was slightly more predominance of CTD patients in these cohorts. Then, like SSC ILD and RA ILD, I would suggest add mycophenolate more often. You have a single cohort study for mycophenolate therapy. You do not give mycophenolate, FVC goes down. You give mycophenolate, still goes down slightly less. But if you look at months before and after mycophenolate, so there seems to be some stabilization once you start using mycophenolate. So look at diagram B, the line is going down and seems to be plateauing. There is some beneficial effect. The problem is IPAF is still a very new terminology. So we're still waiting for any reasonable trials to conclude. And the trials that have already begun already started registering before the criteria was given. Third is consider cyclophosphamide. So this is an interesting study. And what they did was they used cyclophosphamide in steroid refractory ILDs. So when you use cyclophosphamide, and our concern is with IPAF, so this is the red triangle here. Before the start of cyclophosphamide, all three groups had a rapid decline. Once you get cyclophosphamide, IPAF seems to do pretty well in terms of the FVC change, and you actually have a rise. If you take it as a group, there is still a trend towards improvement. But when you take the non-IPAF group, there's a definite worsening. So the subset is behaving more like a CTD-ILD than a truly IAP. Then keep in hand rituximab. So EVER-ILD is something that most pulmonologists are familiar with. And they had a very small number of patients with IPAF, 17 in the rituximab plus MMF group and 19 in the placebo plus MMF group. So EVER-ILD basically found that rituximab plus MMF works slightly better than placebo plus MMF for the patients with ILD. So if you look at this subgroup analysis, now there is a limitation. Obviously, they have combined CTD, ILD and IPAF. But as compared to the idiopathic ILD, this group does well. And the absolute difference is as much as 4.17. This is mean change in FVC. So rituximab is a promising option. Where to give, when to give is something that's a little bit more difficult to define. And then lastly, what about antifibrotics, a drug that pulmonologists love and rheumatologists don't know where to place it? So this was the inbuilt trial, nintedanib. And this was one of the subgroup analysis which has looked at patients with HP, unclassical IAP, idiopathic NSIP and IPAF. And then the other group has the other patients. So while it still does favor nintedanib, change is less than the other patients. It's 143 versus 87. So the p-value is not significant, but the visual change is definitely there. And that goes in with the previous slide, that this is more likely to be inflammatory than purely fibrotic. And what about pirfenidone? This one of the trials of pirfenidone in unclassifiable progressive fibrotic. And 15 patients in pirfenidone group and 18 patients in the placebo group had a diagnosis of IPAF. So if you look at this subgroup analysis that I've highlighted with the pink arrow, the presence of IPAF actually indicates a much worse response with pirfenidone. So antifibrotics in IPAF probably not a very good idea. And that is why you need to be very clear about the diagnosis, especially if you have a UIP IPAF. Because with UIP alone, you would be giving antifibrotics over immunomodulators. And so make a diagnosis of IPAF, probably better not to give. And in the same lines, so this is a retrospective case series. And now they have compared antifibrotic therapy versus immunosuppressive therapy. And they stratified the analysis by the pathological presence or absence of inflammatory cell infiltration. So what they've done is they had a group of patients where surgical lung biopsy was done over 2008 to 2018. They took this cohort and they reclassified it as IPAF-UIP. Then they gave 27 patients antifibrotics and 29 patients immunosuppressive. And what they found was, if you look at this table, in the improved group, 15% improved with antifibrotics, 55% improved with immunosuppressants. If you take a composite score of improved plus stable, so you have 83% on immunosuppressants and 59% with antifibrotics. When you look at these subgroups, in this UCIP is unclassifiable idiopathic interstitial pneumonias because that is what the initial diagnosis they had. This is 15% versus 60%. And that's a massive difference. The p-values are 0.006 and 0.006 again. And now they classified the patients in terms of histologically inflammatory as well as absent inflammatory. They found that the difference is actually based on the inflammatory cell infiltration, where the p-value is significant. And if you have no inflammation, then both work nearly the same. So I leave you more with questions than answers. One is how long to treat these patients. We'll probably know more in the next 5 to 10 years. How much steroids to give, whether to pulse, to give 1 milligram per kg. Again, no idea. And what about maintenance therapy? What is the role of maintenance therapy in these patients? Should they be on azathioprine or mycophenolate for a slightly longer time? Or do you hit it and leave it? These are questions we need answers to, and probably some more trials in the making now that we have more standardized criteria. Thank you so much.
Aadhar, that was excellent. You did a very good review, and I could gain a lot of information from your review. That because IPAF, the data has been sparse, but now we see a lot of observational data at least jumping in, and we have at least some direction to proceed into that. At least some kind of evidence building up that indeed the presence of some of these features, which even if it does not fit into a particular CTD, immunosuppression might still be effective. Adar, I will really request you to stay back a bit because we have the last session, cystic lung disease, and we have an international speaker who might be joining at an odd time. So we'll take up the questions later, and we'll start with Shankar's presentation first.
No problem.
Thank you. Thank you. Please stay back. Shankar, are you there? Shankar?
Yes, sir. I hope you can hear me.
Yeah. So for the last but not the least lecture, we have a very important entity, Sjogren syndrome, which is commonly missed, and we hardly see any experts on this disease. And we have a very kind of upcoming rheumatology researcher from our institute who is looking at this disease. So I invite him to deliver a lecture on Sjogren's related interstitial lung disease. He works as an associate professor in the Department of Internal Medicine in Clinical Rheumatology Division at PGI. Shankar, you can now start sharing your slides.
Yes.
Yeah, I can see your slide. You can make it full screen and go to the next slide so that I can just check. Yeah, so it's moving. So you can start.
So good afternoon, everyone, and thank you, Sajal sir, for giving me this opportunity. So I'll be speaking about Sjogren's ILD. There is not much of data on Sjogren's ILD as such, at least on the treatment modalities. So I'll try to show whatever data is available and show the approach on how to diagnose Sjogren's syndrome, especially if you are in a patient who is having ILD and you're suspecting of Sjogren's. So for a brief introduction, Sjogren's syndrome is an autoimmune disease characterized by lymphocytic infiltration of the exocrine glands. Immunologically, it is characterized by presence of anti-Ro or the SSA antibodies with biopsy of the minor salivary gland showing focal lymphocytic cell adenitis. So it's one of the common kind of autoimmune disease that we come across in our clinics with an estimated prevalence in general population to be somewhere around 0.4%. And as with all other connective tissue disorders, females are much more commonly affected with Sjogren's compared to males. So if you look at the clinical features of Sjogren's, these can be divided into either glandular manifestations or an extraglandular manifestation. So coming to the glandular manifestations, the dry eyes and the dry mouth and parotidal and extraglandular manifestation can involve any of the organ system. Common would be arthralgias or arthritis, fatigue, cutaneous involvement, and renal involvement in the form of distal RTS and peripheral neuropathies. The uncommon manifestations are CNS involvement, pulmonary involvement, myositis, and cryoglobulin. So if you look at the data from India, on the left-hand side, the graph is showing data from our institute where we have documented that Zika symptoms are the most common manifestations, and apart from that, among the systemic manifestations, common are arthralgias and renal involvement, as I already mentioned. And lung involvement is only 4.7% in our study. And similar kind of data is published from CMC Vellore, where you can see that respiratory manifestations have been reported in only 12% of some 350 odd patients of primary Sjogren's from their center. And if you look at the data from other parts of the world, as you can see, as I highlighted, the prevalence of pulmonary manifestations is somewhere around 10 to 15% in most of the studies, except for one study from China, which has reported to almost half of the patients. So coming to the various pulmonary manifestations of Sjogren's, it could be either airway involvement or the parenchymal involvement. So I'll be speaking more about the interstitial lung disease and not going into details about the other manifestations of lung. So coming to Sjogren's related ILD, the prevalence of ILD in Sjogren's patients is reported to be somewhere around 4 to 16% in various studies. And the traditional belief is that ILD would develop late in the course of these patients. However, the recent cohort studies and other data has shown that ILD can precede the first symptom of Sjogren's syndrome, that is the dry eyes or the dry mouth, in almost 10 to 50% of the patients. And in some subset of patients, there could be simultaneous onset of both ILD symptoms and the typical manifestation of Sjogren's. In the remaining patients, we would have a presence of ILD late in the course of the Sjogren's. And the clinical features, as we all know, it would be in the form of exertional dyspnea and non-productive cough. However, the severity of ILD does not correlate with severity of extrapulmonary disease. And in one of the studies, they have reported that acute exacerbations of ILD, the prevalence is incidence is about 5 episodes per 100 patient years, with a very high mortality up to 50%. So what are the features that are associated with ILD? Various studies have reported the clinical and immunological parameters which have been associated with the presence of ILD in Sjogren's. So the most common are the elderly age, then smoking, male sex, then presence of high disease activity in other organs, then presence of Raynaud's phenomena and esophageal involvement, then presence of anti-Rho52, high titer rheumatoid factor positivity, higher LDH and ESR levels, and elevated ESR and CRP levels. So next, coming to the patterns of ILD, the most common pattern is NSIP pattern, seen in nearly half of the patients, followed by UIP in 10 to 15% of the patients. The characteristic pattern is the lymphocytic interstitial pneumonia, that is LIP, seen in about only 5 to 10% of the patients, and organizing pneumonia in another 5 to 10%, with a combination of any of these 4 patterns is seen in about 40% of the patients. Other rare etiologies which have been found in patients who are presented with symptoms suggestive of interstitial lung disease are pulmonary amyloidosis and lymphomas, and rarely pulmonary Langerhans cell histopathology. So coming to the patterns of ILD, I'll not be going into the details of the radiological pattern and the radiological findings of these patterns, but Sjogren's UIP patients are usually older and more commonly females, and they are associated with interstitial inflammation, lymphoid follicles with germinal centers on histopathology. And as far as NSIP is pattern, the outcomes can be unpredictable. They can be categorized into 4 different groups. The patient who might be having a reversible ILD with risk of progression. The patients can have stable with residual disease. The patients can progress and be irreversible with potential stabilization. And there would be an irreversible course without respite despite giving best immunosuppression. And regarding the LIP pattern, it is basically diffuse proliferation of the polyclonal lymphocytes and plasma cells within the interstitium of the lung, resulting in the formation of lymphoid follicles and germinal centers. They manifest as thickening of the bronchovascular bundles with presence of nodules and GGOs and interlobular septal thickening. And the characteristic finding is the presence of thin wall cysts in about 68 to 82% of the patient. And among all the patterns, LIP is one pattern which has shown good response to use of corticosteroids and other immunosuppressants. So the next question is, how do we diagnose Sjogren syndrome? I think for most of the audience who are present here and are practicing pulmonologists, this is one of the most important thing because not all patients who are having anti-Rho positivity or anti-La positivity should be labeled as Sjogren's. So as was being discussed in the previous sessions as well, the clinical context is much more important than the antibody positivity. So we should be thinking of a patient having Sjogren syndrome if there is a compatible clinical feature, that is presence of either ocular or oral dryness, or if there is a presence of typical extraglandular manifestation of Sjogren's. So among the extraglandular manifestation, I think the typical manifestation would include either presence of distal RTA or the presence of hyperglobulinic purpura resulting in palpable purpura over the lower limbs. So rest of the other clinical features can be overlapping with other connective tissue disorders, especially lupus. So not all patients who are anti-Rho positive, we should be labeling them as Sjogren's. And among the laboratory features, anti-Rho, anti-La positivity can be demonstrated, and on minor salivary gland biopsy, a focus score of more than 1 is indicator of Sjogren's. So I'll be showing in detail about these findings of minor salivary gland in the subsequent slide. And it is also important to rule out other causes which can cause Zika symptoms in these patients. So what are the symptoms of ocular and oral dryness? The most common question that we ask is whether the patient is feeling any sensation of dryness in either the eyes or the mouth. But many a times patients do say that they don't feel any dryness, but they do have equivalent symptoms in the form of irritation in the eyes or itchy sensation in the eyes or foreign body sensation within the eyes, or not able to tolerate bright lights, or there is a blurry vision which gets corrected after use of various lubricant eye drops. So all of these can be equated to the presence of ocular dryness. And similarly for oral dryness, the patient can complain of more feeling of dryness in the mouth. Apart from that, they can also complain that they need to drink a lot of liquids while swallowing dry foods, especially like biscuits or other bakery products. And also they have a tendency to frequently sip or drink water, even without the sensation of mouth dryness. And they can have burning sensation in the mouth, especially if they have concomitant candidiasis, and presence of atypical caries, that is caries involving the gum line or the incisor teeth, is an point which would indicate that the patient might be suffering from oral dryness. So regarding the laboratory testing, ANA can be tested. Then the most characteristic antibody is the anti-Rho positivity. However, you need to remember that anti-Rho is not positive in all the patients. A significant proportion of patients, almost like 20-25% of primary Sjogren's, can have anti-Rho negativity. Complements can be low in 1/3 to half of the patients, and rheumatoid factor positivity can be seen in about 40 to 60% of these patients. So coming to the testing for ocular sicca, the common test that we do in our clinics is the Shermer's test. It's a very simple test where we place a filter paper in the lower palpebral conjunctiva and without anesthesia, and after 5 minutes we measure the length of the filter paper which has got wet in. So any measurement which is less than 5 millimeters is taken as abnormal. And the other advanced test would be the tear breakup time, where we will need the help of ophthalmologist to perform this test. So tear breakup time of anything less than 10 seconds is abnormal, and it usually indicates that there is a problem in the meibomian gland's function in this patient. Then ocular staining can be done to see for the presence of devitalized tissue. So rose Bengal dye, fluorescein dye, and lissamine green are the common dyes that are being used. These are the representative images. There are certain scorings based on the patterns of staining. The commonly used is the Van Bijleveld scoring, a score of more than 5. 4 is indicative of dry eyes. And recently, the Sicca scoring has also been proposed, where the score of more than 5 is taken as positive. So then, there are various objective tests to demonstrate oral Sicca. One is the salilometry, where it can be an unstimulated whole salivary flow or a stimulated whole salivary flow. This is not commonly done in most of the centers because it is these investigations are cumbersome. However, the common investigation that we commonly do is the salivary scintigraphy, which is a nuclear medicine scan, where we evaluate the functional capacity of the parotids and the submandibular gland, both with respect to their uptake of the radionucleotide dye and also excretion characteristics from these glands. And minor salivary gland biopsy, it's a common practice that we do in patients, not in all patients, but in those patients where we are not very sure about the diagnosis, or especially in those patients who are anti-Rho negative. So for the diagnosis, minor salivary gland biopsy would be very helpful. So what we see in the minor salivary gland is the focus score, which indicates that there is aggregates of more than 50 mononuclear cells in the periductal or perivascular location. There is a specific formula to calculate the focus score, and this focus score would be representative of 4 millimeter square area. And these are some of the representative images of the foci that we demonstrate in the minor salivary gland biopsy. So this is one of the focus, which is very dense infiltrate of mononuclear cells with around the ducts of the salivary gland. So this is in the higher magnification, where we can see that there is a lot of lymphocytic infiltrates in the periductal areas. With relative preservation, like normal SNI, these light pale stained areas are the SNI of the salivary glands, which are relatively spared. So in 2017, the ACR and ULR have proposed the classification criteria. So there is an essential criteria, that is the patient should have at least one symptom of ocular or oral dryness or systemic manifestation, which is suggestive of primary Sjogren's. And then we can apply this scoring in those patients, and any score which is more than 4 is indicative of primary Sjogren's. So there are some exclusion criteria to apply this score. Those include the active hepatitis C infection, history of receiving radiotherapy to the cervical spine, presence of sarcoidosis or graft-versus-host disease, IgG4 disease, or the use of anticholinergic drugs when the patient is being assessed. So the next question is, when do you screen for ILD in these patients? There can be 2 different scenarios. The first scenario is what we as a rheumatologist commonly come across. We screen for ILD in a patient who is already known to have Sjogren's syndrome. So in those patients, we mainly depend on the presence of respiratory symptoms, that is exertional dyspnea or non-productive cough, and on examination presence of crackles, or streaks. And based if any of these symptoms or signs are present, then we can go ahead with CT chest to confirm the presence of ILD and pulmonary function test further to know the to grade the severity of the lung involvement. And also bronchoscopy with ball may be needed in some patients where the diagnosis is not clear. So the other scenario would be most commonly be seen by the pulmonologist, where the patient has the known ILD, and then you suspect presence of Sjogren's in there as a cause for this ILD. So in these patients, you need to be more vigilant about the presence of various extra respiratory symptoms, especially the presence of keratoconjunctivitis sicca or the presence of parotidal or other features of systemic involvement like arthritis, any renal involvement, presence of features of distal RPA in the form of hypokalemia or presence of proteinuria indicating renal involvement. So in those patients, you need to perform the urine analysis, you need to perform the minor salivary gland biopsy if required, and get an autoantibody profile, especially the testing for anti-Ro antibodies. And obviously, we need to exclude other connective tissue disorders, as I've already highlighted. Many of the clinical features of Sjogren's can overlap with other CTDs, especially lupus. And we can confirm the presence of dry eyes or dry mouth. Both are, first thing is to ask the patient whether the patient subjectively feels there is any dryness, and also objectively testing for the presence of exocrine gland insufficiency by the various tests they have already shown in the last few slides. So in 2021, the Sjogren's Foundation have published an algorithm on how to evaluate for pulmonary symptoms, what all tests to be done in patients with Sjogren's syndrome. As you can see from this flowchart, the first thing is whether the patient has pulmonary symptoms or the patient does not have pulmonary symptoms. So patients without pulmonary symptoms can also have asymptomatic ILD. So the baseline investigations would include baseline chest X-ray and also thorough clinical examination. And if there is any abnormality in X-ray or the clinical examination or the baseline PFTs, then we can go ahead with HRCT of the chest to demonstrate the abnormality. And in patients who are having pulmonary symptoms, the next step would be to perform an HRCT and also pulmonary function test. If both of these are normal, then we should evaluate for other causes, especially cardiac conditions or some other airway diseases, small airway diseases like bronchiolitis or bronchiectasis. And if these both HRCT and pulmonary function tests are indicative of ILD, then we should manage accordingly, according to the abnormality and the severity. So this is another flowchart given by the Sjogren's Foundation. So in patients in whom we have diagnosed Sjogren's ILD, how do we evaluate them initially? So first is to get a functional capacity by performing the pulmonary function test, then pulse oximetry at rest and then with activity, then reviewing the HRCT if there is any need for, if there is any doubt in the diagnosis. And the first step is to closely monitor PFTs every 3 to 6 months, especially if the patient is asymptomatic or mildly symptomatic during the first 1 to 2 years. And we can consider getting an echocardiography if we are suspecting pulmonary hypertension. So in patients who are having no symptoms or very minimal symptoms with PFTs showing very minimal abnormality in the pulmonary functions, then we can serially observe them every 3 to 6 months with clinical examination and pulmonary function test. However, in patients who are symptomatic with moderate to severe abnormality in PFT and HRCT, the first line therapy is oral glucocorticoids, moderate dose being 0.5 to 1 mg per kg. And the second line, the first line immunosuppressant as a steroid sparing drug would be MMF or azathioprine. So on follow-up, if the patient has a satisfactory response, then we can continue these drugs. Or if there is no response, then we can review the HRCT and further decide immunosuppression based on whether it is a progressive fibrotic ILD or not. So if there is a progressive fibrotic ILD, then there is a role to give antifibrotic drugs. And if there is a improvement, then we can continue. If there is no improvement, then we can reassess the diagnosis or consider alternative diagnosis and consider for palliative care and lung transplant. If there is a presence of inflammatory pattern, then we can consider give them rituximab or calcineurin inhibitors or cyclophosphamide. In patients who are having rapidly progressive or refractory ILD to the initial therapy, then these guidelines say that we can use high dose steroids, that is 1 mg per kg, or intravenous methylprednisolone. Then we can consider rituximab or cyclophosphamide, or consider lung transplant evaluation. So, however, I want to highlight here that all these recommendations are mainly based on the expert consensus rather than evidence-based, because there are not a lot of studies. There are no RCTs per se in Sjogren's ILD. And also most of the CTD-ILDs, RCTs on CTD-ILDs did not include patients with Sjogren's ILDs. Even though we are extrapolating this data on rituximab and cyclophosphamide and MMF from those studies to these patients. So in 2023, the American College of Rheumatology had just published the summary of the guidelines for CTD-ILDs. This is not specific for Sjogren's, but one of the subgroup is for Sjogren's. So as you can see from this diagram, the far right column is for Sjogren syndrome. So they have said that the first line ILD therapy is either MMF, azathioprine, or rituximab, and additional options would be cyclophosphamide if any of these three cannot be used, along with glucocorticoids, which can be given for a very short term of duration. And as you can see, all of these are conditional recommendations, as they don't have enough evidence to give a strong recommendation for any of the drugs. And in patients who are having progression of ILD despite first line of therapy or rapidly progressive ILD, again, they say we can use mycophenolate or rituximab, and nintedanib can be given in these patients, and cyclophosphamide. And they conditionally recommend against using long-term glucocorticoids in these patients. And we should plan for a renal transplant at the earliest time in this subset of patients. So there are very few studies which have demonstrated the use of various immunosuppressants in Sjogren's ILD. One is the earliest study is published in 1996, where 20 patients of primary Sjogren's ILD have been studied over a period of time. And among these 20, only 11 had received azathioprine. So as you can see from this graph, patients who had received azathioprine, there is an improvement in the FVC on follow-up. Compared to those patients who did not receive azathioprine, there is a fall in the FVC. So then again in 2020, there is a retrospective cohort analysis where only 14 patients were included for analysis. 7 of them received azathioprine and 7 of them received MMF. And in this small subset of patients, a small group of patients, as you can see, there is a significant improvement in the FVC with MMF, and this improvement was not so marked in patients who had received azathioprine. And regarding the use of rituximab, this is one data analysis from the autoimmune and the rituximab registry, where they have analyzed 78 patients of primary Sjogren's who had received rituximab for various systemic manifestations. However, among these 78, only 9 patients had pulmonary involvement as an indication for receiving rituximab. So among these 9 patients, only 7 patients had improvement in the symptoms, which comes out to be around 78%. So this is the only data on use of rituximab in Sjogren's associated ILD. So the next is the progression. Progression of ILD is seen in about 1/3 of the patients, and the risk factors for progression is highly LDL.
Shankar?
Yes, sir.
Can you please conclude in the next 2 minutes or so?
Okay. So
Sorry
I'll
to
just go to
intervene.
the last
Yeah,
slide.
yeah.
Yeah.
Thank you.
So this is one of the graph where you can see that UIP had a worse prognosis compared to the other patterns of ILD. So I'll be skipping this slide. So to conclude, prevalence of ILD is about 4 to 16%, and NSIP is the most common pattern. Not all patients with Sjogren's will have Zika symptoms at onset, so high index of suspicion is needed. Treatment recommendations are based mainly on observational studies and on expert opinion. And as per these recommendations, corticosteroids are the mainstay. In moderate to severe disease, MMF or azathioprine can be used. And in refractory or rapidly progressive disease, rituximab or cyclophosphamide should be considered upfront. So thank you.
Thank you so much, Shankar. As I said, such few people working on Sjogren's ILD, and now the data is really growing. And now we welcome Dr. Nishan Gupta, who joins us from Cincinnati, Ohio. Shankar will take up the questions later, maybe.
Okay.
Please stay back if you can, or I'll ask. Dr. Nishant, are you there?
Yeah, hi, Sajal.
Yeah, Dr. Nishant, if you have commitment, because it's early morning there, I think, if we can take about 10 minutes for the ensuing discussion for IPAF and Sjogren's, and I would like to have your views also on the questions that we have, as you were part of the committee of consensus committee of experts on Sjogren's ILD, one of the slides that Shankar showed. So if you have time, we can take up the questions first, then your lecture, or if you don't have, then we can do your lecture and take up the questions later.
No, either way is okay, Sajal. You don't need to change your plans for my time is flexible.
No, we are running late. We are encroaching on your time. So yeah. So okay. So we'll take up the questions and maybe involve you also in some of them if you want to comment, because Sjogren's especially has a cystic lung disease component to it. So we had a talk on IPAF, interstitial pneumonia, on autoimmune features also just before the current talk. So there'll be a few questions on that also. So Shankar, are you there?
Yes, sir. Yes, sir. Yeah.
Shankar, we have a question from Dr. Kajal Arora that if there is RTA, that is renal tubular acidosis-like presentation, and we do not have much of a clinical symptom like Zika syndrome, which suggests Sjogren's, but there is Rho positivity. So what do you do in that case? It's a very specific question, but we'll have some insights.
Actually, this is a very specific, but this is one of the most common scenarios that we encounter in emergency. So many a times the patients, especially those patients who are having distal RTA as a sole manifestation, they usually land up in emergencies with hypokalemic paralysis. So they don't, at least in our experience, we haven't seen much of Zika symptoms as their clinical presentation. Most of the patients who are having distal RTA don't have Zika symptoms at the time of their presentation. However, during the course of the illness, almost all the patients do develop Zika at a later point of time. So these patients we usually manage in lines of Sjogren's syndrome, even though there is no proven data to use immunosuppression in distal RTA. So we are also not using in most of our patients. We only give symptomatic therapy to improve the acidosis and correct the potassium values.
So Shankar, we had an IPAF talk, and I believe Adhar is with us. So in IPAF, when we talk of IPAF, if we have NSIP with, say, Rho positivity, we might call it IPAF and not say a CTD. But now you have RTA with Rho positivity, and you say that it's almost like Sjogren's. So
yes, sir. So at that moment, even I think IPAF also will evolve over a period of time. So patients whom we are labeling IPAF, right?
Is it kidney disease with autoimmune features? What do you call it? Because
yes. I think both the situations are similar. So at that moment, we might sometimes Rho may be negative in these patients. So many a times we need to follow up these patients to see if they develop any other symptoms which are suggestive of Sjogren's. So I think the same thing holds true for IPAF also. Today, whom we are labeling as IPF might be labeled as Sjogren's ILD or scleroderma ILD on future follow-up. So the same thing
Adhar,
holds true for.
Adhar is there. So Adhar, I'll ask you a question. IPAF is a research statement criteria which was put up about 8 years back. And we have very specific criteria which need to be fulfilled before calling an ILD as IPAF. But we commonly see rheumatologists writing a diagnosis of undifferentiated connective tissue disorder, and that does not need to follow those IPAF criteria. right? So now if a patient who has been diagnosed with a UCTD, that is undifferentiated CTD, and now has an ILD, so where do you put it? Because we believe that ICTD, UCTD, ILD, and IPAF are synonymous, but IPAF now has been put with a specific criteria, while UCTD remains a little not very well defined as IPAF is. So how do you view it? How do you differentiate between UCTD, ILD, and IPAF or not?
I think the problem lies more with the idea that this should have theoretically been a consensus statement by the ACR and the ATS. The concern would have been much better settled. So now what happens is if the patient comes first to the rheumatologist, he'll get labeled as a UCTD. And during that evaluation, once the ILD is found, he becomes a UCTD ILD. And the problem with that terminology is that you cannot plan any study on that. You cannot collect data on a UCTD ILD. Because UCTD is more like, for me, the UCTD of ILD is what IPAF is. So if you have an IAP and you do not have a diagnosis, don't think it's IPA. If you don't think it's idiopathic NSIP, that's what we do with UCTD. So you have a patient with some joint pains, some serological activity, but does not fulfill classification criteria for a definitive CTD. So for all practical purposes, a UCTD ILD or IPAF is one of the same thing. But the difference that IPAF actually makes it easier. There are no UCTD criteria.
So we'll have Nishant's view on this, don't Nishant? So how do you, in your practice, how often do you label patients with interstitial pneumonia with autoimmune features? Do you use it as a clinical diagnosis, or do you use this term UCTD, undifferentiated CTD-related ILD?
Yes, Sajal, I'm not sure that I will have a whole lot more than the current experts have already said. We tend to not use IPAF as a clinical term, just staying true to the statement that was put out. I should add that even though we use UCTD, I think all over the world rather loosely, if you go back to the paper that described this term UCTD-ILD, that was by Brent Kinder in 2007, in the Blue Journal, it actually had fairly specific criteria for it. And the problem with those criteria was that what some people felt was that they were a bit too many non-specific criteria. So as others gave their criteria, then they started giving a different name to it. So there was a lung dominant autoimmune flavor or autoimmune dominant lung flavor. I can't remember the names now, but there were like 2 or 3 other such names that came out. And every group that came up with this name would be preferentially using their name, which prompted ATS and ERS to form this joint task force, and they solved this problem by creating a 4th name. That was a little bit tongue-in-cheek, but anyway, all I'm trying to say is that, yeah, we use UCTD in our clinic more than IPAF, but that's we don't also necessarily stay true to the criteria that were put forth for UCTD.
Yeah. Shankar, just give your bit about how differently do you treat Sjogren's ILD in real practice as compared to, say, systemic sclerosis, RAILD, or myositis ILD? How much of it is different? And also just a comment on Rho positive ILD as such, whether it's Rho 52, whether it's Rho 60, and whether it affects your management when it is not Sjogren's, it is not clinically Sjogren's, you just get referred because I find a row in my practice and I send the patient to you. And just a bit about the role of salivary scintigraphy, how specific it is. Does it help to pick up Sjogren's even in the absence of clinical symptoms? So 3 questions.
So coming to your first question, sir, regarding how differently I treat, I don't think we treat it differently from scleroderma ILD. So whatever evidence we have is from scleroderma ILD, the SLS1 and the 2 studies. So even for Sjogren's ILD, we don't have a lot of patients with Sjogren's ILD in our clinic. I think I remember hardly 5 or 6 patients of Sjogren's ILD who are under my follow-up. So 2 of them are on MMF and the other patients are on cyclophosphamide. So this is how we treat scleroderma ILD as well. whether it is MMF or cyclophosphamide, mainly depending on the patient preference and also depending on the severity. So I think at least I follow the same rules which I follow for scleroderma ILD in managing patients with Sjogren's ILD.
Okay, just wait
and
a
also
bit.
the data is also not.
We'll ask Dr. Nishan to come in. Dr. Nishan, do you see a lot of Sjogren's ILD in your practice? Cystic lung disease or even non-cystic like LIP or even non-LIP patterns? And how do you really approach their treatment?
Yeah, I think exactly as Shankar said, we do see a lot of Sjogren's ILD, and especially the LIP component, we get to see a lot because a lot of these patients get referred to us with a diagnosis of LAM. And aside from LAM, I think Sjogren's is the second most common cystic lung disease that at least we see in our clinic. And that's probably the disease that we find most difficult to distinguish between LAM and Sjogren's related LIP. I will also second the issue of the diagnostic uncertainties that arise in Sjogren's because Rho and La are not very sensitive or specific biomarkers. And there are a lot of times when you end up with everything that looks like Sjogren's, but you don't meet the classification criteria for Sjogren's. From a treatment standpoint, cystic lung disease from Sjogren's, for most patients, we generally don't have to treat as that doesn't progress very much. The ground glass nodular components treatment is the same as other connective tissue disease ILDs. Just personally, given the prominent role of B cells in the pathogenesis of Sjogren's, if someone is having a refractory disease or rapidly progressive disease, I'd probably have a lower threshold of switching to or adding rituximab in these patients than, say, the other CTD-ILDs, but that's a personal style thing rather than necessarily a very data-driven thing.
Thank you. So Shankar, just about a little bit about salivary scintigraphy.
Yes, salivary scintigraphy is actually is a very non-specific test to see the functions of the salivary gland. It is not specific for Sjogren's per se. Any condition which can cause salivary gland abnormality can result in an abnormal test. So to objectively document that there is some salivary gland abnormality in patients who are coming, we do get the salivary scintigraphy. The other issue with salivary scintigraphy is that it is not available in most of the centers. So that is again a problem in to say that to document salivary gland abnormality, we need to do a salivary. We need not do a salivary scintigraphy in all the patients. So it's the changes are not very non-specific. So even use of anticholinergics can result in problems in the uptake of these glands. So it cannot be taken as the sole criteria to diagnose as well.
Okay, so we end this session now, and we'll have the last but not the least. It is a very special session from a very special person, Dr. Nishan Gupta, who is an international expert on cystic lung disease, and he has work in a lot of these disease entities. He also works a lot in other ILDs too. So don't go by the modest CV that he has sent to me. So it is not modest at all. He's the Lamb Foundation Professor for Lamb Research. He's the Director, Interstitial and Rare Lung Disease Program at the University of Cincinnati, Ohio, United States. And he has umpteen number of publications. So over to Dr. Nishan. I think I'll stop sharing my slide and then you can start sharing yours. So we are going to listen to him on approach to cystic lung disease.
Thanks, Sajal. Let me figure out the screen sharing here in a second. I should know this 3 years into COVID by now. Let me know if you can see this.
I can see the slides. And can you move to the next slide so that we can just check whether it's working well or not? Yeah, it's working. So you can go back.
Yep. No, great. Once again, thank you very much for asking me to present here. This is absolutely my pleasure. I think I was allotted 30 minutes. I'll try to finish in that time frame. I'm happy to take questions in between, afterwards, whatever helps the group is all okay with me. So, let's get to cystic lung diseases. So cystic lung diseases are a family of diseases with very different and unique pathophysiologies underlying them, but they all share a common phenotype in that they have thin-walled cysts as a radiological phenotypic manifestation. And a few years ago, we had proposed this pathophysiology-based classification of the cystic lung diseases. So some entities here, they stand alone. So you have your infectious causes, or you have your congenital causes, or some things that can mimic cystic lung diseases. But then the more common cystic lung diseases they all sometimes have overlapping categories. So for example, you can have neoplasms, and they can be frank neoplasms such as metastatic sarcomas or lymphoma, or they can be low-grade monogenic neoplasms. And we'll talk about a couple of them in the form of LAM and Langerhans cell histiocytosis. You could have smoking-related cystic lung disease. Again, a bit of an overlap here between Langerhans cell, which is a neoplasm, a smoking-related disease, as well as a genetic disease. And we'll talk about why that is the case when we get to the PLCH section. Or you can have purely genetic things like Birt-Hogg-Dubé, or lymphoproliferative disorders such as follicular bronchiolitis or lymphoid interstitial pneumonia. And even though they are mentioned separately, really they are a continuum of a single entity, so I'll treat them as one entity. And the reason these four diseases, LAM, Birt-Hogg-Dubé, LAM, and PLCH, are highlighted in red on this slide is that these are the four most common cystic lung diseases that you will encounter in your clinic. And so I'm gonna, the next few minutes, just focus my talk on a description of each one of these four entities. Okay, let's begin with lymphangioliomyomatosis, and I'll refer to this as LAM throughout the rest of this talk. So LAM is a rare lung disease. It's seen almost exclusively in women, most commonly seen in the reproductive age groups, although the age of diagnosis can vary from teenagers to octogenarians. The average age at diagnosis probably somewhere in the mid-30s. And if you leave it unchecked, it causes progressive lung destruction over time to where 10 years or so following the onset of symptoms, about half the patients are short of breath while walking on a flat surface, and about 1/4 are on oxygen. And one of the things that led to a remarkable pace of progress in LAM was the identification of the driver gene mutation. So LAM is caused by mutations in the tuberous sclerosis complex genes. And as such, it can be seen in association with the tuberous sclerosis complex, where we refer to it as TSC LAM, or it can occur sporadically in women who do not have TSC, where we refer to it as sporadic LAM. Now, there are two known TSC genes, TSC1 and TSC2. And in patients with TSC LAM, both gene mutations can lead to LAM, although it is clear based on work done by others and by us that patients with TSC2 mutations tend to have more severe cases of LAM as compared to patients with TSC1 mutations. In the case of sporadic LAM, only TSC2 mutations have been described to be associated with LAM. Regardless, what happens at a very simplistic level is that mutations in the TSC genes lead to constitutive mTORC1 pathway activation, which subsequently drives clonal neoplastic proliferation of smooth muscle-like cells. That the origin of those cells actually is still not fully understood. We believe they arise from the uterus. There is some recent evidence from Cincinnati that suggests so, but that's the jury is still out on it. But subsequently, these cells gain access to the blood and lymphatics. They invade the lung and cause progressive cystic tissue remodeling. And these are the various manifestations of LAM that you can see on chest imaging. So on the top left-hand panel, you have a patient with a relatively mild cystic lung disease, but I like the CT scan because you can clearly see the cyst features of LAM. So these are smooth, thin-walled, very uniform, bilateral, diffuse, no geographic or axial predilection cysts with a fairly normal-looking intervening lung parenchyma. In the middle panel, you have someone with more advanced disease, and you can see almost the entire parenchyma has been replaced by cysts. Now, in patients with LAM, you can also see these benign tumors, typically in the kidneys, called angiomyolipomas. These tumors are seen in about 1/3 of the patients with sporadic LAM and about 80 to 90% of the patients with TSC LAM. So this image is from one of my patients with TSC LAM, and you can see the entire kidney is replaced by this fatty tumor. And she also happens to have a couple of these tumors in her liver. Another complication in LAM is that as these LAM cells are traversing up the lymphatic channels, you can sometimes have dilated or obstructed or blocked lymphatics with lymphatic fluid collections, or even lymphatic fluid seeping out in other cavities. So here's a MRI showing a dilated lymphatic system in a patient. Here's a lymphangioma with a collection of lymphatic fluid. This is a very rare complication of LAM. Here, this chylous fluid is regurgitating into the lung parenchyma, leading to this ground glass presentation in addition to the typical cystic lung disease. This is a more common lymphatic presentation where you have a chylothorax. And last but not the least, these women have a very high propensity to develop spontaneous pneumothorax, as seen on this CT scan. Yeah. Now, when it comes to diagnosis, you need to have characteristic CT of the chest. Plus, if you have any one of the following features, you could establish a clinical diagnosis of LAM without needing a biopsy. So first is an elevated serum vascular endothelial growth factor D, or VEGF-D, greater than 800 picograms per mil. The next is if the patient has known TSC, or if they have known renal AMLs, chylous effusions, or lymphangioliomyomas. A bit about VEGF-D is that it is a very specific test, but it is not necessarily a very sensitive test. And it was that threshold was chosen carefully because our main idea was to avoid the need for a biopsy. So the paradigm being, if you have high VEGF-D, you can be sure this is LAM, you do not need a biopsy. But a low VEGF-D does not exclude the possibility of LAM, as about 1/3 of the women with low VEGF-D might still have LAM. Other point of note here is that we often see in practice where a VEGF level is measured, which generally translates to VEGF-A rather than VEGF-D. And there is no known utility of a VEGF-A or VEGF measurement in the diagnosis of LAM. And about 2/3 of the patients with LAM we can diagnose based on any one of the above features, to where biopsy is needed in a relatively small proportion of patients now. Okay, a bit about natural history. So this is data we analyzed from an existing LAM registry from the late 90s, comprising about 250 women, and we linked them to death and transplant outcomes over a long time frame. The bottom line here is that the FEV1 decline in LAM, the average rate is about 90 mils per year, which is about 3 to 4 times faster than normal healthy control. Also, within this is that premenopausal women decline faster than postmenopausal women. That has now been shown across 3 or 4 different studies. And the average survival in women with LAM is upwards of 20 years. And this is derived from a time before mTOR inhibitors as treatment was available. And that's important because a lot of times patients with LAM get these dire prognostic estimates, which are just not true in these days. And we have currently in the process of making this LAM prediction model as a decision-making aid. We're using the data from the registry we just talked about, along with a cohort from the UK. Simple demographic measures like age at diagnosis, baseline lung function test, menopausal status can allow us to predict what the FEV1 would be in the next 12 months. What would be the rate of decline? What is the probability that a patient would decline at a given rate, etc. And the idea being that this is something the patients and the clinicians can use at point of care to make treatment decisions. Coming to treatment, if we go back to how we talked about the key pathway in the pathogenesis of LAM being an activated mTORC1 signaling, we have a very effective mTORC1 inhibitor in the form of sirolimus that, as you know, is commonly used as an immunosuppressant in patients with kidney transplant, etc. But in LAM, we do not use it for its immunosuppressive properties. We use it because it is a very unique and targeted mTORC1 inhibitor. And the phase 3 trial that showed the efficacy of sirolimus in LAM was the MILES trial. And the way this trial was designed is that there are about 90 women with LAM. They are randomized 1:1 to either be on sirolimus or placebo for the first year. And in the next 12 months, both groups are observed off of treatment. And so on the left-hand side of this graph, if you look at the open circles, this is the placebo group. They have continued lung function decline at about 12 mils per month. And the treatment group on sirolimus has complete stabilization of lung function. And when the treatment was held in the next year, both groups started to decline. And so what we learned from here is that sirolimus is a very effective stabilizing agent for LAM. But what we also learned is that the effect is not remission inducing. The effect is disease suppressing. So to gain durable control, these patients have to be on sirolimus for a long time frame. And based on this data, sirolimus was approved by the US FDA in 2015 and now approved in 40 plus other countries across the world. Another key feature for MILES here was that we took patients with moderate to severe disease activity, so their lung function had to be 70% or less. We are currently conducting a trial which is finished recruitment called MILD, where we are taking patients with preserved lung function and randomizing to low-dose sirolimus versus placebo to see if early treatment makes sense. This is just a slide showing some real-world efficacy of sirolimus. So this is from a current registry in LAM that we have across 20 centers in the US, where on the black bar here are patients who are not treated with sirolimus. The red bar are patients who are on sirolimus. And you can clearly see that patients not on sirolimus are declining at about 80 mils per year, and patients on sirolimus have stable lung function. The reason I like to show this slide now is that, this is in a world where, in the real world, if we think someone has severe disease, progressive disease, or meet the criteria for treatment, right, those patients would be on treatment, while the patients who we generally think are stable, are at low risk of progression, etc., we might elect to wait. But despite that bias, you're seeing a clear treatment benefit of sirolimus. And not shown on this slide deck, at least I don't think so, is that there is also recent data from our colleagues in China showing that patients with LAM on sirolimus have a survival benefit as well. Other complications of LAM, we talked a bit about how in LAM you can see a lot of chylous effusions. Sirolimus is a very well-working agent when it comes to targeting chylous effusions, to where it is recommended that sirolimus be the first-line treatment rather than invasive options. Worth noting that sometimes it can take a few months for sirolimus to work from a lymphatic complication standpoint, but it almost always does work. And this is work that one of our trainees published last year, Ella Cortines, where she looked at whether the pneumothorax counseling in LAM should be a little more nuanced rather than everybody being given the same risk. And what she found was that the risk of a pneumothorax substantially decreases after about the age of 50 years or after menopause. But what was most striking to us in this analysis was that the use of sirolimus was associated with a significantly reduced subsequent risk of pneumothorax as compared to patients who are not on sirolimus. And that's something that might by itself become an independent indication to treat, although that's an evolving field. Okay. This is a concept that we are currently working on, where we have about a third of the patients with LAM who have cyclical variability in their symptoms. coinciding with the hormonal fluxes of the menstrual cycle. And what we find is that patients who have the cyclical variability tend to get diagnosed earlier and tend to be more symptomatic than patients who don't have menstrual cycle related variability. And these patients also, while they show overall response to sirolimus, their menstrual cycle related symptoms do not respond well to sirolimus. So we are currently enrolling this subset in a prospective analysis to understand if there is a different natural history for this subset. And if so, this might become the target for next trials looking at hormonal therapy in LAM. A customary COVID slide or two. So, this was an analysis we did across the LAM clinics internationally to identify patients with LAM and see if there was a difference, what their outcomes were from COVID, and also if there was a difference between patients who are on sirolimus versus not. So some key takeaways here were that the overall mortality following COVID was about 1%, similar to the general population. And that despite the patients being on sirolimus having worse lung function, it really didn't lead to a difference in long-term outcomes from COVID. And the next question from a COVID standpoint we asked was whether there is a difference in response to vaccinations in patients who are on sirolimus versus not. And there certainly was a lot of angst both amongst patients and clinicians about the degree of protection you would get given the known potential immunosuppressant properties of sirolimus. And I think we've all seen how patients on CellCept, etc., don't really tend to mount as much of a response to vaccination. And this is work we did in conjunction with NHLBI, and the bottom line here is that the median anti-spike antibody level was actually similar in patients with LAM on sirolimus as compared to patients with LAM not on sirolimus. Okay, let's switch gears to away from LAM. Let's talk a bit about Birt-Hogg-Dubé syndrome. So Birt-Hogg-Dubé syndrome is an autosomal dominant disorder and is characterized by the triad of fibrofolliculomas, which are these hair follicle tumors, renal tumors, and curiously cysts in the lung. It's caused by a mutation in the folliculin gene, which ultimately results in a truncated folliculin protein, and that compromises its tumor suppressor properties. And there is recent evidence linking the mTORC1 pathway in the pathogenesis of BHD as well. So some similarities there between BHD and LAM. So quick slide about just the non-pulmonary findings in Birt-Hogg-Dubé. So first, this is a very close-up image of one of our patients with Birt-Hogg-Dubé, and you can see these whitish dome-shaped papules on the forehead of this patient, and they are commonly seen on the face, on the neck, upper torso. A good place to look for it is behind the ears. And also, this requires very careful examination because sometimes they can be very subtle to where you or even the patient may not know that these exist on their face. Coming to renal tumors can be seen in about a third of the patients with Birt-Hogg-Dubé. It's a little bit of a late manifestation where the mean age at diagnosis is about 50 years. The key here is that they can be bilateral, multifocal, can have various underlying histologies, with the most common being hybrid oncocytic and chromophobe renal cell cancer. The good thing, however, is that for the most part, they generally follow an indolent course. And typically observation is recommended until the lesion reaches 3 centimeters in size, beyond which you recommend partial nephrectomy. Focusing on the lung aspect, so lung cysts in Birt-Hogg-Dubé can be seen in about 80% of the cases. Let's contrast it to what we talked about the cysts in LAM, as opposed to the uniform round cysts that are seen bilaterally with no geographic predilection. The cysts in Birt-Hogg-Dubé tend to be more oval. They are almost exclusively at the bases, and they tend to abut the pleura, especially the mediastinal pleura and the pulmonary vasculature. So these are CT scans from 4 or 5 different patients with Birt-Hogg-Dubé highlighting the various features here. You can see that they are all taken from right at the bottom of the lungs. and how these cysts are more oval, more abutting the pleura, more abutting the vessels, etc. How do you diagnose Birt-Hogg Dubé? You can diagnose really either based on skin biopsy showing fibrofolliculomas with characteristic CT scan or genetic tests showing follicular mutations. Worth pointing out that there are no pathonomic features on lung biopsy for Birt-Hogg Dubé, so a lung biopsy is not necessarily helpful. So if you're thinking that you have an unknown cause cystic lung disease that might be Birt-Hogg Dubé, I'd send the genetic test first before pursuing a biopsy. And from a management standpoint, really the major thing in Birt-Hogg Dubé is to institute a program for renal tumor screening. And we typically start screening after the age of 20 years. And if no lesion on the original scan, you could probably image every 3 years or so. And for patients with a known lesion, that frequency can be individualized based on the size and the features of the original lesion. MRI is considered the best modality of screening because ultrasound can miss small lesions and CT scan over a lifespan can be prohibitive from a radiation standpoint. And once again, nephron sparing surgery for tumors more than 3 centimeters in size. Okay. Let's talk a bit about Langerhans cell histiocytosis or PLCH. Again, a rare disease, unknown etiology, but characterized by the infiltration of pulmonary parenchyma by these specialized myeloid or dendritic cells that share morphological and surface receptor markers with Langerhans cell. Now, typically, this is a disease that's seen in association with cigarette smoking, to where upwards of 90% of these patients are current or former smokers. Worth also mentioning here that we don't often think about marijuana, but marijuana is also, at least in our experience, equally associated with the risk of Langerhans cell. The typical age of presentation somewhere in the 3rd to 5th decade. And coming to why I was putting Langerhans cell histiocytosis not only as a smoking-related disease, but why as a genetic or a neoplastic disease, is that over the past few years, we now know that there are mutations in the MAP kinase pathway that are present in majority of the patients with Langerhans cell histiocytosis. And here's a very simplified MAP kinase pathway where you have the RAS, the RAF, the MEK, and the universal activation of ERK. Now, mutations in this pathway along this entire chain from RAS to RAF to MEK have been described in patients with LCH. By far, the most common mutation is in one of the RAF genes called the BRAF V600E. But as I said, mutations both upstream and downstream of RAF have been described. But the end result is the same, that they all lead to activating phospho-ERK, which drives the subsequent neoplastic clonal proliferation. What's interesting is that these are the same mutations that are also seen in melanoma, in hairy cell leukemia, and papillary thyroid cancer, etc. And this is why we classify PLCH as an inflammatory myeloid neoplasm rather than just a cigarette smoking disease, to where in my mind the pathogenesis is that you have a patient who is susceptible because they harbor these MAP kinase pathway mutations in their dendritic cells. And when they start smoking cigarettes, that cigarette smoke acts as the second hit that then drives these cells to hone in away from the bone marrow into the pulmonary parenchyma. Coming to radiology of Langerhans cell histiocytosis, again, compare and contrast to now with both LAM and Birt-Hogg Dubé, is that where LAM cysts were uniform and everywhere, Birt-Hogg Dubé was right at the bottom, the cysts in Langerhans cell happen right at the top. And in addition to cysts, you can see nodules, cavities, or sometimes all three of them in the same patient. And from a cyst shape standpoint, the cysts in Langerhans cell can often be very weird or bizarre shaped rather than, say, the round or the elliptical shapes we talked about in the prior two entities. Another key feature is the costophrenic angle sparing and in general less of a disease at the bottom of the lung. So here you have an axial scan showing nodules and cysts. Here's a scan showing the typical bizarre shaped cysts. And here's a scan clearly showing costophrenic angle sparing in a coronal view in a patient with LCH. Okay. When it comes to management, smoking cessation is by far the most important step as far as management is concerned, which is, as I'm sure everybody knows, easier said than done. We also focus on marijuana in addition to cigarettes. There is a risk of pulmonary hypertension in PLCH, so we at least clinically inquire about it. There is no proven role of screening echocardiography in this circumstance, though. Even if patients stop smoking, we do still serially monitor PFTs because a third of the patients may still progress despite successful smoking cessation. Beyond that, there are no control trials to guide treatment. There have been some case reports and small case series showing efficacy of cladribine. There is also mounting evidence showing the efficacy of targeted treatment with BRAF and or MEK inhibitors. And so either one of these two are good options for progressive disease, but again, no good high quality evidence to guide which way to go first. Lastly, coming to lymphoid interstitial pneumonia or follicular bronchiolitis. And this is a clinico-pathological entity, and I consider them as basically along the same spectrum, similar to how you might consider RB and DIP. And in follicular bronchiolitis, you have more of a peribronchiolar involvement. In LIP, you start seeing this spill into the pulmonary parenchyma. And it's commonly associated with immune dysregulatory states, by far the most common of those being the Sjogren's disease. And other associated conditions can be HIV, CVID, EBV, etc. And again, coming to the radiological findings. So here you can see ground glass attenuation and nodules, but cystic changes are sometimes by themselves are seen in a lot of patients. And the cysts here tend to be distributed around the blood vessels. As opposed to LAM, there is often a lot of variability in size of these cysts, and they often have internal septations and internal structures. So here's a coronal view of a patient with LIP, and you can see how these are eccentric vessels at the end of the cysts. And you can see this just variability in cyst size and internal septation. So this is very typical of follicular bronchiolitis / LIP cysts. I think as we discussed in the question and answer session a little bit, there is no effective treatment for cystic change. For patients with LIP secondary to HIV, treatment with antiretroviral therapy can help. In general, the ground glass changes and the nodules are responsive to immune suppression. The effect of immune suppression on cystic change is a bit unclear. There's a relatively small, perhaps a 5% or less risk of a transformation to lymphoma. So we do periodically image these patients. What is the right interval? We don't know. I will anecdotally say that roughly about every 3 years or so is when we start thinking of doing a repeat CT scan. However, again, I have no high quality evidence to guide that interval. And if there are ground glass or nodular lesions that are increasing in size, we have a low threshold for biopsy. A common feature of all cystic lung diseases is the risk of spontaneous pneumothorax. And so the 3 diseases where it happens the most are LAM, Birt-Hogg-Dubé, and LCH. And you can see on this table, the median age at diagnosis is about somewhere in the 30s. And the prevalence varies. So in LAM, over half the women with LAM have a pneumothorax at least once in their lifetime. Birt-Hogg-Dubé, you see this wide variance, and that's likely driven by ascertainment bias. The 25% comes from a primarily urology clinic data. The 75% comes from a primarily pulmonary clinic data. The reality is probably somewhere in the middle of about 50%. And in PLCH, the prevalence is a little less. However, the common feature is that in all 3 diseases, there is a very high risk of recurrence. And this risk of recurrence can be cut in half by following pleurodesis. So we recommend that patients with underlying cystic lung disease who present with a pneumothorax, that they be offered pleurodesis early rather than waiting for recurrent events. A common myth is that pleurodesis can be a contraindication for future lung transplantation. That is not the case. and pleurodesis should not be withheld because of any future transplant considerations. And we showed a few years ago that if you do a screening chest CT to look for cystic lung diseases in patients who are presenting with what you may otherwise call as a primary spontaneous pneumothorax, is cost effective. I should add that a recent study from Europe has contradicted these findings, so take these with a grain of salt. And a common question that patients often ask us in the clinic is, can they safely travel on an airplane with underlying cystic lung disease? And it's a table summarizing the data in the 3 cystic lung diseases from others and from us. The bottom line here is that the risk of a lung collapse on an air travel with cystic lung disease is about 1%, so about 1 per 100 flights. So for most patients, we do not preclude air travel. All right, that's just coming to the end of my talk here is that once again, the critical review of the chest CT is probably the most important non-invasive method to diagnose cystic lung diseases. And again, you can see the smooth bilateral uniform thin-walled cysts in lamb, contrasting it to a basilar predominant elliptical pleura-hugging and vessel-hugging cysts in Burtag-Dubé, to the upper low predominant bizarre-shaped cysts in Langerhans cells, to a slightly lower low predominant variable size eccentric vessels and internal septation carrying cysts in lymphoid interstitial pneumonia. A bit of a plug-in for the Rare Lung Disease Clinic Network, which was started as an NIH-funded consortium where we have about 37 sites within the US and about 30 sites in the rest of the world, which can allow us to study a number of rare lung diseases that you otherwise can't study in silos. I'm certainly happy to talk more about this or see if people have otherwise interest in joining. And most importantly, just this is a lot of people put a lot of effort into the slides that I showed you. I'm not going to go through everybody in the interest of time. The right-hand side, some of our funding sources. And if you are more interested in cystic lung diseases, here's a little bit of a shameless promotion of a book we just published a year or so ago, if you're more interested. I'll stop here. Once again, thank you very much. Happy to take questions.
Thank you, Nishant. That was an excellent exposition on this topic, and it was very clear. I would like to ask a few questions, especially some of them may be repetitions of what you told us, but it is practically the problems that we face. So first, how often a CT is good enough to differentiate between the different cystic lung diseases in your practice? How often do you go beyond CT? Okay, you'll do it VEGF-D, you'll do a follicular. Suppose you don't have them. Just on the basis of CT, how certain you get it, and what percentage will you need more information?
Yeah, good question, Sajal. So a lot of times we can feel fairly comfortable that this is what we are likely looking at just based on CT alone. The crux there is that I typically would not feel comfortable starting someone on treatment based on CT alone. So if we are looking at someone who has enough of a cyst profusion or they are progressing rapidly to where I'm instituting starting therapy, that's the circumstance where I would like to go beyond just my radiological best guess to having some other feature of confirmation.
Yeah, can you hear me?
Hi, Sajal, I can hear you. You're frozen again, though. I'm happy to answer the questions that are in the Q&A if that works best for the group. Maybe I should just do that in the interest of time for everybody, because I think everyone has been at it since the morning and I'm just joining in. So the questions are on the Q&A here is, where in India is VEGF-T level done? That's a good question. There is no lab in India that is currently doing VEGF-T levels. Really the only place where a VEGF-T level currently is done in a CAP CLIA approved manner is the lab based in Cincinnati. Let me actually copy the link of the lab and see if I can put it in the chat here. If you require VEGF-T levels on a patient in India, you could send a sample at ambient temperature to the lab in Cincinnati. The lab will run the test at no charge to you or the patient, but you or the patient would need to figure out the shipping fee. If you give me a second, I'll post the link of the lab here. In general, that's on a bigger level. That is a good question. Is that we do need to try to identify ways where hopefully this can start happening in India, and you're not required to ship samples halfway across the world. That's a major area of need in lab. The next question on the chat is, do we require a biopsy for the diagnosis of LAM? So similar question to I think what Sajal had been asking. So, if we exhaust all non-invasive means to establish a diagnosis, in about 2/3 of the patients, we can establish that non-invasively. In the remaining third, we do a biopsy if a patient is progressing or we are thinking of starting therapy. Similar question, and is there a role for HMB45 in LAM? So HMB45 is a melanocytic marker, and that has role in the diagnostic purposes for LAM, but it is a IHC antibody staining, so it's only useful after you have a biopsy. So outside of a biopsy, HMB45 doesn't have a role in LAM. The next question, can LAM be ruled out if there is ground glass along with CIS? For the most part, yes. The one exception being, if you remember the one CT scan where there was ground glass in a patient who had chylous effusion, not effusion, but chylous fluid refluxing into the pulmonary parenchyma. So if something that looks like pulmonary edema in an otherwise cystic lung disease, that could be a rare LAM manifestation. In almost all those circumstances, though, they have a very high VEGF-T level. And someone is also writing about VEGF levels. I'll again reiterate, the VEGF level generally translates to VEGF-A level, and that VEGF or VEGF-A level doesn't have diagnostic specificity for LAM, and we need the VEGF-D levels for LAM. Sajal, hopefully you're on, but I think I answered everything on the list.
Hello, Dr. Nishant. I'm Dr. Abhishek. I'm a pulmonologist from NIMS Bhopal. I have one question which you might be able to answer, because I am struggling with this question for many years. Frequently, we see some tall, thin individuals who have kind of Marfanoid habitus, but not fitting exactly into Marfan syndrome. And they usually present with pneumothorax. They have few cysts which do not fit into any of the description which you have mentioned. So how do we proceed with this kind of individuals who do not fit into anything, but they usually present with pneumothorax and few cysts?
Yeah, no, good question. And can I, if you don't mind me asking a little bit of a follow-up question, are most of these patients you're referring to teenagers or very young adults, or they fall across the entire spectrum?
they fall across the entire spectrum. I've seen few patients in adolescents, few in 30s, and recently I had one nursing staff and one doctor from my hospital only presenting with pneumothorax.
Yeah,
And the age of 30 to 40.
Yeah, good question. So first, Marfan's by itself has an association with cystic lung disease. So if you have a known case of Marfan's, that would explain it. Some cases of cystic lung disease are seen in Ehlers-Danlos syndrome as well. And in general, if you think about anorexia, etc., they also can present with cystic lung diseases. The general idea being if you have an underlying connective tissue disease that let's say in a very layman term doesn't render the supporting parenchyma to be of the same strength, that can predispose you to a cystic dilation. So a lot of times we just sort of generally think that this is a variant of an underlying connective tissue disease that is predisposing these patients to an underlying cyst development. But you're right, often we don't reach a definitive diagnosis to put them in a bucket in this circumstance. And we approach the pneumothorax similarly in terms of early pleurodesis. But beyond that, we just tend to follow these patients serially. And thankfully, a lot of these patients don't tend to progress much from at least a pulmonary parenchyma destruction standpoint.
Nishant, so can you hear me now?
Yes.
It is Murphy's law. Things fail when you least want them to. The entire day was seamless, but when we had India's Wi-Fi network reputation to say, we faltered. So I would ask one more question. So what is your take on surgical, like how often do you require a surgical lung biopsy?
Yeah, good question. So, when we look at, if you look at the data for transbronchial lung biopsy in the diagnosis of LAM, there is about a 50% yield of just transbronchial lung biopsy in LAM. So in fact, when we were working on the LAM guidelines, from a biopsy standpoint, we had recommended that you perform a transbronchial biopsy first and then do a VATS biopsy. That evidence is weak, though, as you could imagine. And I will say that a lot of times different centers have different practices. Some centers would just go straight to VATS and not do a transbronchial biopsy. We, at least at our institution, we are very heavy in terms of cryobiopsies for almost all ILDs. And anecdotally, we have had really good performance of cryobiopsy. So for almost all of these patients, we are just doing cryobiopsies now.
So how safe is it in cystic lung disease? We do a lot of cryobiopsies at our center, but we are a bit hesitant when we see a lot of cysts because obviously the risk of pneumothorax is there, but how often do you see air leaks, persistent air leaks after the pneumothorax?
Yeah, a good question. Again, weak data, but in our experience, the risk of pneumothorax is not terribly different in these patients as it is in otherwise fibrotic lung disease patients. Which is why we tend to do it. You can also flip this around to say you have whatever risk of pneumothorax you might have with a cryobiopsy as opposed to a pneumothorax that you will have from a VATS biopsy anyway. And the risk of a persistent air leak is there with every biopsy, regardless of the mode of a biopsy. And I'm not sure that risk is any different from a VATS biopsy. In fact, we've had patients, a couple of patients have really problematic leaks after VATS-guided biopsies. And more often than not, that tends to happen when during the surgery, you tend to get more aggressive and start stapling and cutting down cysts, etc. So we tell thoracic surgeons whenever we get a chance is just simply do a biopsy and leave everything else alone to the extent possible. That also goes for pleurodesis.
A bit about PLCH. So what kind of treatment do you use usually for that, apart from smoking cessation? For example, chemotherapy, and also if there is a fibrotic phenotype, then is there any sense in using antifibrotics?
Yeah, so treatment of PLCH, I will first put a caveat that there are no controlled trials. And if you ask different people, you'll get a different answer. So for example, if you ask Abdulatif Tazi, who probably has the world's highest number of patients with PLCH in France. His first line therapy is cladribine, and he would go to MEK inhibitors or BRAF inhibitors next. In our practice, we tend to go to BRAF inhibitors or MEK inhibitors first, as opposed to cladribine. And that's likely driven by the bias in terms of where we feel like this is a very more targeted approach to where you're targeting directly the mutation that is driving the disease. But again, no controlled evidence for it. Fibrotic disease, antifibrotics, I have no idea. Typically PLCH scars are a very late manifestations. By that time, there is generally not even much active Langerhans cell in there. So you could argue that that thing is not going to progress much at that stage. And typically you could just follow serially. If they are progressing, I suppose you could try antifibrotics. We've never done it.
Talking of cryobiopsies again, going back to it. So how do you interpret some of the data which is not as good as surgical lung biopsy in such cases? For example, we had a cystic lung disease patient, we did a cryobiopsy, and we got follicular bronchiolitis in that particular biopsy. That is fine that follicular bronchiolitis and LIP lie in a spectrum. But then would you label it just on the basis of the tissue that you got on cryobiopsy that it is follicular bronchiolitis? Or it might still be labeled as LIP, putting other features into the mold?
Yeah, I think that depends on how confident clinically you are. If it otherwise fits the mold, and that you have a young woman with Zika with cysts that look like follicular bronchiolitis or LIP, and you got that on the biopsy, yeah, I will take that as a definitive answer. As the distinction between follicular bronchiolitis and LIP, frankly, we don't even try to make that distinction. In fact, I think most cysts are a manifestation of follicular bronchiolitis. I think LIP is really when you start to see the other manifestations. I think even the cysts in LIP tend to be because of follicular bronchiolitis. That's just my personal bias or belief on it.
Right. So I think most of these cystic lung diseases, ultimately the cysts are originating because of some kind of small airway obstruction taking place due to one or the other reason, right?
Not necessarily. That is the most commonly ascribed phenomena. That's probably because that's the most easily understood phenomena of the ball valve, where you have a small airway obstruction and you have ball valve phenomena, you have distal hyperinflation that can manifest as cysts. That is almost certainly the case in follicular bronchiolitis. That has been described in other forms of bronchiolitis, including respiratory bronchiolitis, etc. That may have some role in Langerhans cell histiocytosis, although that's probably more of a bronchiolar destruction itself, which is why you tend to have more of these bizarre cysts. The cysts in LAM are likely due to direct parenchymal destruction rather than ball valve effect from small airway involvement. And no one knows why cysts in Birt-Hogg-Dubé form, so I can't comment on it, but they likely are not representing ball valve phenomena in Birt-Hogg-Dubé either.
When you go for a follicular gene testing, there are a lot of mutations described and a lot of new mutations are being described. So do we mostly look for, like in clinical practice, in research, definitely you'll go for very extensive tests. But in clinical practice, do we just look for the well-described mutations, or we really go for all kinds of mutations and then ascribe pathogenicity to it? And that will require a lot of good bioinformatics. So in clinical practice, how do we go about it?
Yeah, not necessarily. So just answering from a research standpoint of a genotype-phenotype correlation, where you might wonder if certain mutations give you more of a risk of renal disease versus progressive lung disease, etc., etc. This hasn't really been shown to be true. So far, at least, there is relatively little in terms of a genotype-phenotype relationship to where a mutation in folliculin is a mutation in folliculin. Regarding the clinical testing, once you send the folliculin gene for sequencing, most companies would sequence the gene and will give you whatever mutation exists, to where you don't necessarily have to pick and choose here or necessarily need a bioinformatician. And that's sometimes that's relatively easily determined by the company doing the sequencing for you.
So that means that any exonic missense mutation will be taken as a pathogenic mutation.
Oh yeah, sorry. Let me. Yeah. Good question. Would you take? Yeah, I think you look at the fact whether it is going to lead to a truncating protein activity or not. And generally, if you have a cyst that pattern that looks like BHD and you identify mutation in folliculin, I think the odds are that you'll probably take it.
Okay, I think I'm up with my questions. Maybe I'll look at the question answer box from the audience. So I think. Okay, so a CT looking like lamb, but no other features of lamb, and the patient had some U1 RNP positivity. So how do you proceed? It's a very specific question, but may give insights.
Yeah, no, good question. And, first is that the presence of an autoantibody doesn't exclude LAM. And the presence of autoantibody may, however, clue you towards possible follicular bronchiolitis as the underlying cause. And again, that's why I said even before my talk began that LAM and LIP/follicular bronchiolitis are the entities that we get confused with the most. And at least in my view, are the most difficult to distinguish. It gets further complicated by the fact that about 5% of patients with LAM have positive autoantibodies. And we have had a couple of cases where you have features of both LAM and follicular bronchiolitis on the biopsy. And so right now, I think I'm just confusing whoever asked the question more rather than helping. But I think the answer here will be serial follow-up. And if this patient is progressing, I think you would need a biopsy to figure out which pathway you're going to go from a treatment standpoint.
Yeah, just a last question from my side. Maybe we'll look at the audience first. Any more audience questions? If you want to ask Nishan, just type it in quickly because we are then going to end the session. All right. Okay, so you have sent the link, right?
Yeah, I sent the link. Sajal, there was another question that I just saw. Let me just say one quick thing. Sorry for keeping everybody over. So there was a question. Someone asked a question about VATS versus perhaps a chest tube pleurodesis first in a patient with pneumothorax. And I should say that typically when I say pleurodesis, I was referring to a VATS-guided pleurodesis as our first line approach, the idea being that you could have the surgeon carefully address and scrape the entire pleura as opposed to a chest tube pleurodesis with the hopes that you will address the entire pleura.
Yeah. One more last question from my side, that even in the image that you showed in the end, the 4 cystic lung diseases, CTs, I really sometimes have difficulty in differentiating between Birt-Hogg-Dubé and LIP. Sometimes both have those kind of oval cysts and just a bit of maybe a perivascular presence or near the septae, but it's really sometimes confusing. Do you encounter such a problem, or it's always very crystal clear?
It's not. It's what we find it a lot easier is to say that, okay, this is not LAM, this is Birt-Hogg-Dubé, or this is not LCH, this is Birt-Hogg-Dubé. LIP, follicular bronchiolitis, is where things get a bit complicated. And you're absolutely right. You could confuse LIP with Birt-Hogg-Dubé in that they both tend to have a lower lobe predominance. They can both have eccentric vessels. They can both have internal septations. They can both be around the pleura. Typical differentiating features for me tend to be that if you see some things going more in the mid to upper lung zones, that tends to happen more with follicular bronchiolitis and LIP as opposed to Birt-Hogg-Dubé. In general, the cyst profusion tends to be a lot less in Birt-Hogg Bay. As follicular bronchiolitis and LIP, you tend to have a lot more cysts typically. Again, that's not a hard and fast rule, but these are a couple of features that you might use to help you sway one way or the other.
Right. Thank you so much, Nishant. We are really enriched with the kind of expert talk that we had on cystic lung disease. Otherwise, we have just listened to just each other in several conferences, just bits of knowledge, bits of acquired knowledge. But yeah, really honored to have this talk here.
It's absolutely my pleasure. I doubt that I added anything beyond what you already knew, but I'm happy to give the talk.
Right. Thank you so much. We have reached the end of today's business, and we'll be joining tomorrow again at about 9 a.m. for another 2 or 3 sessions, which will go on till tomorrow evening. We have Dr. Gitika Yadav. Nishant, if you want to carry on, you might. If you
I might, if you don't mind, because I'm working this weekend, so I need to leave.
Thank you. We kept you for so long. Thank you so much. Thank you so much.
No, my pleasure. Thank you. Bye.
We have Dr. Gitika. Dr. Gitika, are you there? I would love if you could address the audience for just a couple of minutes so that we can have some more on INPF. Dr. Gitika? Okay, she might not be there currently. So, okay, I will just say a few parting words. Thank you so much, all the participants. There were about more than 1,000 registrations, and all the time we had the presence of about 200 participants. And towards the end, it got reduced to 150. But then we had a very good participation, good questions coming in all the time. And the participation in the quiz was although a bit lower than what I expected. I don't know whether people were hesitant in putting out those questionnaires back to me. That was just a kind of a survey that I wanted to conduct, but it's fine. So I invite you tomorrow again, the same time, but we'll try to end the session much earlier for the Sunday evening. And we have very good sessions tomorrow with good speakers again. And another international speaker from the United States will be joining us for the Sarcoid talk. Thank you so much. Thank you so much. See you tomorrow. Thank you, panelists also. Dr. Marwa, Dr. Abhishek have been there till the end. Thank you so much.
It's been a wonderful session, Sajal. Thank you.
Thank you. Thank you, Vikas. Thank you.